Good morning, my dear friends. We welcome you all to the next Enrich meeting. I'm sure yesterday we have a very good academic discussion with evening with endocrinology. And let us start this session with lamp lighting. So may I now request Dr. Sundaraman sir, Dr. Murthy, and President Thomas Paul sir, Dr. Muthukumaran to come on stage for lamp lighting. Yeah, Dr. Usha, I agree, and Dr. Geeta Lakshmi, you are welcome, please. May I now request Dr. Muthukumaran Jayapal to give the welcome address. Over to Dr. Muthukumaran.
Good morning, respected seniors, friends, and colleagues. It's my pleasure to welcome you all for this hybrid Enrich meeting of 2021. And it's always our pride and prestige of the Endocrine Society of Tamil Nadu and Puducherry to organize this meet for postgraduates. So we have allotted this weekend of 1st of December every year for the society to give back something for its postgraduates in the longer run. We've been traditionally conducting it directly at Leela Palace for the last 3-4 years. And unfortunately, due to COVID, we have to move to a hybrid setup. Every year, the numbers have been going up, and we are currently looking at around 500 postgraduates all around the country to attend this meeting. We've got a full day's program, and the schedules have been posted, and it's online. I think we will have to swiftly move on to the program as we go along. I hope as postgraduates, you will enjoy this day and learn a lot from it. Thank you so much.
May I now request Dr. Thomas Paul, President of Endocrine Society of Tamil Nadu and Puducherry, for his comments.
Very good morning, everyone. And as Dr. Muthukumaran informed, that it is going to be an enriching program for all postgraduate trainees and physicians. Program has been carefully devised, and I welcome you all as delegates and faculty for this program which is starting now. It goes on till evening. Welcome you all.
We will start with our academic session, and first session we have a journal review where we have 3 interesting papers to be discussed by Dr. Asha, Dr. Geeta Lakshmi, and Dr. Varun. To chair this session, we have our eminent professors and teachers. May I now request Dr. Murthy sir to stage. Murthy sir is a senior most endocrinologist and who has been a backbone of endocrine in Tamil Nadu and I would say the whole India. And welcome you, sir. And other chairpersons, we have Dr. Krishna Sheshadri, who might be joining us virtually, and Dr. Sangamuni, who is the Dean of Virunur Medical College, and he was instrumental in starting the Department of Endocrine and DNB program in Madurai. And over to the chairpersons.
Murthy sir, good morning, sir.
Sir, good morning, sir. Sangamani, sir.
Good morning, sir.
Good morning, sir.
I am sorry, sir, I am joining virtually.
Nice you're here.
Yeah.
Good morning, friends, and welcome to this first session of Enrich 2021. On behalf of my co-chair, Dr. Krishna Seshadri and Dr. Sangamani, I welcome all of you to this very, very interesting program. The session one is journal review. We have 3 papers, followed by discussion following every paper because the topics are different. So we'll have about 8 to 10 minutes of presentation and probably 3 to 4 minutes of discussion. We move on. So by 9:45, we should finish. Since there is a very tight schedule packed for the day, request all the speakers to stick to time. The first paper is by Dr. Asha, who is the professor of endocrinology, CMC Vellore. And the topic is a critical review of the efficacy and safety of inclisiran. And just to give an introduction, the association between LDL and cardiovascular disease well established with an emphasis on lowering LDL levels. Statin therapy has been traditional treatment for LDL-C reduction, but they do not achieve target goals despite receiving maximal tolerated doses. So with this in mind, focus then went on to the PCSK9 inhibitor, the pathway, and the 2 inhibitors, evolocumab and alirocumab. But the problem was the cost and bi-weekly or monthly subcutaneous injections. Now a new pathway is being studied in which the synthetic small interfering RNA targets the PCSK9 gene expressed in hepatocytes to prevent PCSK9 production. This small interfering RNA, inclisiran sodium, significantly reduces hepatic production of PCSK9, causing a marked reduction in LDL-C levels. And it has to be given subcutaneously once every 6 months. So may I now welcome Dr. Asha to review the paper.
At the outset, I would like to thank the Enrich organizing committee for giving me an opportunity to present this very interesting paper. I would like to thank Dr. Murthy sir for the kind words of introduction and introducing the topic for discussion. I'll just share my slides. So this is a critical review of the efficacy and safety of inclisiran. So as already alluded to, LDL cholesterol has been significantly associated with major adverse cardiovascular events and to premature morbidity and mortality in patients with familial hypercholesterolemia. Statins are the first line treatment of choice, and we are all aware of the indications in patients with established CVD, elevated cholesterol levels, as well as those with risk factors. When it comes to the mechanism of action of these cholesterol lowering drugs, statins act primarily by inhibiting the enzyme HMG-CoA reductase. This reduces the synthesis of cholesterol, and thereby it reduces cholesterol total as well as LDL cholesterol. Ezetimibe, which is another molecule which has been around for a long time, it inhibits the intestinal absorption of cholesterol by acting on a pathway known as the Niemann-Pick C1-like-1 receptors on the epithelial cells of the intestine. The third pathway which is of interest for today is the PCSK9. So the normal function of PCSK9 is that it binds to the LDL receptor complex on the hepatocytes. Normally, what happens when LDL binds to its receptor is that the entire complex gets internalized into the lysosome, where the LDL is degraded while the receptor is recycled to the hepatocyte cell membrane to take up more LDL and thereby efficiently reduce the LDL cholesterol levels in the circulating blood. But in the presence of PCSK9, when the lysosome takes up the LDL receptor complex, in addition to degradation of LDL, it also degrades the LDL receptor, and hence it is not available for recycling of the receptor for LDL. Thereby, there is more circulating LDL, which causes the cardiovascular risk. The efficacy of statins has already proven in terms of the reduction in LDL cholesterol levels, as well as reduction in all-cause mortality by 10%, cardiovascular mortality by 20%. But the main problem with statin therapy is the adverse effects, mainly myalgias and myopathies, which are a common problem reported by patients who have been on this long term, and to a minor extent, hepatotoxicity, renal toxicity, and very rarely neurocognitive effects. And it has been reported that about 40 to 70% of patients initiated on statins discontinue treatment within 1 year of starting therapy. And this is a matter of concern when we are considering this as a therapy to prevent further cardiovascular events, especially as a secondary prevention. Hence, there is a need to look at other targets for LDL lowering, and here comes the role of PCSK9. So what is available right now is that we have monoclonal antibodies that bind to PCSK9 and causes degradation of PCSK9 in the extracellular space, and thereby they prevent its action on the LDL receptor, leading to more LDL receptor recycling. The other pathway which has been studied is the small interfering RNA, which prevents the translation of PCSK9 mRNA to the PCSK9 protein. So thereby the PCSK9 protein is not formed and more LDL receptor is recycled for LDL uptake. So the studies on evolocumab and alirocumab among patients whom it is used as monotherapy or with statin therapy have shown efficacy in terms of LDL lowering by about 50%, and it is also useful to a similar extent among statin intolerant patients. When it comes to patients with familial hypercholesterolemia, both homozygous as well as heterozygous, it has been shown to reduce LDL cholesterol more effectively among the heterozygous familial hypercholesterolemia to about 50 to 60%, while in homozygous state, the efficacy ranges from about 20 to 30%. Now coming to the mechanism of action of inclisiran, it is a modified double-stranded RNA which is attached to N-acetyl galactosamine in its tail, which helps it binds to the receptor on the hepatocytes. And once it is internalized, the two strands break up into a passenger strand and a guide strand. The guide strand has complementary sequences to the PCSK9 mRNA. This guide strand in turn recruits RNA-induced silencing complex, and this combination of the RISC and the guide strand further bind to PCSK9 mRNA and degrades it. Each RISC and antisense strand can degrade multiple copies of PCSK9 mRNA, and hence its action is prolonged. So once the PCSK9 mRNA is degraded, PCSK9 protein is not synthesized, and so there is more LDL receptor recycling onto the cell membrane, leading to more LDL uptake and also lowering of LDL cholesterol levels. The phase 2 trials, which looked at various doses of inclisiran, showed that 2 doses of 300 milligram reduced LDL cholesterol at best to about 58%. And subsequently, the phase 3 trials looked at the efficacy of inclisiran in various subgroup of patients. The Orion 9 studied it in patients with heterozygous familial hypercholesterolemia and found that inclisiran reduces LDL cholesterol levels by 40%. The Orion 10 and 11 recruited a large number of patients, about 3,000 patients with atherosclerotic cardiovascular disease or its risk equivalents, and found LDL cholesterol lowering by about 50% in patients treated with inclisiran. When they looked at a subgroup analysis, the effect of inclisiran did not differ irrespective of the age, race, gender, BMI, cardiovascular disease status, prior statin therapy, associated metabolic disorders, or renal dysfunction. In addition, inclisiran was found to lower the total cholesterol, ApoB, triglycerides, as well as lipoprotein A, which are detrimental to cardiovascular disease, and increases HDL by 7.5 to 10%. Coming to the adverse effects, though the pre-specified cardiovascular endpoints were a little lesser among the inclisiran patients, the risk ratios were not significant. The main adverse event reported was injection site reactions. Diabetes mellitus was not increased, and there was a mild increase in upper as well as lower respiratory symptoms and arthralgia. But adverse events leading to treatment discontinuation was only seen in 2.4 to 2.8%, which is an encouraging point to note. There are various trials of inclisiran which are currently ongoing, comparing inclisiran versus evolocumab, and also looking at inclisiran, the effect of inclisiran on the occurrence of major cardiovascular events as the endpoint in patients with homozygous familial hypercholesterolemia, and also extension studies of the previous Orion studies looking at the long-term effects of inclisiran. When it comes to cost, the PCSK9 monoclonal antibody evolocumab is currently available in India and costs about 96,000 rupees per year, but the injections have to be given every 2 weeks. Inclisiran has to be given as an initial dose, followed by a repeat dose at 3 months and subsequently every 6 months. Currently, it is not available in India. It is licensed only in the European Union, and converting the European cost to Indian rupees comes to about 2.7 lakh rupees for 2 doses per year. To conclude, inclisiran is the first small interfering RNA-based therapy for dyslipidemia. It has demonstrated very good efficacy as a LDL lowering agent, lowering LDL cholesterol by 50% in patients with cardiovascular disease as well as heterozygous familial hypercholesterolemia, and has a potential to be used both for primary and secondary prevention of CVD. The efficacy data on major cardiovascular events and long-term safety are awaited. Short-term safety profile seems to be good, and the benefits are that it can be given once in 6 months, and hence the patient compliance is likely to be good. Constraints are the high cost and non-availability in India at this point in time. Thank you.
Thank you very much, Dr. Asha, for that very elegant presentation. May I request my co-chair for their comments, views, and also
Thank you, sir. Madam, very good presentation and very good review, madam. Congratulations to you. You told almost 2.5% of the patient withdraw from the trial.
Yes.
Probably because of the side effect, I think. What side effect the patient had? But some of the literature says inclisiran can, like statin, can lead to the myalgia also. Myalgia is a side effect also.
Yes, sir. The initial dose escalation studies looked at myalgia as one of the important factor, and they found that myalgias were similar in the inclisiran versus placebo. So myalgia, though reported with inclisiran, the occurrence was similar to that of placebo in the phase 2 trials.
Madam, whether the intolerability or withdrawing from the trial for the 2%, major side effect is the myalgia or some other side effect was there. That is, and if there is a myalgia is a side effect, whether they have taken CPK like that, myositis like that.
Sir, myalgia was noted only in the phase 2 trials and to a very small extent in the phase 3 trials, as I mentioned. They did measure CPK, and some of them had minor CPK elevations, but not CPK elevation of more than 5 to 10 times. So yes, sir.
And regarding the cost effectiveness, madam, whether the total cost of the statin, if you look into you, whether it can be reasonable. Since the dose interval is a large dosing interval.
Yes, sir. The thing is, once it comes to India, then we can actually think about cost. Because currently what I have shown the cost is the conversion of the euros to Indian rupees. I think any drug, when it comes to India, the price will be different compared to the price for the Western countries. And so hoping that it will be less expensive.
A basic question I am asking is there any oral preparation in future can be available? Now we are taking subcutaneous.
Sir, as of now, if you look at trials of octreotide for acromegaly, we now have the oral octreotide which has come up. So hopefully in due course, something will come up whereby it could be delivered orally. As of now, it is subcutaneous injection, and because it is once in 6 months, like how we give denosumab, I think it won't be a problem.
Thank you, madam. Thank you.
Any question from the participants? Okay. Thank you very much. And in the interest of time, we'll move on to paper 2. And this is going to be presented by Dr. Geeta Lakshmi, Professor of Endocrinology, Ramchandra Medical College and Research Center. And the paper is titled is Fertility Reduced in Ovulatory Women with Polycystic Ovarian Syndrome, an opinion paper. Now, this paper will summarize the collective evidence supporting the hypothesis of reduced fertility potential in women with PCOS, regardless of ovulatory status, and speculates that reduced reproductive potential may be caused by altered oocytes, embryo and endometrial contents, and infertility-related comorbidities, as well as an increased risk of pregnancy complication. Over to you, Dr. Geeta Lakshmi.
Good morning, one and all. Thank you, ESTN, for giving me this opportunity. Thank you, Murthy sir, for those introduction. So moving on to the paper, this is an opinion paper on the possible mechanisms of infertility in women with PCOS, especially in the phenotype of ovulatory PCOS. So slide not moving. It's not moving. So all of us talk about PCOS related infertility as being the anovulation being the mechanism behind the infertility. And PCOS, as we know, is the most common cause of anovulatory infertility. And but studies have shown that there is reduced fertility potential in patients with PCOS, regardless of their ovulatory status. So though there might not be oligoanovulation, still infertility is seen in many individuals with polycystic ovary morphology and hyperandrogenism. Despite all this, there are wide range of effective interventions in terms of anovulation, ovulation induction, and we know that surgical interventions, assisted reproductive techniques, which are very, very effective in restoring fertility rates in PCOS patients. But still, proportion of infertile patients with PCOS who finally undergo IVF, despite all this after failure of multiple medical interventions, is very, very high. So this is the clinical data. So women with PCOS undergo more of assisted reproductive techniques. They're often older and nulliparous at the time of first delivery. And the probability of childbirth or the fecundity rate is 40% lower, considering if you take only spontaneous conceptions. And as I said earlier, treatments employed are very effective. So that is why if you compare at the end of the reproductive lifespan with normal women, the fertility rate is actually same. The number of children born are actually same compared to the non-PCOS females. So what about the pregnancy complications in PCOS? Again, women in PCOS, if they conceive, there are a lot of complications, especially early pregnancy complications like miscarriage and late complications in terms of metabolic aspects like pregnancy-induced hypertension and gestational diabetes. And not only that, it not only affects the woman, this hyperandrogenic environment, the milieu that exists for the fetus in utero, as such affects the neonatal environment as well and the neonatal development as well. So because of this, neonates of women with PCOS, when they are born, they have a high rate of admission to NICU. So this is said to be because there's a chronic low-grade inflammatory state because of the hyperandrogenism and also the placental abnormalities, that is in terms of impaired decidual trophoblast invasion and placentation. And not only the hyperandrogenism, the coexisting factors like obesity, metabolic syndrome, insulin resistance, the advanced maternal age, and many a time the use of fertility drugs, multiple fertility drugs, high dosage of these drugs used for ovarian stimulation and IVF, these themselves cause the damage. So what are the factors as such involved in the infertility in PCOS patients? Even if they have ovulation, regular ovulatory cycles, there are certain factors in terms of oocyte quality, oocyte competence, and the crosstalk between the embryo and the endometrium, and the placental abnormalities and the endometrial abnormalities. So these are the factors which are involved in high risk of pregnancy complications as well as in infertility as well. So there are a lot of neuroendocrine and metabolic alterations which happen in PCOS, which affect the ovarian function. And when they analyzed the transcriptomic signatures and metabolomic signatures in these oocytes, they were able to find out the meiosis was altered and there was a high level of oxidative stress inside the follicles itself. And there was altered glucose and lipid metabolism regulation. And as I told, crosstalk between the oocytes and surrounding somatic supporting cells was also abnormal when the follicles were developing. And these metabolic changes were independent of the follicular hormonal environment. So something beyond the hyperandrogenism and LH surge is leading on to all these problems. So these are the reasons which have been cited for the oocyte incompetence. There's high levels of free fatty acids inside the follicles, which lead on to lipotoxicity and endoplasmic reticulum stress. And because of this, there's a dysfunction of the granulosa cells. And not only that, chronic low-grade inflammation as a result of hyperandrogenism, which leads on to increased meiotic abnormalities, translated into increased aneuploidy in the baby, in the embryo, leading on to increased risk of miscarriage. And because of all these altered environments, the metabolism is altered. So various growth factors, cytokines, adipokines, all these things are abnormally expressed. And not only that, at the genetic level, again, there are some non-coding RNAs which are involved in regulation of gene function. So these are also abnormally expressed, and hence secondarily oocyte quality is impaired. So what about the embryo quality? So whenever they analyzed the patients with PCOS who underwent IVF and the embryos retrieved from them, these embryos were analyzed. So they noted that a significant temporal delay for the pronuclear breakdown and the further cleavages to happen. So the cell division was also delayed. And not only that, whenever the cell divided, they were also able to find out there's an increased incidence of aneuploidies. And this is about the endometrium. So again, the same reasons, that is hyperandrogenism, insulin resistance, contributing to oxidative stress. So these result in abnormal expression of proteins in the endometrial cells. This leads on to abnormal cell cycle regulation and mitochondrial dysfunction. And also there's something called as abnormal expression of estrogen and progesterone receptors. And another thing called as progesterone resistance, which happens. So these abnormal receptors and abnormal glucose metabolism cause something called as resistance to progesterone receptors. And so this leads to altered glucose metabolism and altered decidualization when the patient conceives. And this leads on to abnormal placentation as well. And increased expression of androgen receptors in the endometrial epithelium again leads on to local hyperandrogenic environment inside the endometrium. So there's also an increased uptake of androgens into the endometrium and increased expression of endometrial androgen receptors as well. And abnormal immune cells are also seen. So this again disrupts the insulin sensitivity and also alter the angiogenesis which happens in the endometrium. We all know that proper angiogenesis is important for proper placentation and proper trophoblast invasion. So this is again in turn contributes to placental microvasculature abnormalities translating into pregnancy-induced hypertension and as such. And independent of the ovulation, hyperandrogenism activates a process called as ferroptosis, that is iron-related increase in free radicals and causing cell death in the endometrium. And endometrial differentiation and receptivity to an implantation is also altered. So these data suggest that PCOS and its comorbidities are linked to altered oocyte and endometrial competence, impaired endometrial embryo crosstalk, increased risk of infertility, and increased risk of early and late pregnancy complications. This is mainly because of the endometrial abnormalities and placental abnormalities. So finally, to summarize, so what they're saying, though the efficacy of strategies employed for treating infertility in PCOS is very high, restoring ovulation is not the only aim from our side to restore fertility. Other factors like hyperglycemia, blood pressure, sleep, and mental, emotional, and sexual health should also be optimized through lifestyle modifications. And also PCOS women should be counseled about the fertility potential, and it should be insisted that improving ovulation or inducing ovulation is not the only means to achieve fertility. And the current opinion reveals a crucial scientific gap in the knowledge of ovulatory function in women with PCOS. So future research should concentrate on improved fecundity or the spontaneous conception rate and reduce dependence on medical and surgical interventions in these patients. And approaches beyond ovulation induction must be a key strategy to do this, to improve fertility potential and reduce pregnancy complications in the PCOS patients. Thank you.
And thank you very much, Dr. Geeta Lakshmi, for that lucid presentation. The paper is open for discussion.
Madam, very good paper, madam. It is a very good paper. It says foresight also. Still, the etiology or etiopathogenesis of the PCOS is ill-defined. Even the mechanism of the action of the metformin is also questionable always, even for the past 10 years. So, definitely your final slide, the future status or future of the PCOS treatment going to be enriched, and it should be investigated by the research aspect. So I want to ask, since we are in endocrine forum, since you are talking about the hormonal resistance in the PCOS, is there any drug resistance in the PCOS? Because in and out we are using the metformin for PCOS. So is there any resistance? Have you encountered the resistance for the metformin resistance for PCOS?
Yes, sir. So far, drug resistance has not been observed. Actually, in this paper, they have added an additional point saying that, sir, most of our PCOS patients are on metformin, and even when they conceive, we are advising them to continue metformin. So when we look at these various cellular level and metabolic alterations, they are suggesting that it is actually advisable and it's very rational to continue metformin. But as of now, there have not been any drug resistance which has been noted.
So what do you think, what will be the future of the PCOS? Since you have put a lot of research paper.
Sir, what they're saying is actually to address all these cellular level and metabolic alterations, the treatment should focus on some medications, developing some medications which can address at this level, and including again and again, they are re-insisting on the lifestyle changes, the importance of lifestyle changes in bringing about the epigenetic changes which are happening here. So more than medications, that is what they are insisting on to bring about these changes.
So prevention of the PCOS is the mainstay of the
Yes.
management,
Yes, sir.
rather than we are putting the drugs. Thank you, madam. Thank you, madam.
Thank you, sir.
There's a question in the chat box. Yes, Dr. Sundaraman, you can talk, then you can look
It was
at the
a
question
very
in chat.
nice presentation. In fact, we know that there is a boom of PCOS with the increasing in the fast, very much in the population. And you are very categorical in stating that's a multifactorial, and we are not able to pinpoint the genetic loci as such, and also because of the other epigenetic phenomena. I just want your opinion on, because this has occurred because of the change in lifestyle, alteration in the biological clock, and also that endocrine disruptors, which are coming to existence of more. I think if you can tackle those issues, I think that will very long way go into the epigenetic phenomena.
Yes, sir, which actually they have quoted a reference by the same author in 2017, where he has looked at the insulin resistant part, which has happened in PCOS. And finally, he has concluded the same thing. So this endocrine disruptors, everything like tackling them will in turn affect the genetic alterations which are causing this hyperandrogenemia and insulin resistance. So that is what he is also stating.
Dr. Geeta Lakshmi, the question is in the chat box from Dr. Priya. Is it possible to clinically differentiate between ovulatory and anovulatory cycles?
Yes, so the first thing, as we all know, like ovulatory cycles are most commonly going to be relatively regular. Very rarely PCOS with anovulatory cycles are going to be a regular menstrual cycles. And other than that, I think withdrawal bleeding will also be one of the factors which can help us, and the endometrial thickness also.
Thank you very much, Dr. Geeta Lakshmi. We will now move on to the third paper, and that's by Dr. Varun, who's an endocrinologist from Madurai. And his talk is based on the paper, Comparative Efficacy of Pharmacological Therapies for Fibrosis Improvement and Resolution of NASH. Very interestingly, several databases have been looked at and analyzed by an experienced librarian. And he has now analyzed this data to rank order of efficacies of various NASH therapies in terms of their improvement in liver fibrosis and NASH resolution. Therapies that have been shown to improve NASH resolution may be combined with therapies that have an antifibrotic effect to further boost treatment response rate in future. Over to you, Dr. Varun.
Good morning. Thank you, ESTM team, and thank you, chairs, for your kind words of introduction. And I will swiftly move on to my paper. This is a systematic review with network meta-analysis that was published in the Alimentary Pharmacology and Therapeutics. We know that NASH is being one of the most commonly reported the biochemical problems that is noted in obesity and diabetes mellitus. The prevalence is gradually creeping up along with obesity and diabetes mellitus. So to summarize, it is basically the most common cause for the transplant, that is second leading in US and third leading in India after the hepatitis and the alcoholism. Because of the rise in the metabolic derangements, we find a lot of NASH, and NASH leading on to fibrosis causing cirrhosis. So the most proposed and widely accepted the modality of the therapy till now is diet and lifestyle that can change the metabolic derangements. There's, as of now, there is no FDA approved agent for the treatment or management of NASH as such. But there are streamlines that have been focused on, but we don't have an effective strategy for treating or managing the NASH as such. So to sum up, there is no drug which can combat the metabolism or can change the pathology, that is from a NASH getting into a stage of fibrosis. This discrepancy has been noted, and this paper is trying to find out the answer what we have right now. So the aim is basically to find the relative efficacy of the drugs that have been in the trial right now for both the fibrosis improvement and the NASH resolution. So basically, these are all pathology-based, drug-based studies, and where the number of trials have been grouped everything together into a certain systematic review, and then they are trying to focus on the efficacy of the individual agents, and they are trying to compare and rank the agent that is going to be better in terms of fibrosis improvement as well as for a NASH improvement. So it is as Sir quoted, it is a database search study, and they have taken a lot of studies into considerations, RCTs, which are going to be biopsy proven. None of the studies were excluded by the librarians, and they wanted to know as a primary outcome the resolution or improvement in a single stage of more than one stage of fibrosis. In the secondary outcome, they wanted to prove that the biochemical parameters are getting better as well. So 26 RCTs were taken into consideration, out of which 4,000 and odd studies were taken into considerations. So 5,000 patients were dealt in, out of which 4 were from single centers trials and the remaining were multicentric trials. Most of the duration of follow-up were between 24 to 100 weeks. The mean age of the population studied was 47 to 63. Then NAFLD activity score was between 3 to 5.7. We know that higher the score, the chances that the patient is having a greater severity of the liver disease. That's the activity score that is between 0 to 8, and most of the patients were between 3 to 5.7. So this diagram on the right side, we can see that the upper one is basically the primary outcome trial, where they looked into the network of analysis. So the starting point, the comparison may be with the placebo. The drugs were taken into consideration, and the overall network was analyzed, and the outcome was quoted and given. So coming to the primary outcome, that is the more than one stage improvement in the fibrosis, the direct analysis, what they did when they looked into the trial, they analyzed the drugs individually with the placebo. When they looked into the odds ratio, they noted that out of the 25 drugs that were studied, obeticholic acid with an odds ratio of 2.2, pioglitazone and vitamin E were superior compared to the placebo, which was from the direct meta-analysis. When they looked into the network analysis, where they tried to look the order or ranking of these each and every individual drug, when they compared with placebo, the lanifibranor, the obeticholic acid, the pioglitazone and vitamin E were ranked in the descending order with their odds ratio as the main parameter they were considering. So to tell that when they looked into the individual studies, these studies basically obeticholic acid had 2 to 3 studies that was compared. So lanifibranor had 1 trial. So each and every trial was grouped, and then they compared, and they found that this was the order of the ranking that was obtained from with respect to the primary outcome improvement. Based on these data, they gave a Sukra scoring. Basically, this is the statistical scoring for giving the weightage for the drug. So when the score is higher and higher, it is approaching the 1, then it is going to be better. So these 2 drugs, lanifibranor and the obeticholic acid, had the highest score of 0.77. That means with respect to primary outcome, these 2 agents were having the best benefit as a highly ranked agents. On the contrary, losartan, simtuzumab and solanercept had the lowest probability of having an improvement in the primary outcome. So this is the studies and comparisons. We can see that they had a favorable outcome with respect to obeticholic acid and pioglitazone and lanifibranor, but not with the other agents that were studied. So again, to show that there is a statistical favorable outcome with these agents when they were grouped again. So coming to the secondary outcome, that is a NASH resolution as such. So when they did the biopsy and found that the improvement is there, they quoted that the secondary outcome is better. The individual studies that looked into were given by each and every individual author. Semaglutide, liraglutide, the vitamin E, the pioglitazone and lanifibranor had the better overall individual study outcomes out of the 20 studies that was analyzed. When they did a direct analysis of the multiple studies, the obeticholic acid had 2 studies that were quoting and it was found to be superior compared to the placebo. But when they tried to do a network analysis, there was a statistical benefit with these agents like semaglutide, liraglutide, vitamin E, and combination with pioglitazone or pioglitazone, lanifibranor, and obeticholic acid, which was statistically significant. We can see the odds ratio order also with these descriptions, starting from 6.6 to 1.62. So the semaglutide being liraglutide, both the drugs having the highest the odds ratio compared to the obeticholic acid having the least of the outcomes. So the ranking has shown that there is a discrepancy between the fibrosis and there is a discrepancy between the NASH resolution as well. So the studies that have been quoted, these are some of the summarized studies that were quoted and found to be statistically significant. Just to highlight the overall rank order as well. So coming to the discussion part, basically we have a lot of drugs that have been studied, out of which we have lanifibranor and obeticholic acid, pioglitazone, vitamin E that were statistically significant, and they had the highest ranking as well. Particularly when they tried to rank it, only lanifibranor and obeticholic acid actually had the statistical network analytical significance. So we had a lot of drugs for NASH as well, but semaglutide, liraglutide, and vitamin E plus pioglitazone were the 3 that were found to be having the statistically significant network analytic parameter as well. So we have as such ASLD criteria that shows the vitamin E and pioglitazone for biopsy proven NASH. There are premature, the guidelines states to be premature, but we have evidence now that GLP-1 and agonist and the OSCA had the better overall benefit as well. So this is the sucrose scoring. We can see that the 0 being the least, and when it is approaching the 1 being the group and statistically having the significant overall scoring. So strength of it, basically multiple drugs are getting studied in a single study. Coherent results are obtained, but there are a lot of limitations. We are trying to see drugs individually, and that studies have been done in multiple centers with a heterogenic data of people as well as the analytical pattern. Again, the ranking probabilities can be misleading because the studies have been individually done, and we are trying to group into a single study that can have a misleading data as well, because some studies may have an individual higher ranking when it is done individually, but once it is grouped, their ranking may come a bit lesser also. Here, the studies have been done between phase 2 and phase 3 trials, so which is not going to be uniformly the same. So concluding, the therapies trying to improve the NASH as well as for antifibrotic therapy should be combined rather than given individually. For the future, we need to do RCTs to prove that instead of network systematic reviews, and we need to do some RCTs to prove that they are going to be better in respect to overall improvement in the fibrosis stage as well as for the NASH clearance. Thank you.
Thank you very much, Dr. Varun, for that very interesting presentation. The paper is now open for discussion.
Varun sir, very good presentation, sir. Whether your study shows obesity with NASH or obesity with diabetes with NASH, even obesity can lead to the NASH, as you are aware. Is there any randomized study regarding
sir? Yes, sir. The studies have been pertaining to the NASH. The population studies were biopsy proven, and the individual drugs were given, and the individual studies were looked into, and they are grouped together, sir. there is no separate analytical pattern for diabetes or non-diabetic population.
Oh.
We have a chat question. Is obitocolic acid similar to UDCA, which is commonly used in India? That's what the trials had shown, that the UDCA was also included in the trials. So when they did the ranking, they found that UDCA was not superior. I didn't quote it, but when it is considered along with it, the obitocolic acid had a better overall outcome with respect to the fibrosis improvement. As well, NASH improvement was also noted, but UDCA is not found to have a betterment in both aspects. So it is not similar.
Sir, can you tell what is the mechanism of the obitocolic acid and the pioglitazone as a treatment or prevention of the NASH or prevention of the fibrosis?
Sir, sorry, sir.
Like you told pioglitazone also
Yes,
and obitocolic acid also.
Yes, sir.
Pharmacological mechanism I am telling.
Yes, sir. Obitocolic acid acts like over the farsenide X receptor mechanism, that is suppressing the inflammation, and the inflammatory pathways being blocked by the obitocolic acid. Pioglitazone is the PPR gamma and alpha agonism. So again, indirectly in the insulin resistant pathway, as well as part of inflammatory pathways being blocked by pioglitazone. The lanifibranor is again a pan PPR agonism. So though the alpha, beta, and gamma agonism is a bit different, saroglitazar, the pioglitazone, and the lanifibranor acts via the PPR pathways.
Thank you, sir. Sir, all these drugs only specific for the liver, or can you use for other conditions which leads to fibrosis or pre-oxidation injury, oxidation radical injury?
Here the studies have been focused on the NASH improvement, sir, particularly fibrosis. Pioglitazone, we know that it has been used in multiple other systems as well. Like trials have been done with PCOS and other, inflammatory disorders. We have metformin that is being done with a lot of other systemic disorders as well. But when we look into the NASH and particularly the NAFLD improvement, these trials have been particularly focused on these two parameters right now.
Dr.
Thank
Varu,
you, sir.
question.
Yes, ma'am.
That was a great presentation. Did they also look into SGLT2 inhibitors here?
Yes, ma'am. SGLT was also included. That's what 26 drugs were taken into consideration along with SGLT.
So they didn't find any evidence with what did they find?
Individually, they had benefit, but when they ranked it, it was not superior.
Okay.
It was basically the ranking that was found to be there. That's a limitation of the study as well. The ranking was not having a superiority over the other drugs.
Thank you.
On behalf of Professor Sangamani and myself, would like to congratulate Dr. Asha, Dr. Geeta Lakshmi Varun for the excellent presentation. And we would also like to express our gratitude to the organizers for giving us the privilege of chairing this session. I close session 1, over back to the organizers.
Sir, 1 minute, sir. Sir, 1 minute. So I thank the organizers because of the giving us a chance of enriching my knowledge. Enrich itself shows it is a privilege to chair this session with a great man, an endocrine Pidamagar like Dr. Murthy, Professor Murthy also. So it is a very good day for me to chair this session with Professor Murthy. Thank you, sir. Thank you very much, sir.
Thank you so much, sir. Thank you for joining us virtually in spite of your hectic schedule.
Thank you, sir.
Thank you, Chairperson
Thank you.
Murthy and Dr. Sangamani, sir. And thank you, speakers, Dr. Asha, Geeta Lakshmi, and Varun. May I now request Dr. Ushaya Agri for the next session on thyroid. Over to Dr. Ushaya.
And welcome to session 2 of Enrich. Thank you for everyone who's joined us online. We have about an hour, just over an hour of thyroid related sessions coming up. Initially, I would like to invite Dr. Sriram Mahadevan, Professor of Endocrinology at Ramchandra Medical College. Dr. Sriram is going to take us through the clinical examination aspects of thyroid. And then followed by that, we'll have a panel with experts on hyperthyroidism. But I'm handing over to Dr. Sriram for clinical examination skills first. Thank you.
Thank you, Dr. Usha. And thanks to the ESTN team for one more opportunity to discuss the second most common endocrinopathy, thyroid disorders. And that too, this time giving a back to basic kind of topic. In most of the conferences, as we all know, thyroid disorders are discussed predominantly from the biochemical point of view, investigations hovering around TSH, how to interpret the thyroid function tests, T3, T4, TSH, etc. But when this topic was given to me, I was going on thinking what to do, and I have compiled quite a few of our clinical cases which we had seen in the last couple of decades and tried to compile in some fashion so that it'll make some sense in implying that clinical examination, even in this era of extensive and easily affordable and accessible investigations, is very important. And I hope I'll convey that message. And we will recapitulate some basics of thyroid before going into this aspect. That is, we need to remember that thyroid develops from the tongue, the foramen cecum, and the thyroglossal duct going downwards, and it could get arrested in any of these stages. And this carries a lot of meaning in certain situations, as I will allude to in the next few slides. And thyroid, bilobed butterfly-shaped gland in the front of the neck, and typical third-year MBBS clinical teaching, in especially surgery. When I look back at our medical school training, thyroid, including Graves' disease, was 99% discussed by surgeons more than physicians in our characteristic government medical college training. I wish now the things are changing. So examination of thyroid is repeatedly discussed. So I will spend less time on this nodule and palpation, etc., but give the clinical endocrine significance. And hopefully a lot of postgraduates are listening to this talk. It will be very useful. This is a basic thing which we all do in any general medical examination, whether it is endocrine or not. So anthropometry, vitals, today I think SpO2 should also be included in that. Head to foot exam, you can call it in any way. Nowadays I see a lot of our college students writing pickle, pallor, icterus, cyanosis, clubbing, in that order. Whatever, it's always worth following one routine and always stick to it. Foot to head to foot, whatever it is. And it is highly relevant, as you will see, that sometimes simple examination will give a lot of clues. And system examinations, I put others because sometimes, see, at a postgraduate level, everything will not follow the textbook order. While examining, you will see a skin finding based on which you will have to go back to the history. So it's a correlation between physical findings and basic investigations is what is important. So we will go to some hypothyroidism related case vignettes, which will help in understanding the examination part. And before that, standard Werner Ingbar textbook of thyroidology. You see, this is early literature. I mean, I'm not going to read out. We all know this repeatedly, slow speech, dry skin, croaky voice, puffy face. All these are well known, and not all of them. They're like, even in endocrinology, the Cushing also from a distance will appear the same, especially exogenous steroid therapy, puffy face, nephrotic patient, CKD patients, all will appear hypothyroid. We ultimately need to do investigations, but suspicion of these tests based on certain, but none of these symptoms are very specific. That's the unfortunate thing. And it's a correlation of a constellation of symptoms and signs, which is important. I think it's a spotter. We'll start with the neonatal thing. Both these children are 9-month-old when they presented to us. You can see the gross hypothyroid faces, puffy face, the protruding tongue, and the second patient, you can see even the umbilical hernia, etc. So I think in this era, it's even though I'm showing a clinical finding, this is put first just to re-emphasize the fact that never a child should undergo this. I think the government is also taking a big thing, a big step. A lot of there are model districts in Tamil Nadu which are undergoing newborn screening as a routine, and you see how even at that level of treatment, the child improves well. Unfortunately, these children are under our follow-up for more than 10 years now, and speech is the most importantly affected. Very unfortunate. That gross mental retardation doesn't occur even, that quote unquote crude word called cretin, neurocretin, myxedematous cretin, all these words were used in the past, but unfortunately, they develop certain subtle speech and intellectual abnormalities which will be picked up. Speech is very affected, so it will be very easily detectable. This is again another typical rural and Indian presentation. I remember during our training sending a couple of such gross hypothyroid children to an Australian journal, and the reply came back that we don't see such patients and our readers will be shocked to see this. They refuse to accept it. See, here is the younger sister growing taller, and then only they bring to the first child. You see the goiter also. I'm sorry that these patients, when I went back to the history, this girl's mother tells that she has been diagnosed hypothyroid. They stopped treatment. And we have presented one paper in last year's ESICON also, where we showed that in spite of diagnosing congenital hypothyroidism early and starting treatment in a government setup, very unfortunately, treatment was stopped because accessibility to thyroxine, remote area, not available, interrupted therapy. I think that has also to be taken care of, and we presented that paper saying, what is the use of then diagnosing? You have congenital 11 newborn screening, but you don't follow up at the first 3-4 years. This is again textbook picture. This is for PGs, and I think the seniors here. So in juvenile age, this kind of a pseudo hypertrophy of the cough is called by a eponymous name. I'm not going to put that. Cocker, Debre, Semelagny. My pronunciation is wrong. I'm in the land of French people, so this is how to pronounce. Somebody can tell me later. But Cocker-Debre syndrome, gross hypothyroidism you see here. An interesting one more endocrine point to look for in this patient is the large testis. I learned one new term recently. What is the difference between megalotestis and macroorchidism? It will be of interest for some PGs, or it's a leg pulling question in a typical odd bedside thing. Both look apparently similar in the term. Megalotestis is the normal variation in the population. Some ethnic people will have bigger testis, some will have small testis. Macroorchidism is pathological. Like for example, in a precocity in a male, obviously at that age there will be, and Fragile X syndrome, hypothyroidism where the TSH will have a spillover effect on the FSH receptor and increase the size of the testis is another example. And we have a couple of other situations or whatever. So macroorchidism is the word we use when there is a pathology causing the increase. Then you can say bilateral, unilateral, and approach it that way. And hypothyroidism, severe, overt, especially juvenile onset hypothyroidism is a classic example of macroorchidism. Again, this should be not occurring, and we unfortunately see at least 1 or 2 times a year. I can just recollect quickly. This is a girl, 80-year-old, who went with this abdominal distension to the major cancer hospital in Chennai, and the pre-anesthetic evaluation showed high TSH, for which they referred to us for. And you can see she's 80-year-old with breast development, and Dr. Murthy sir also used to many times say this is the hypertrichosis seen classically in juvenile overt, and you see the dry scaly skin. All these are classic features, and they wanted us to clear the patient for a surgery suspected CA-125 being very high, ovarian cancer. You can see multicystic ovary. This is an extreme manifestation, and you do an MRI, you'll see a typical thyrotroph hyperplasia, and we all know what it is. This is the Van Wyck-Grubbach syndrome due to the protein manifestations due to enormously elevated TSH and its effect on multiple systems. This is just to say how much thyroid can mimic even as a rare, symptom. So a simple examination, why is this child having the breast development at a young age? Is ovarian CA so common, etc., should be, thought about. And otherwise, what will happen? This is another unfortunate story. I had to see this patient 15 years back. Again, the same case, Van Wyk Grumbach, very unfortunately underwent surgery. Luckily, the gynecologist did unilateral oophorectomy. You can see the scar here. She's now still under our follow-up. She's getting married in the near future. So this is absolutely avoidable. A simple thyroxine will solve the problem in all these cases. Coming from hypothyroidism to examination of goiter, this is what I said. Elaborate descriptions are given on how to examine the thyroid. Today we have ultrasound as an extension of our fingers. I think ultrasound is part of clinical examination today, but today's focus is on clinical exam. This is what we mentioned. Thyroid, the isthmus will be felt soft here, especially normally also in young ladies. Whether you go from front or back, all these, our surgery professors used to scold us if we examine from the front. But with practice, in whatever way you feel, you should know what you are feeling correctly. And I heard this is a diving thyroid in Werner Ingbar. It's an interesting thing. If you flex the neck at the appropriate level, the gland is seen. But after that, if you flex it more, it goes into the thoracic inlet. And these are all important for patients who are lying down where they cannot be examined properly. So examine properly is the simple statement I will make, but preferably from the back, because it will be easy to extend and the 4 fingers can run over the lobes and you can feel it better. Very important sign, often overlooked. I think postgraduates listening to this is the mechanism of the classic Pemberton sign here. Even without undressing, you can easily see how much of congestion. You can see the veins in the not well made out here in many clinical setup. So this is a straightaway indication that there is a retrosternal extension. Simple, and you should approximate the arms as much as possible towards the ear. And if there is a significant retrosternal extension or a large goiter with some minimum compression, it will be easily made out. This will not be seen even by a CT scan. CT scan will tell you only the anatomical thing. Whether there is a dynamic compression on the vital structures will be shown by these kind of simple tests. You see how much the veins are getting engorged here. This was very unfortunate. I think our colleague, Dr. Dalapati, is here. This man, I was told by another colleague also, he is obviously he belongs to the Muslim group. He was not examined. This part of the thing with the fully covered thing, it was missed. Only the second, third examiner is finding out this. So I think these all should be avoided. Undressing the patient, looking for subtle signs will give a lot of clue. This is to put how a young child thyroid normal utopic position. This is goiter, hypothyroid. You can see the dull faces. But you see how suprahyoid, ectopic thyroid also presents at the same age. Again, a good examination will tell you that this is not normal position of thyroid. What is the implication? Any ectopic thyroid means it is a permanent hypothyroidism. And the same autoimmunity can occur even in an ectopic thyroid. You see here the technetium scan and the force. Please examine the oral cavity properly. So many patients of lingual thyroid we have seen. And every time, these photos are one of the best photos we have. But you see, this will be a straightaway clue. That good thing about this is, if this gland was functional, especially in the first 2-3 years of life, the mental retardation part is over. They will come after 3-4 years. So permanency of hypothyroid is a very straightaway implication. And secondly, unnecessary surgery should not be done. This previous case, I'm sorry to say that surgeons, swelling here on a thyroglossal cyst, this tongue protrusion and swallowing, etc., are not that easy to differentiate. A good ultrasound and a technetium is mandatory before operating. Patient posted surgery in the major corporate hospital in Chennai. Later, it was the only functioning thyroid, and just by giving thyroxine, it will just regress. So lingual thyroid is something I want to repeatedly emphasize. Even in adults, sometimes it poses problem. This was another interesting case where you see here the same child has an ectopic thyroid, suprahyoid, as well as a lingual thyroid. Nicely demonstrated in the technetium. And these are all the functioning thyroid. Obviously, she's well preserved till the age of 7 or 8. So now she has hypothyroid again, permanent. The other one is the minor salivary gland, what you are seeing here. And family history, familial goiter. Sometimes these are all picked up just by, the attenders coming to us. This was one rare thing, goiter, local, beliefs, tattoo, etc. This is for just fun, I put it here, but our people can go to any extent, but not to the surgeon or proper evaluation. Spotter. This is the only endocrine rare condition where you can spot. I'm thankful to the medicine resident when we were training. This is courtesy PGI Chandigarh. You see here the lumpy, bumpy lips, the tongue, neuromas, classic MTC, meant to be is though a rare diagnosis with a beautiful genetic basis, it's a spotter. So coming to thyrotoxicosis and clinical examination, again, lot of clinical series are all presented. Today, we know it can present to any department and you have a TSH. Had this been a routine talk, TSH suppressed, 2 minutes more. Yeah. And this is pre-tibial mixed edema, can present in any way, but in South India, unfortunately, we are not seeing at all. Very rare. I don't know how many of you have seen commonly. We actively look for it. I have seen 2-3 patients only out of hundreds of thyrotoxicosis. Maybe others can share. Onycholysis is a characteristic sign which we can look for. This is star due to the hyperhidrogenetic feature and Muller's muscle. Unilateral presentations are also there. Bilateral, even after thyroidectomy. This says that thyroid-associated orbitopathies pathogenesis is not directly related to the thyroid level. And many clinical signs are described. This, if you see from top, you will see the proptosis left more than right. Sometimes it will give clue to the etiology. You see here vitiligo with Graves, they straight away it's an autoimmune. Beware, there are associated conditions to be looked for in thyroid, not just thyroid alone. This is myasthenia gravis along with Graves in an ablated patient. And not everybody will come with thyroid disease alone. This is third nerve palsy in diabetes in a diabetic patient. So not everything is thyroid, even in a thyroid patient. Beware of this. So Graves ophthalmopathy, this slide 10 seconds more. I'm very happy that they are emphasizing clinical score here. That's very important. Lid edema, lid redness, you see on the top, and caruncular edema, caruncular swelling, conjunctival chemosis, and pain on movement. This is a simple clinical score, how beautifully the things are improving on steroids. Other findings, I think as postgraduates, anybody who has undergone neck surgery, please look for Vostek and Trozius sign, easily demonstrable, straight away signs of, with all unreliable calcium reports, they are the best test. Horner syndrome, not at all rare. This may be academic, we are not going to change, but the subtle ptosis, mild in ophthalmos, and point to the postgraduates, pupillary inequality cannot be seen by naked eye. You see from a distance with ophthalmoscope, you will easily see the red reflex on both the eyes, pupil being different. Nicely brought out in this picture from another place. Again, thoroughly examine the patient. This is alopecia areata. This gives clue. Examination of the sister, vitiligo. So these are all signs of autoimmunity. Associated finding, B12 deficiency, severe treatment. So not every time it is Addison. These are all things which you will, unless you look for, we will sometimes miss. I'm sorry that these videos are not playing well and time is not, I hope one video at least I'll demonstrate, I hope. It's not coming. Yeah. Yeah, this is another sign which we are insisting, and simple Romberg sign, a significant clue. I request our postgraduates to every time carry a torchlight, a knee hammer. Rarely they also bring. You see, these are all straight away signs of B12 deficiency. Not everybody will have pigmentation. The neural and the hematological manifestations are dissociated many times. This is tongue tremors. And if this place, this will be nice to see. This is published in BMJ case reports. I think JIPMER people have also published. This is not a sign to be demonstrated. It's slightly painful. The severe myoedema, you can see here, seen in severe hypothyroidism. And certain rare neurological manifestations like chorea, akathisia. You see here, this man is going on dancing in the, and there was a hemichorea-like feature on the right side. All this just got abated with simple carbimazole therapy in this guy. I'm not going to continue here further, but just to conclude by saying that even though it's investigation oriented, we have excellent simple test. One TSH will give you the answer, but the beauty and the satisfaction which clinical examination gives, and in telling the patient about the, and you find a small alopecia spot here and you say that there is an autoimmune thing, has more satisfaction than seeing one TSH value from a less reliable lab. So I conclude by saying that clues from good clinical observation is the most cost-effective way of diagnosing even in this era of investigations. Thank you very much for your kind attention.
Thank you very much, Dr. Sriram. I can see we have a few questions online. Perhaps I could request Dr. Sriram, in the interest of time, maybe to just answer the questions in the chat box remotely, unless there are any questions in the room that we need to address. No, excellent. So may I please invite onto the stage Dr. P.G. Sundararaman, Dr. Ravi Kiran, and we have remotely, I think, Dr. Jayashree and Dr. Velayudham. Dr. P.G. Sundararaman, we all know, one of our senior most endocrinologists, one of the most recognized endocrinologists in Tamil Nadu and nationwide. Dr. Ravi Kiran, our endocrinologist from Chennai in SIMS. Dr. Jayashree Gopal, yes, I can, she's online from Chennai, and Dr. Velayudham as well. I mean, these are all very active members in ESTN and nationally, and we're very lucky to have them with us today for this discussion on hyperthyroidism. I'm just going to open my slides. So over the next 30 to 40 minutes, what we're going to try and do, we have an amazing array of expertise on this dais, and we're going to try and take advantage of this expertise and take through a case-based format and discuss 3 time permitting 4 cases. Can you please show my screen? Thank you. 3 time permitting 4 cases. Cases, and then going onwards to perhaps rarer presentations. You want me to share screen? Lovely. Thank you very much. Thank you. Right. Now, in this case series, moving on. Now, just a few bits of definitions before we go on. We need to differentiate between hyperthyroidism, which we use quite commonly, and thyrotoxicosis. Hyperthyroidism is the pathological disorder which is characterized by excess thyroid hormone, which is synthesized and secreted by the thyroid gland. On the other hand, thyrotoxicosis is the clinical syndrome associated with high circulating thyroid hormones, irrespective of the source. And this is important. We'll see why in a few minutes. If you look at the pathological mechanisms of thyrotoxicosis, you can have an increased effect of thyroid stimulators. This could be TSH receptor antibodies. This could be an inappropriate high TSH secretion, excess HCG secretion, like from trophoblastic tumors, or it could be from an autonomous thyroid function like receptor mutation or a GS alpha protein mutation. Now, the other side of it is you can have thyrotoxicosis without hyperthyroidism. Remember the differentiation. whether the gland is functioning high or whether you just have the clinical manifestations of an excess circulating thyroid hormone. And this can be related to a thyroiditis. It can be related to extra thyroidal source of thyroxine, for example, iatrogenic or factitious intake. It could also be, I mean, we've all heard these reports, especially in the 70s and 80s, of hamburger thyroiditis. And you can also have the same effect because of excess exposure to iodine. So when you say hyperthyroidism, or when you look at a set of thyroid function tests, it's not enough to treat hyperthyroidism. You really need to pin down the clinical as well as the pathological diagnosis before we think in terms of treatment. So coming on to case presentations. First case, a female, 32, otherwise fit and well, started having palpitations about an year and a half ago and had a weight loss of 6 to 8 kilos over a few months. TFTs, as you can see, had a very suppressed TSH and a high T4 and T3. Now I'm going to come to our panel in this kind of, no. I'm not able to see my panel on screen. Is there any way?
Yeah, I'm here.
Oh, yes. So I'll start with Dr. PG Sundaraman. Sir, what would be our differential diagnosis? Female, 32, symptoms of hyperthyrotoxicosis and biochemical hyperthyroidism.
Yeah, as Dr. Usha has highlighted that thyrotoxicosis is a general term. Hyperthyroidism is a more specific term where there is an excessive secretion from the thyroid gland per se. So here is a condition where it shows the clear biochemical evidences of increased thyroid hormone secretion. So whether it is going to be a form of thyrotoxicosis where it is an endogenous or exogenous. Since this female is otherwise non-pregnant for any particular reason, and she is having signs of palpitation and weight loss, these are two important clinical signs, is very pertinently associated with a diffuse toxic goiter, or it is going to be a toxic multinodular goiter or a toxic nodule. So these are the first initial diagnosis that we can think of. So it also depends upon her further clinical examination and the history, and all these parameters are very important.
Thank you very much. So as Dr. Sundaraman said, it could be autoimmune, it could be nodular, it could be thyroiditis. And although initial treatment may not differ between these, it's very important to get to a definitive diagnosis, because eventual treatment does depend on actually diagnosing this correctly. So coming on to investigations, Dr. Ravi, how would we go further with investigating this young lady? Now, I'm specifically not going into physical examination. We are not going into the clinical signs and symptoms because they've just been thoroughly covered by Dr. Sriram. So we're going to only the investigations, clinical management, and differential diagnosis. Thank you.
If we don't find a diffuse goiter on examination, or if we find evidence of solitary nodule or nodular goiter on examination, probably next, since she is not pregnant, I will be going for nuclear scan, thyroid scan. In India, generally, technetium 99 scan is used for because the gamma emission is good, capture is good, and the patient can finish the scan within 1 hour. So that being the main reason, and cost is reasonable. So probably I will be sending her for technetium 99 nuclear thyroid imaging next.
Excellent. Dr. Velayudham, would you do antibodies? If so, would you do TP or TRAB? What is the relative sensitivity of each, please?
See, as far as the antibody levels are concerned, the most common antibody which we do in clinical practice is the anti-TPO antibodies, which is done more in patients with hypothyroidism actually. But if you consider anti-TPO in this case, if you are suspecting the so-called Hashimoto's, where patients with Hashimoto's thyroiditis, they can present with features of thyrotoxicosis in the initial phase. So who tend to have high titers of anti-TPO antibodies. The TSH receptor antibodies, which is mentioned here, is very specific for Graves' hyperthyroidism. But the test was not that widely available a few years back. But now I think each and every place they have their own assay system. So getting the test may not be a issue. But the utility of the test remains in few situations, I suppose, where you do not, you are not able to clearly differentiate between Graves' hyperthyroidism and other causes based upon your imaging and other modalities, and sometimes to prognosticate the disease. For example, to find out which patient may go into remission when you start them on therapy or during pregnancy and so on. So I don't do it routinely in all patients, but maybe in selected set of people with hypothyroidism, TRAB levels may be of use.
So I think we'd agree that we'd probably go for an uptake scan in this kind of a situation, possibly a technetium because of its ease and short time and availability. And if that gives us the diagnosis, well and good. The TRAB is much more specific, but perhaps because of cost and widespread availability, maybe something that we might not consider in the first instance. So this is what an uptake scan would look like. On the left of your screen, you can see a normal thyroid gland, and in Graves' thyrotoxicosis, which was the ultimate diagnosis in this young lady, you have a uniform, homogeneous uptake. So this is what a typical Graves would look like. So on an examination, this young lady had conjunctival injection, periorbital puffiness, lid lag, exophthalmos, diplopia on left lateral gaze. Jayashri, I know I presented these signs later, but had you seen these signs, would you have clinically concluded and treated it as Graves, or would you have done any further investigations to confirm?
Yeah, morning, everybody. So I think the eye signs are pretty specific for Graves' disease, but I would still like to go ahead and do at least an uptake scan to confirm the diagnosis. And one other thing I did want to mention, the place where I found TRAB useful was during the lockdown. You know, when the nuclear medicine sort of department was closed, and so apart from all of the drawbacks of availability and cost, TRAB was useful in that situation when we were seeing people, particularly during the height of the COVID, where we weren't sure whether it was a thyroiditis related to the infection. But would I hang my hat up and say this is definitely Graves and start treatment? I would like to have more corroborating evidence. I would say I'm 99% sure, but I would like to have a blood test. I think partly also for, thinking about it, maybe also for medical legal reasons. I think I would like to have a definitive sort of diagnostic test before I start the therapy.
So maybe in resource constrained settings, we could perhaps go by the clinical signs.
Very definitely. Very definitely. Like I said, I'm 99% sure with this. I would say it is Graves. Yeah.
But if the patient is keen to have a definitive diagnosis and in situations where tests are accessible and affordable, perhaps we could go on to do something confirmatory. So we need to have a variety of practice techniques because not every technique applies to every clinical setting. And I think postgraduates need to be adaptable in making a clinical diagnosis, but perhaps also knowing when to request and what to request in terms of tests. So this young lady was started on carbimazole 30 milligrams once a day. TFT improved eventually with no significant change in the thyroid eye disease. Now, this is important because sometimes treating straightforward Graves without thyroid eye disease, I think, is something straightforward that all of us can do. But when you get to thyroid eye disease, it's really tricky. Now, Dr. Sriram showed a quick questionnaire. I'm also going to show you slightly more specific. The UGOGO questionnaire is one of the ones that we can use. They have 2 assessment proformas. And as you can see, this is their initial assessment proforma. And it is actually quite intricate. You can see that they start with a lot of clinical diagnoses. They will start with looking at Yep, you can see that. Looking at the duration, goiter, antibody test, comorbidity, smoking, which is very important because it worsens your eye outcomes. And it's about 4 or 5 pages long. This in clinical practice, and they have a follow-up pro forma for the same, which on subsequent visits, they use to look at. Again, very intricate and very detailed. Please do go have a look. If you type in EUGOGO, EUGOGO, the European group for the study of Graves' ophthalmopathy, you will be able to see this. But in clinical practice, coming back to our presentation, more than the EUGOGO questionnaire, we actually in routine clinical practice can just go on to do a clinical score, which again, Dr. Sriram alluded to. So this is dependent on the degree of diplopia, degree of proptosis. I don't know if anyone's still using a Herschel ophthalmometer to look for a degree of proptosis, but we were all taught how to do it. Degree of soft tissue changes and impact on quality of life. This is called the no specs, no signs or symptoms, only signs. So lid lag, lid retraction, Asteri gauge, soft tissue involvement. So conjunctival injection, maybe a little bit of periorbital puffiness, proptosis, extraocular muscle involvement, which my patient definitely had with diplopia on left lateral gaze, then corneal involvement and sight loss. So this is very important and an easy, no specs, easy to remember grading for severity of thyroid eye disease. So Dr. Sundaraman, when we have these kind of patients with thyroid eye disease, what would be your trigger point for referral? How far would we manage ourselves, and at what point do we refer to a specialist ophthalmology service?
I just want to reiterate the initial clinical features. See, if in a city that you're going to be there, it's different. The approach is entirely different. But when you have the resource settings where you don't have an approach to the nuclear scan or TRAB or these things, once again, if a person with thyroid function chemical study of frank thyrotoxicosis with eye signs and other features, I think there is no point in doing a uptake. I don't think that you must paste unless until TRAB is done for the future course of treatment, whether you want to stop it or not. Otherwise, I think if you have a frank signs symptoms with ophthalmopathy, with T3, T4, which is high, and TS, I think can straight away go without doing a uptake scan. I think so. Regarding the referral, as you have told about the recent criteria, 2021 guidelines, where they have gone through the various, this thing like smoking, the eye signs, the antibodies, the thyrotropin levels, and infections and hyperlipidemia and so many things. And once again, I think to a very great extent, I think you can manage to a great extent. Only if it is going to be a severe case where there's a proptosis more than 20, where your treatment plan is failing. So initially the management is basically an anti-thyroid medication and subsequently go for prednisolone. That's what we just, and if we want that further, that you're not able to have the requisite improvement, then definitely you refer to an ophthalmologist for decompression surgery or anything.
Thank you very much. As Dr. Sundaraman said, proptosis, which scores you at 3 and under, we can probably manage. 3 is a slightly, let's see if you can or can't, but 3 and over is probably referral territory. This young lady was referred and was treated with steroids. Her progress was quite stormy. The steroids were weaned, and then she went on, she was given IV methylprednisolone, and now they're actually discussing rituximab. So that then brings me to prognosis in Graves' thyrotoxicosis and how do we maintain? Because she required, apart from prednisolone, nearly 60 milligrams of carbimazole once daily. And she continued to complain of symptoms and especially eye-related symptoms. So, Dr. Ravi, overall, what is the prognosis in Graves' thyrotoxicosis? What percentage do we expect to see going to a reversal remission? What are the chances of relapse?
The kind of case presented here, generally we see with medical treatment around 60 to 70% go into remission over 1.5 to 2 years. So here, if the eye symptoms don't abate despite normalizing of thyroid function, then other options have to be thought of. Since the lady is probably married, but probably waiting for conception, and she's also having significant eye symptoms, then surgery that option has to be kept in the background, because we don't want to give radiation therapy, and that may postpone her pregnancy options for another 6 months, and also because it may aggravate the ophthalmopathy. But this is a very generalized statement. The duration needed for complete abatement of Graves is a general statement. It may happen in 1.5 to 2 years. Many times you have seen patients being maintained on very low dose of carbimazole for even up to 10 years. So I think we need to have a frank discussion with the patient. What is her preference, whether to go for a definitive treatment, or if there is absolutely no side effect with the antithyroid treatment, patient accepts it totally, then whether they want to just carry on with a very low dose of antithyroid treatment. So I think nowadays the consensus among experts is to put it forward, put it on the table, and probably discuss it out with the patient and take a consensual decision. That's better nowadays. That's the trend nowadays.
Thank you very much. So you've answered 2 or 3 of the questions on this page. So prognosis about a 60-70% recovery. Options for definitive treatment, yes, surgery and radioiodine therapy, but perhaps in the setting of the eye, surgery might be a safer option. Dr. Velayudham, this young lady is requiring relatively high doses of carbimazole, 40-60 milligrams, even 12-18 months into treatment. What are the risks of this kind of? So Dr. Ravi has quite correctly said, if it is a low dose, you could consider maintaining. But in somebody who's requiring higher doses, what are the risks and how long would you wait before you consider definitive treatment?
Yeah, see, for postgraduate sake, in a patient like this, we have only 3 options of treatment for thyrotoxicosis is concerned. One is medical management with carbimazole or methimazole, whatever it is, and you have radioiodine therapy and surgery in the form of total thyroidectomy. So the radioiodine therapy will be a lost option because of her significant eye disease, because eye disease gets worsened when you try to give iodine therapy. But here the medical therapy which she is on, she tends to require a relatively higher dose to maintain the thyroid function in a relatively normal state. The problem is you need frequent monitoring, because a higher dose of carbimazole has its own issues. Number one is drug-induced hypothyroidism. These patients can go into a hypothyroid state if you don't monitor their thyroid function regularly. The second thing is the other side effects or adverse events due to the antithyroid drugs, and the most worrisome effect would be the possible bone marrow suppression or agranulocytosis. Though it seems to be an idiosyncratic reaction, there is some dose response relation to this problem as well. So the higher the dose exposure, the higher the chance of having adverse event like that. But all said and done, the risk of agranulocytosis is relatively rare. So we don't see in each and every patient, but we do not know. In a given patient, this can happen at the first day of therapy or years later. So if we decide to expose the patient to a higher dose of antithyroidics for a longer time, then you always try to look for other options. The general guideline is if you are not able to withdraw the drug within a period of 18 months, then you always look for the other option. So if you have already crossed 18 months or say 1.5 years to 2 years of antithyroid drugs in a stiff dose, then I think it's better to switch over to other form of definitive therapy. In this case, I think surgery would be a better option.
Thank you very much. And that's exactly what we did in this young lady. We went for total thyroidectomy, because especially with higher doses and during the COVID period, because remember this started March last year, she was swinging between hyper and hypothyroidism, which was then making her eyes worse. Now, we have another about 10 to 12 minutes left to take us through the rest of the cases. I'm going to try and go at a slightly brisker trot because these are all fairly more straightforward. 29-year-old female, 6 months after normal delivery, came in saying, I have palpitations and I'm not really this short-tempered, but I'm really feeling irritable and short-tempered, and that's affecting my family. When you look at her blood test, in July, she had a suppressed TSH with a high total T4 and total T3. That point of time, she was still breastfeeding and she was in her mom's house. So they decided, TK, we'll go back to Chennai anyways. And then once we go back to Chennai, we'll get a second opinion. She was actually advised antithyroid drug therapy when she initially consulted elsewhere, but she held off and came to Chennai. By August, her TSH was still suppressed, but then her free T4 and free T3 had come to within the upper limit of normal, and her TPO levels were positive. Jayashree, are you still up? Excellent.
Yeah, I'm here.
So what are your differentials? And apart from the TPO, is there anything else you would do? And I think the third question is a giveaway. If you were to consider an uptake scan, she's breastfeeding, what would you say?
So given the time frame that this is about 6 months after her delivery, obviously the number one diagnosis is postpartum thyroiditis. And postpartum thyroiditis, we need to think of also in women who present with depression. And of course, this lady presented with palpitations. So as of now, actually, if she's clinically asymptomatic, I would just wait and watch. I wouldn't do any other investigations at present. Maybe if she has a goiter, consider doing an ultrasound scan. But if she's well, otherwise, then we can wait. Definitely no uptakes, no sort of nuclear medicine radioactive scan in a woman who's breastfeeding. The likely course, she is going to recover. Just wait for another month. You already said that the free T4 and free T3 was at the upper limit of normal. Reassure that continuing to feed the baby is not going to affect the baby. The baby is going to be fine, and just wait and watch. Repeat the blood test in about a month's time. She may become normal, then go through a hypothyroid phase. And given the fact that the antibodies are positive, I think the numbers quoted are that about 2/3 of women would come back into the normal range. 1/3 may remain persistently hypothyroid. Even if they come back into the normal range in this pregnancy, the chances of the postpartum thyroiditis recurring in future pregnancy is very high. And we just need to sort of watch out for this and counsel and caution the woman, even if she's not going to remain on thyroid tablets after this episode of thyroiditis is over.
Thank you, Jayashree. So for any thyroid dysfunction occurring within the first 12 months after delivery, please do keep in mind your postpartum thyroiditis. Now, as Dr. Jayashree said, there is a good chance, 60-70% of recovery, but a third of the women will become permanently hypothyroid. And over the course of the next 8 to 10 months, you can see her TSH gradually went up and her free hormones came down, and she's now on medication with thyroxine replacement. Now, in this young lady, because she was breastfeeding and it was postpartum thyroiditis, we did not do an uptake scan, but should you suspect thyroiditis, your uptake would be reduced compared to the normal on your left. On the right, in theory, if there were an uptake scan, you would see reduced uptake in thyroiditis due to any other cause, viral or autoimmune. Now, moving on to the third case. So this is a 27-year-old male, well till 6 months ago, now has weight loss and frequent stools, was initially seen by a gastroenterologist, had a whole load of tests done, and then somebody did a TSH somewhere along the way. He, on systems review, also had retrospectively tremors, sweating, poor sleep, anxiety, and on examination, he had a small mobile mass on his neck with, and again, Dr. Sriram flagged up the importance of this, of any pressure effects when you see a neck mass with no pressure effects. Now, this, when we did an uptake scan in this young man, and the differential for something like this would be a multinodular goiter or a toxic adenoma. Now, clinically, I could feel a single nodule of about 1.5–2 centimeters in size. And if it is a single nodule, you will see what it looks like on the right with uptake in the nodule and suppression in the surrounding thyroid gland. And if it is a toxic multinodular goiter, you'll have multiple points of uptake with suppression elsewhere in the thyroid gland. So in this kind of a scenario for toxic nodule, what, Dr. Sundaraman, what would you advocate for treatment, and what would be our options for definitive management for this young 27-year-old with a single toxic nodule? So initial treatment and definitive management.
Yeah, before that, just want to, you showed me the nuclear scans for especially to the differentiation between thyroiditis for a simple thing. If you're able to visualize the salivary glands, and that is more of a thyroiditis where you have a low uptake. When you're not able to visualize the salivary glands, then it's more of a high uptake scan. So that is the one thing. And here we have seen earlier a diffuse toxic goiter or a Graves' disease. And here we have got a toxic multinodular goiter or a single nodule. And in fact, in these cases, in all these patients, the medical line of management is the first and foremost. So you're going to start on antithyroid medications. But you know very well, these are the conditions where whenever you have a multinodular goiter, it is more or less resistant to the medical line of management. And in a long run, I think it depends upon various other clinical features, whether this having an increasing size of the goiter in spite of a treatment, or the patient is having a pressure symptoms, or he's got other manifestations, all must be taken into account. So if there is going to be an increase in size of goiter, then definitely you must do a final aspiration cytology. And if there is going to be an increase, then also you do other forms of therapy like an ultrasound or a CT. And based on this, you'll go for a definitive line of management, whether it is going to be a surgery or a radioactive iodine uptake, ablation therapy. So normally it depends upon so many insight into what type of case, what is a clinical examination, and how it progresses. And basically to start with, I'll go for a medical line, then go for a definitive line of management.
Thank you very much. So I think in a 27-year-old chap with a solitary nodule, maybe medical management will be lifelong in all likelihood, whereas definitive management with radioiodine ablation would be the most straightforward option. Or if the patient is resistant to that, despite adequate counseling, surgery with a hemithyroidectomy might be an option. Now, last case, and I'll try to go through this, 27-year-old female, again, looking hyperthyroid when you look at it, but something not quite right, looking a little stressed, looking a little fidgety and anxious in clinic, says that mom has hypothyroidism. She's a little worried. She's also a little worried about having gained some weight during a period of unemployment and staying at home and being sedentary. She's just joined a new job. She's quite stressed with life in general and looks like a suppressed TSH with a high T4 and a T3 pattern. Now, normally you would have thought that this might be a straightforward hyperthyroidism. But as we agreed, if we see hyperthyroidism, to determine the cause, we would do a uptake scan. And this is what it showed. Absolutely no uptake in the thyroid gland. So what would we need? What are our cautions and what would we need to think about, Dr. Ravi?
The lady under discussion seems to be having, severely stressed and feeling anxious. And she had a period of weight gain and she had felt the need to lose weight. And there was a
thyroxine at home.
yes. So the possibility of thyroxine ingestion has to be considered. Factitious thyrotoxicosis has to be considered. I think the uptake scan kind of concurs with the clinical decision. There is a reduced uptake of both lobes of thyroid as compared to the normal scan. In this particular case, this particular cause comes up. Otherwise, if there is no particular history and there is no tenderness, then other causes like recent iodine exposure or recent amiodarone ingestion and many other causes, any trophoblastic, any struma of ovary in a lady with ovarian tumor, other causes also have to be thought of in such cases.
Excellent. Thank you very much. So,
can I add one more point? Yeah.
Yes, please.
In case of the thyrotoxic here, they won't have a goiter. That is number one.
She didn't
And,
have a goiter.
I'm
yes.
just telling for these the postgraduates, and also the thyroglobulin levels will be very low compared with the other forms of hyperthyroidism.
Yeah.
That's two important things that you must note.
Yeah. So just
In this
to-
particular case, even free T4 or free T3 was noted to be high. That's a bit slightly unusual, but if she has been taking free T3 is also, T3 is available commercially. Maybe her mother was taking bit of both and she had access to both.
Yeah.
That's one possibility.
So just to summarize, antithyroid drugs for Graves' thyrotoxicosis, 12 to 18 months, up to 2 years. If not, then think in terms of definitive management. For nodules, please consider definitive management. I wish we had time to go through the individual drugs and switching, but especially if they have hepatitis, please think in terms of definitive management. We have a couple of questions. Dr. Anvit Saha is asking about the role of CT scan of the orbits. Would you like to take that, Dr. Velayudham?
Yeah. See, the clinical diagnosis of thyroid-associated ophthalmopathy would most often be straightforward, particularly when a patient presents with thyrotoxicosis. But sometimes you may have a patient who has hypothyroid or euthyroid, where you want to look at differential diagnosis. So where in that case, we resort to imaging. But most often, rather than a CT scan, a MRI may be a better option in this case. And the typical finding in an MRI of thyroid-associated ophthalmopathy would be enlargement of the ocular muscles. But the point to be noted is the tendinous insertions are spared. So if the tendons are also involved, then you will look at other options like a pseudo tumor or other infiltrative pathology. So in a typical case with thyroid-associated ophthalmopathy, there is enlargement of the muscle belly with sparing of the tendon, and there is increased intraorbital fat. So rather than a CT, MRI would be better, particularly when a patient, you think of if the patient doesn't have typical features of thyrotoxicosis.
And I think certainly when it goes beyond a no specs 3, rather than us trying to investigate this patient, referral might be the best option. So I have a couple more questions.
Another thing is MRI, whenever there's that you can think of when there is optic nerve compression, that's also very important that you must go into it.
So in the interest of time, the rest of the questions I'll try to answer in the chat box. Thank you very much for all your questions. I would like to express my heartfelt thanks to my panel, Dr. Sundaraman, Dr. Ravi, Dr. Velayudham, and Dr. Jayashree online, and to all my colleagues here. Thank you very much and have a great rest of program. Thank you.
Thank you.
Thank you.
Thank you so much, Usha, for the wonderful panel. We swiftly move on. We've actually had a partial clinical examination skill sessions by Dr. Sriram. I invite Dr. Thomas Paul, Professor of Endocrinology from CMC Vellore, and Dr. Sridhar, Professor of Endocrinology from Madurai Medical College, for chairing the clinical assessment skill session back to medical school. As we have asked Dr. Sriram to speak earlier, we will swiftly move on to the hypogonadal male session. I'd like to invite Dr. Vignesh, consultant endocrinologist from Trichy, to start the first talk.
So, first. Good morning, everyone. As Dr. Muthukumaran mentioned, clinical assessment skills. So now the whole thing of medical curriculum is based on competency-based teaching, learning, assessment, competency based. So it involves 3 segments: cognitive, affective, and psychomotor. So this is very important for the current curriculum. Now, I don't want to waste any more time. I'm just request Dr. Vignesh to go to the topic.
So at the outset, I would thank the Endocrine Society for having given me this opportunity, and thank the chairperson, Thomas Paul sir and Sridhar sir, for chairing this session. So for next 10 minutes, I just recap the basics of how to take history or how to go about the clinical examination, how to interpret your findings to match your clinical diagnosis of hypogonadism, especially male hypogonadism. Just a recap of basics. This is very important, what we call as Tanner's puberty scale. So we have a scale, grade 1 to grade 5, to assess the development of genitalia, it is testes, phallus, and the pubic hair, so that we can grade and that's the child that has entered the puberty or which stage of puberty, whether the child is progressing to puberty or whether it has in a pubertal arrest. So this is very important to know the Tanner's scale and to evaluate the child and to evaluate and follow-up visits to assess the pubertal progression or initiation. And most important thing, this many of the postgraduate may not have seen, this is what we call as archidometer. So while during our MD days, we read theoretically in Harrison, there is an archidometer. We thought like it is like something like a vernier caliper, some kind of thing, but it is not like that. It is like simple Mali kind of thing. So we will have a different volumes of testes. So we see the numbers. It is 1, 2, 3 is given in a different color. This is because less than 4 ml of testis is a pubertal testis, or the child has not entered in the puberty, and at 4 to 15 is peripubertal, and more than 15 or 20 or 25 ml is adult testis. So this is very important tool for a clinical examination, examining a child or an adult with the suspected hypogonadism. So testicular volume has ethnic and racial variation. So this has to be kept in mind. So when we read foreign textbooks, so Indian compared with African, there are, say, the ethnic variations are there. So there are no specific studies for testicular volume in India, though there are studies to have a penile length normogram for Indian data. So generally it is said any testicular volume less than 4 ml is prepubertal, or anything somewhere between 4 to 15 ml is peripubertal, and more than 15 ml is adult volume. So this is very important to diagnose initiation of puberty or pubertal arrest or regression of puberty. And next most important thing, what we learn in our medical school is that upper segment, lower segment ratio, where we measure from the head of the top of the head to the pubic symphysis, and from pubic symphysis to the foot. So normally at both, the ratio would, the trunk will be larger, limbs will be shorter. The ratio would be around 1.7 or 1.6. So the ratio gradually decreases by 10 years. Almost the ratio will be like 1:1, trunk ratio compared to the limbs. Why it is important? So normally because of the estrogen, both male and female, it is the estrogen that is responsible for the maturation of the bones. So when there is an estrogen deficiency in female, or estrogen deficiency because of secondary to testosterone deficiency, the testosterone is converted to the estrogen by aromatase. The testosterone deficiency in male leading to the secondary estrogen deficiency, the segment will be immature. Those adults, those who develop hypogonadism during the childhood, they will have enochoid proportion. That is how they'll have a long limbs, both upper and lower limbs. This is because of progressive, there will be delay in fusion of epiphysis to the metaphysis. So there will be progressive growth. Usually we do this evaluation for Marfan syndrome in clinical medicine. Whenever we suspect long limbs, we evaluate for Marfan syndrome. But remember, my friends, so always do a clinical examination to look for upper segment and lower segment ratio. If it is less than 0.8, it is probably suspect the hypogonadism or as developed before the puberty. Again, the arm span. Normally, we expect arm span almost just 1 or 2 centimeter more than the height. But in an adult where the arm span is more than 3 centimeter or 5 centimeter than the height, probably there is a progressive enlargement of the limbs. So it could be due to pathological component, what we call as hypogonadism. So this is a basic pathophysiology why these hypogonadal men develop unicoid status. This is because of normally the androgens are converted to estrogen by the enzyme called aromatase, which is present in the fat. So the estrogen is responsible for the maturation of the bone. So the epiphysis fuses with the metaphysis. There will not be any further elongation. So what happens when there is a decrease in the androgen? So there will be a secondary decrease, lack of estrogen. So the bones keep on elongating. So there will be a constant linear growth for a long period of time, even more than 18 years or 20 years. So they will develop unicoid proportions. That's what we have described in the last few slides. So when do you call a delayed puberty? So very often to an endocrinologist, very often in clinical medicine, we do get referral from our friends, 10-year boy, they do the testosterone level in the morning and they refer for a low testosterone level. So when do you call, that is why it is important to address when do you call the puberty is delayed? When do you call the testosterone is low? So there are criteria. In girls, they have not shown any signs of puberty by 13 years. In boys, they have not shown any signs of puberty by 14 years, where we call as delayed puberty. In girls, the first sign of puberty is increase in the height spurt followed by telarchy. In boys, the first sign of puberty is the enlargement of the testes. That's why we need an orchidometer. So if you find a boy who is referred for a delayed puberty, who may be around 10 years or 15 years or 15 years, if there is a testicular enlargement more than 4 ml, so definitely we don't call it as a delayed puberty. So he has entered into the puberty. That's why the clinical examination is important. That's why the orchidometer is important. And most important thing, many times they do an ultrasound. They do have a total ultrasound report where they report a testicular volume of 1 ml, 2 ml. I do personally find the ultrasound is not a good investigation to evaluate a testicular volume, because there are many criteria, there are many formulas to evaluate testicular volume, and many times it is underreported. Testicular volume we see clinically by orchidometer as 8 ml or 10 ml, but they report as 3 ml or 4 ml. So I personally feel we should have an orchidometer to evaluate and not go by simple ultrasound findings. Just a definition of hypogonadism. So hypogonadism, it is inadequate gonadal function. It can manifest as deficiency in gametocytosis, gametogenesis, that is that can present as infertility in men, or it can manifest with decrease in gonadal hormones. So if it occurs before puberty, definitely the testicular size will be small, phallus will be small, prostate may be hypertrophic, hypoplastic, and there may be scant pubic and axillary hair and unicoid proportion, and most important thing, they can have gynecomastia, and the boys breakup will not happen, so they will have a high pitched voice. So but if a hypogonadism occurs after the puberty, so the proportions will be maintained, they won't have unicoid proportions. Only thing they manifest, the signs are subtle. They can manifest with the sexual dysfunction, or they can manifest with the infertility kind of thing. So that's why it is important to assess them clinically before we make a diagnosis. So there are just a brief recap of basics. So we do classify hypogonadism as primary, secondary, and target organ resistance. So primary, what we call as hypergonadotrophic hypogonadism, where the FSH-LH will be high and testosterone will be low. Secondary hypogonadism, what we call as hypogonadotrophic hypogonadism, where there will be FSH-LH will be low. So this is just a recap of basics. So primary, FSH-LH high, testosterone low. Secondary, FSH-LH and testosterone, everything will be low. And it can be mixed or it can be compensated one. So when we look at the causes, so why it is important to some extent we can clinically decide, to come to a diagnosis whether what type of hypogonadism the patient is suffering. So it can be a primary. I'll just go through in detail in the next further slides. So if it is a hypogonadotrophic hypogonadism, the most common cause, it can be idiopathic or a Kallmann syndrome. So in which there will be low FSH-LH. So there will have various phenotypes. The most important thing is we need to assess a olfactory function. They may have a anosmia or hyponasmia. They may not be aware until we examine. They said, I can able to perceive smell, but unless we examine the smell, they may not be identified till the lifetime. So this is a clinical. So once we diagnose the patient as anosmia, the diagnosis is straightforward. You can directly do a gonadotropin, and if it is low, then you can, if at all, if it's affordable, they can go for an MRI to make a diagnosis. So, so it is a simple bedside examination. Patient present with hypogonadism, assess the smell. If it is if there is anosmia, the diagnosis is straightforward. And other symptoms include they can have nystagmus, they can have bimanual synkinesia of the limbs, or they can have eye movement or retinal abnormalities or renal abnormalities or cleft palate. All these cleft palate, this is because of the other transcription factor deficiencies can happen. So this patient who present with the hypogonadism, he has absence of smell. When we did an MRI where we find there is hypoplasia of olfactory bulb, we confirm the diagnosis. We started the patient on testosterone therapy. He is doing well. So one most important thing, so when we diagnose hypogonadism, there is a close mimicker. Always there we should, many a times when a child or adult referred for a hypogonadism, most of the time we find it is not a hypogonadism. Either it is a differential, close differential diagnosis kind of condition, that is what we call as constitutional delay. It is called a physiological or some kind of physiological delay in growth and puberty, where the child may be short for age, and where there won't be any malformation, like there won't be any anosmia or any facial or skeletal malformation, but especially they will have a family history. This is a typical child who presented with delayed puberty, referred for evaluation of hypogonadism, where we find the height was on the lower side of normal, that is at the 5th centile. And just we follow we just reassured the parents. We didn't do any even testosterone level. Just we did a bone age, and we followed them. So the bone age was delayed. So it is not corresponding to the chronological age. The bone age is delayed because there is a delay in maturation of the axis, and this child need not be treated with testosterone. Just reassure them. If at all, if they have parents have an anxiety or apprehension about the condition of the child, they can be given a short-term 3 or 4 courses of low-dose testosterone for a while. There is no need for a hurrying in therapy. Most important crucial thing, the CDGP, what we call as constitutional delay in growth and puberty, is the most common referral for a short child with hypogonadism rather than Kalman syndrome. So we should always keep it in mind. So do a growth chart, plot it, look for the growth velocity. Then we decide. This is the most important clinical assessment tool for a child who presents with short stature or some delayed puberty. So other conditions like hypogonadism is Prader-Willi syndrome. Usually the child present for obesity and short stature rather than for hypogonadism. They come for a progressive obesity or a round faces.
3 more minutes, please.
Yes, sir. Usually they'll have poor tone, short stature, hyperphagia, and obesity, and they will have this thing, movement abnormalities. The next condition would be hypopituitarism. So anything that can be a space-occupying lesion at the pituitary or a hyperprolactinemia of any cause, they can present with hypogonadism. So it can be a genetic cause for hypogonadism. So this is a child with who present with short stature and hypogonadism, multiple pituitary hormone deficiency, where we see a frontal bossing and mid-facial hypoglycemia, since there is a depressed nasal bridge, which you could not make out, and since I have covered it, there is a frontal basing. When we evaluate, the growth hormone was low, testosterone was low, cortisol was low, multiple pituitary hormone deficiency. This is a very clinical clue. The short stature with the hypogonadism, always think about this condition also. Hyperprolactinemia by any cause, especially when there is a severe hyperprolactinemia by prolactinoma, which can present with the short stature and hypogonadism. The testicular causes, the most common would be Klinefelter syndrome. Other testicular causes include a previous history of hypocardism or undescended testis surgery, that is orchidopexy, or a varicocele can present with hypogonadism, or a previous history of viral arthritis, mumps, or a trauma to the testes, radiation to the testes for a seminoma or a lymphoma, or granulomatous diseases that can lead to hypogonadism. This is a child, the Klinefelter syndrome is a very most common congenital abnormality, congenital form of male hypogonadism. It is 1 in 500. The chromosome pattern will be 46XXY. Usually unnoticed in childhood, they present only in the adolescent or adult group. They will have a pubertal arrest, unicoid proportion, all absent body hairs, gynecomastia, small testes. They can have a genital abnormality and learning abnormality and behavioral changes. This is one of the child who present for micropenis and small size of testes, absent pubic hair with the Klinefelter syndrome. This is another adolescent boy, 18 years, who present with gynecomastia for evaluation. Later on, after evaluation, we found it the karyotype was 46XXY, low testosterone, high gonadotropin. So we made a diagnosis of Klinefelter syndrome and started. Actually, this patient was referred by a surgeon. They were planning for a surgery for gynecomastia. So we started them on, we made a diagnosis of Klinefelter syndrome. We started him on testosterone therapy. So then less common causes will be androgen insensitive syndrome. Usually they will have a different pattern of ambiguous genital. There can be female genitalia. So finishing, sir. Last slide. So there are less, and most important thing, there can be hypogonadism due to chronic diseases like chronic kidney disease or epilepsy or GI diseases. This is a child with nephrotic syndrome on steroid therapy who present with hypogonadism. Hemochromatosis can present with hypogonadism, or obesity, again in adults, can present with the functional hypogonadism. So this has to be kept in mind. So most important take-home message would be clinical assessment is very important in evaluating a hypogonadism or a delayed puberty. So it is very helpful, very important to differentiate a physiological conducting CGP or a physiological gynecomastia from pathological one. And it is also important to assess the other syndromic manifestations of hypogonadism like anosmia. And it is also important to predict the response to therapy. For example, who has a testicular volume of less than 4 ml, the response to gonadotropin will be less. The testicular volume is important for predict the response of therapy and assess the response to therapy. Some form of idiopathic hypogonadism is reversible. So you always examine the testes every year to look for testicular enlargement. So take-home message is a clinical examination plays a role, not only diagnosis of hypogonadism, it also plays a role in predicting the response and treatment to the therapy. Thank you for your patient hearing.
Thank you, Dr. Vignesh, for your elaborate discussion. Since hypogonadism is a systemic disease and it is a spectrum of manifestations from newborn to childhood to adolescence and even adult life. And he has highlighted about the various clinical examinations, including in additions to the secondary sexual characters and as well as the various systemic manifestations, as well as the broader archidometer like prepubertal or postpubertal onset of hypogonadisms, and what investigations to order. For that, you need an exact clinical diagnosis. Then only we can able to pinpoint the exact investigation. So the clinical examinations is paramount importance in any cases of male hypogonadisms, and hope he has done a good job. Thank you, Dr. Vignesh.
Thank you, sir.
So I request Dr. Vignesh to answer the questions on the chat box for the want of time. There's a chat.
Okay, I can answer.
One question is, please.
System it will be. We can take only one question. A 28-year-old 20 milligram of. Oh, I think no questions is there for this topic. We will move to the next session.
It is my privilege to introduce Dr. Shruti Chandrasekharan, and she's a senior endocrinologist from Chennai, and she has got brilliant academic background, and what she's practicing, she's going to tell with regards to polycystic ovarian syndrome with relation to competency-based learning.
Thank you, sir.
Dr.
Respected chairperson and my dear audience, a very good morning. So I will take about 15 minutes of your time this morning to talk on the clinical examination in PCOS and how do we examine our patients. Before we go into the clinical examination in polycystic ovarian syndrome, I will also tell you why it is important for us to, do what we are doing in our practice right now. So I have no conflict of interest for this talk this morning. So what is the most common endocrinopathy in women of reproductive age? So the options are listed there, A, B, C, D, E, F. And I know we're not taking poll questions here, but this is important for us to understand that we are talking here this morning on PCOS because it's the common endocrinopathy in reproductive age group. 5 to 10% of our female population present to us with PCOS. And we heard Dr. Geeta presenting on the fertility aspect of PCOS this morning, and it goes about 15 to 20%. I'll reiterate the point, most common endocrine disorder in women group, and it is important for clinicians to have a good clinical knowledge and examination skill when we talk about examining our PCOS women. So there is no universally accepted definition for PCOS, even though there are a number of criteria for the diagnosis of PCOS in terms of 1990 NIH consensus. I'm not going to read out this slide to you, right? You can choose any one of these guidelines in your practice and use this in your practice. But what is important to all the 3 guidelines that we currently have in our practice is it should not be attributed to any other causes. That is true with NIH. That's true with the Rotterdam criteria and also the Androgen Excess Society. So PCOS is a diagnosis of exclusion, and we need to be very, very careful before we label our patients, especially in the adolescent and even the pre-pubertal age group. So again, excludes women with other known causes of hyperandrogenism is a diagnosis of exclusion. So thus coming to the morning discussion of why a good history taking and clinical examination is of utmost importance when we see women with PCOS. When we talk about PCOS in the history taking aspect, I think what I've heard is a family history is very important, even though it's a complex genetic trait, right? But if you actually get a detailed family history, you will probably hear either the mother or the grandmother having some menstrual irregularities or even diabetes or other features of insulin resistance. So the precise mode of inheritance is still uncertain, but you should get a good detailed family history to see what the pattern of inheritance is, which was not very clear yet. They might have one or more symptoms of PCOS that can run in the family, and it's also been shown in twin studies. So the second clinical history question is what defines irregular menses? So that is also very important from the history taking aspect of PCOS. Irregular menses is something that is defined as anything that is less than 21 days or more than 35 days, right? So that has to be important in our clinical history taking. And 75% of our patients will have clinically evident menstrual dysfunction, which means majority of our patients could present to us with eumenorrhea. And this would further, give us clinical clue of whether, we talked about being at an anovulatory cycle, risk of endometrial hyperplasia, what about the chance of fertility, etc. Right? So it is important to get a detailed menstrual dysfunction in PCOS. And this is very important in adolescent age group because we know in those age groups, the periods can be irregular and we need to actually get a good menstrual history in a PCOS women. And the beauty of PCOS is the clinical symptoms that the patients complain could also be the clinical sign that we would elicit as a clinician, right? So the patients would give us these complaints when they see us. So the common thing that we see are the hirsutism that tops the list, acanthosis, acne, which I'll talk briefly in the next few slides, seborrhea, male pattern balding, the increased muscle mass, deepening voice, clitoromegaly could indicate that that's something more other than PCOS, probably a non-classic CAH or other causes of excess androgen. These are the clinical signs that the patients could also complain. When we talk about hirsutism, it can be the only presenting complaint for patients and the families, and psychologically a very, very disturbing pattern. How do we do in clinical assessment? We can do a Ferryman-Galloway score, but it might be a bit of a challenge depending on the skin color that we see in our patients. But you could categorize them as 1, 2, 3, 4, depending on the distribution of air, and you can probably note it down in a piece of sheet or what is the scoring system. And this is from the Indian data. If you look at the Western data for Caucasians, when we were in training, any score that's more than 8, we would think of androgen excess. We do the scoring system 0. Some scale has even 0 to 4. Some Ferryman-Galloway score also has extended body parts that you can take into for accounting for the calculation for the hirsutism. But if you look at the Indian data, which was published in IJEM, modified Ferryman-Galloway score of more than 6 to 8 in an Indian population could signify a hirsutism. So for the postgraduate students, you can actually have this printed in your clinic, and you can just put a small tick mark when we examine our patients. And it is important to examine our patients without their gown. Preferably, you have to examine them thoroughly, not a very superficial examination. So that's important take-home message. And then a normal amount of hair can be between less to 2 to 3. That can be reassured. And significant proportion of the patient, even with a scoring of 2 to 6, can have an androgen excess. When they talk about androgen excess in this paper, it's predominantly PCOS. So in clinical examination assessment for hirsutism, which can be psychologically very, very disturbing for the family and the patients, Ferryman-Galloway score, which actually was first used in the year 1961, right? So it's important for us to calculate the scoring system. And then comes the acanthosis. So we need to examine, and this is probably also something that we pick up easily when we actually getting the history, just talking to the patients, we could actually see the acanthosis even without examining them. So this is like a spotter. It's a velvet, mossy, hyperpigmented skin disorder. It's a sign of insulin resistance. Usually we see it on the neck and intertriginous areas such as upper thigh and the axilla are involved. The pathology is hyperkeratosis and papillomatosis. So one important point here is this. A lot of our patients self-check their fasting insulin level from their labs because they have PCOS, lab profile that are available, which I'm not going to be talking today this morning. The acanthosis correlates with the magnitude of peripheral insulin resistance and less with the hyperinsulinemia that we see on the blood test. The fasting insulin levels could still be normal and we could still pick up acanthosis on the clinical examination. So the point here is trust your clinical examination skill, and that's more important. And the mechanism is not very clear. There are multiple growth factors that are involved with this. Acne, right? So acne is another clinical symptom and a sign that we can pick up in our exam. And it's seen about 15 to 25% of our patients with PCOS. Primarily, it affects the face, especially the jaw area, the jaw line area, and less often on the back and the chest. And this has been shown. And usually very cystic acne. Patients are very troubled by their facial appearance because the acne is very cystic, and some of my adolescent and even women with acne also complain of painful cystic acne and that's also quite resistant to the treatment. And that's where the dermatologist would need the help of an endocrinologist for hormone assessment and lifestyle modification to get this better. So acne is something that we should look for, and also the patients would complain. And androgenic alopecia, right? So this is a common thing. Women with the frontal hairline, usually if you look at the male, androgenic alopecia can happen in men and women. So in men, it's mostly the frontal area, but in women, it's mostly the central area that is affected. So usually the partition that we do in our hair, that's where the hair loss happens. So it's typically spared with diffuse hair loss at the crown and the top of the head, and it's often marked in the white central part. So this you can see in women, even when we don't have to really examine. This is all something that we can pick up when we can actually talking to our patients and getting the history from our patients. So what I learned is the androgenic alopecia is a marker for cardiovascular disease, right? So of course it's cosmetically concerned for the family, but when I see androgenic alopecia, I evaluate them more closely for a metabolic derangement for PCOS, because the androgenic alopecia that has happened or reported in women has shown to increase the risk for heart disease, diabetes, abnormal lipids, obesity, and infertility. So that is a clinically important clue, not just from the cosmetic perspective, but also from the metabolic perspective. There's also modest risk of colon cancer and kidney stones have also been reported. And in men also, the prostate cancer has been reported, but we're not talking about men today. But mostly in women, when we see androgenic alopecia, always think about metabolic, always screen for the metabolic parameters. Seborrhea is something that we see in PCOS as well, and I've had a couple of patients who I refer to my dermatology colleagues for this. The other signs in terms of increased muscle mass, well, muscle tone, voice change, deepening of voice, clitoromegaly. These are not very, very common in PCOS, but we should think of other causes for androgen excess. So we did talk about all these things. We talked about acne. I didn't focus specifically on the weight today, but that's a common complaint that we get from our patients: acanthosis, hirsutism, ovulatory dysfunction in terms of irregular menstrual cycle, infertility, and androgenic alopecia. So these are the common clinical manifestations that we would come across as clinicians or postgraduate students when you see your patients. But there are also metabolic manifestations. I would not have time to talk about this in detail, but we should also think about diabetes, the way diabetes presents, and screen them for diabetes, cardiovascular disease. Depression can be the presenting feature for many of our PCOS women. I had a patient who just had PCOS and depression because she had 3 failed IVF attempts. Her periods were okay, fairly okay skin. Her skin was not bothering her. In PCOS, we treat the problem that is, troubling the patient the most. So in that patient, I would only have to address the depression. So always when we talk, I have to get this subtle clue from the patients on how they are sleeping and how their day-to-day activity is and how much they are interested in day-to-day activities. So screen for depression, obstructive sleep apnea, fatty liver, and also the risk of malignancy goes up in terms of endometrial cancer and breast cancer. So these have to be screened as well. In the interest of time, I'm not going to be talking on this in detail. And as I told you, the other diagnosis of exclusions are non-classic CAH, when we have very pronounced androgen excess, Cushing's, growth hormone excess, when you have severe acanthosis, skin tags, carpal tunnel syndrome, obstructive sleep apnea. Always think about growth hormone excess and screen them for that. A very acute presentation, hirsutism that starts very quickly and rapidly progresses, and a very deepened voice, should think about androgen and ovarian tumors, genetic effects of insulin action. Primary ovarian failure, hyperprolactinemia, thyroid disorders are common reasons for menstrual irregularities. So these have to be ruled out. Again, this is something that we would pick up when we talk to our patients in presentation. With this, I finish, and I thank the organizers for Enrich for giving me this opportunity. Thank you very much.
Thank you very much, Shruti. You finished in time, and it was right. It was an excellent overview of the presentation, especially from trainee point of view. My senior colleagues will agree here that you presented very nicely with illustrations. So I think, with the permission of Dr. Sridhar, my co-chair, can I ask you, do you want to give one message on obesity and association with the PCOS, or normal weight obesity and we do see PCOS? Can you tell obesity association PCOS? And sometimes we say people may not be obese, still they will be having PCOS.
The obese PCOS is common, but as Dr. Paul said, we also see patients who have thin PCOS or thin phenotype PCOS. I think what is important is, in at least from the history taking, a woman could be 45 kilos when she get married, which is absolutely normal. She could have gained 5 to 6 kilos, which is still normal, 51 to 52. Her BMI would still be normal. And that's change in the weight that happens after marriage, or even with the COVID pandemic where a lot of women gained weight, that could tip off the cycle, that could change the hormone axis. So you don't have to really be obese. I think from the history, any changes or even changes in the sleep pattern, I would say, can change the hormones and cause insulin resistance and the cascade of events that happens down, causing menstrual irregularities and other features of PCOS. So it is common in obese patients, but nevertheless, any change in the life event can also trigger this.
Can I request you, I'm not able to read out one thing, any question on the chat box?
The question that has been put here is on a 13-year-old girl who has a growth hormone deficiency. I think I would say that we can address that during the growth hormone session. We have stimulation tests in the afternoon. Sir, if you would stay for the session, that question will be addressed at that point of time. Thank you very much.
Sir, Dr. Sundaram, sir.
It was really nice that you have categorical that clinical evaluation is very important. I just want to add that a lot of prepubertal girls come with acanthos nigricans. That is an important pointer that we must go. And also they present with delayed menarche. In fact, they're not primary amenorrhea, but they have delayed menarche. These two important associations I found in PCOS, and it's a spectrum disease where you have an unexplained infertility on one end, a florid signs of PCOS.
I absolutely agree, sir. I didn't talk about the pubertal part of it all in the interest of time. As sir said, in pre-pubertal also the PCOS can present with delayed cycle and acanthosis, which you are seeing with an increased rise in pediatric obesity now.
Thank you, Dr. Shruti. Wonderful lecture.
Thank you. Thank you.
Thank you, sir.
Thank you so much, Dr. Shruti. That was a wonderful presentation. I'd like to thank the previous speakers, Dr. Vignesh and Dr. Sriram, for a fantastic morning session. Our next thing is we are going to move on to our grand round session, where we have got two teams who will tell us how to approach an important case. And first, we request the CMC team to teach us how to address a 40-year-old male with severe hypertension. We have got Dr. Thomas Paul on the stage, and I invite Dr. Nitin Kapoor to join the session.
Dr. Nitin will take over the session, and our postgraduate also will be there online. Over to you, Dr. Nitin.
Sure. Thank you, sir, and a warm welcome and good morning to one and all. We're going to present over the next 30 minutes a case of a 40-year-old male patient who's presented with severe hypertension. The case will be presented by our second-year resident, Dr. Anis Joseph, who's online right now. I request Dr. Anis to start the presentation.
Good morning, everyone. Presenting a case of 41-year-old gentleman, the eldest of 3 siblings, presented with 4 months history of recurrent episodes of palpitation, flushing, and headache. One such episode was associated with severe giddiness and vomiting, for which he was taken to a local hospital and was found to have a very high blood pressure of 190/120 millimeter of mercury. The patient was admitted for 2 weeks, and despite being on 3 antihypertensive, his blood pressure was difficult to control.
So the question here is a 40 or 41-year-old gentleman with severe hypertension as a presentation and some symptoms of catecholamine exist. But when you talk about hypertension young, it varies across the age. Like, for example, if you take somebody, with children especially, we have to think more of a renal cause, because it can be the primary renal parenchymal disease as a cause. As you grow, when you come across the different age groups as given in this table, we will be thinking of course, always there is an essential hypertension will be there, but we have to rule out secondary hypertension in the form of renal as well as endocrine as in form. We'll come to that little later, like adrenal causes, like adrenal cortical problem, adrenal medullary problem. Adrenal cortical itself, we have a Cushing's, we have Conn syndrome, that is hyperaldosteronism, then pheochromocytoma, and the other causes like genetic causes also there.
So taking the discussion further, when we look at the history, so in the clinic, when we have a patient with young hypertension, the key presenting complaints the patient will bring to us. But then what are the other points in history that we have to ask? If I may say, we can divide the history in 3 broad domains. We can divide the history with respect to the impact of hypertension itself. And the most common symptom because of hypertension patients will come to us is with headache and visual blurring. We'll want to assess on history the end organ damage because of hypertension, which could be either a cerebrovascular or cardiovascular event if has happened. And we also want to know the etiology. And this gentleman, we've got very clear history of palpitations, but in other causes, we have to find out other history like proximal muscle weakness or any kind of periodic paralysis that may have happened. So all of these three different domains of history need to be assessed. Another very important component of history is family history, especially in younger patients. And if you have to assess the family history, you have to not only go to the same generation, but the generation above. The history of onset of hypertension in them is important. In this particular case, the father had died because of having a hypertensive crisis because of an unknown abdominal tumor. That's all the history that the patient had.
Coming to the clinical examination, at presentation, he had a blood pressure of 150/100 millimeter of mercury, despite being on 3 antihypertensives. All peripheral pulses were well felt, and there were no abdominal bruit or mass per abdomen. There was no evidence of hypertensive changes in the retina, and he had normal systemic examination. So in summary, this is a young patient with very high blood pressure on multiple antihypertensives. So a secondary cause need to be ruled out.
So we have a severe hypertension in an young individual, as Dr. Anish pointed out. What are the investigations we have to do? So broadly, we divide into bloods, urine, imaging, which includes structural like CT scan, MRI, and renal Doppler to look at a renal artery, and functional scans like MIBG, especially for adrenal, catecholamine secreting tumors, PET scan, especially FDG or DOTA PET scan. When you talk about blood biochemistry, electrolytes, creatinine, urea, and hormones like cortisol, renin, aldosterone, and we can also measure metabolites there. And urine, especially if a young person, like child, then we want to see what is the sediment. There is any cast is there, renal, no, looking at the hematuria, then looking at a protein, then once again, hormones like cortisol, we look into that. And we also look at the metabolism of the metabolites of catecholamines like metanephrine, normetanephrine. And finally, we have to look at the end organ damage, looking at the electrocardiogram and echo and other things we have to look at for the comprehensive evaluation of the hypertension in a young individual.
So on evaluation, he was found to have an elevated urine normetanephrine level, 3,540 microgram in 24-hour urine collection, normal being less than 600 microgram per deciliter. His urine metanephrines were normal. His other biochemical parameters were within normal limits.
Right. So whenever we have these urine investigations that we have, like in this case, I think even before we look at the lab, before we look at the assay, the pre-analytical stuff needs to be looked at, and the collection of urine, even a very simple thing, like whether the 24-hour urine is actually 24 hours, what is the urine volume? I think these are important points we need to look at. But once we have all these things in place, and if we have to interpret a 24-hour urine metanephrine, and this was a study done by Dr. Kanakmani from Vellore, couple of years ago, and we looked at the utility of using urine metanephrines and non-metanephrines, and a cutoff twice the upper limit of normal of our lab was found to have fairly good sensitivity and specificity. We know that a few centers in India do use plasma metanephrines. Yes, the sensitivity is higher. So in those cases, whenever the index of suspicion is very high, yes, those tests may also be used. We in Vellore use urine metanephrines. So what next? So we've got a young gentleman who's got classic symptoms of palpitations, headache, flushing, and then the investigations show that the urine metanephrines are high. I think next we need to go on to structural imaging. We've proven a biochemical diagnosis of an underlying paraganglioma or a pheochromocytoma, and then we did a CT scan, a CT angiogram.
So his CT scan showed a large 8x5 centimeter lesion on the right adrenal, but this was it was just not one lesion. On the other side, there were 2 more lesions on the left side.
So this is an important question. This is a functional scan for unique for catecholamine secreting tumor, meta-iodobenzyl scan. And when patient is young, as in this case, there are multiple lesions, You want to see what are the, sometimes you may miss out structurally. Sometimes you will have a discordance. Patient will have a typical symptoms. Biochemistry may not tell us. Still, you may be clinical suspicion is high for catecholamine secreting tumors like PO and paraganglioma. Then we will order this MIBG scan. In other setting, like when somebody has got metastasis, then we will go for the PET scan, like a DOTA PET scan or FDG PET scan.
This is his MIBG scan. As you can see, there is large uptake on the right side, and also there are uptake on the left side as well.
Right. So now that we've proven by biochemical testing, we've proven by structural imaging, we've got functional imaging, and everything has pointed out that this patient has an adrenal lesion as well as 2 extra adrenal lesions. But what is the role of genetic testing in our setting? When do we do it? And what's the prevalence of genetic disorders that we see, especially when you're discussing a patient with hypertension in young? When we look at data from our own center, and this is a paper that was presented by Dr. Nayak way back in 2015 in Edinburgh in UK, where data of 180 patients with paraganglioma was presented. Amongst the patients who underwent a genetic test, about a third of them have an underlying genetic cause. And the most common mutation that we found in our setting, and that's also what is globally reported, it was the VHL gene. So when do we do a genetic test? For all the postgraduates who are listening to us, I think it's important to know that whenever we have clinical findings to suggest a syndromic disorder, and the common syndromes that we talk about when we talk of pheochromocytoma or paraganglioma as VHL, is MEN2 syndrome, we talk of the SDH mutations commonly, and the neurofibromatosis type 1. So if these other associations, clinical associations are present, we definitely would like to do genetic testing. We commonly do genetic testing for bilateral tumors, but we also may consider to do it in unilateral tumors, especially if there is a young onset of hypertension or if there is a family history of having such tumors. And in paragangliomas, again, the suspicion of doing a genetic test is important.
In our patient, we did Sanger sequencing, and we found that previously described SDHT mutation, which was a frame shift deletion in exon 4.
So coming to after history examination, then some diagnosis, evaluation, finally we are coming to preparation, because ultimately patient is going to need surgery. So important point, there is some paradox here. Usually hypertension, no salt. Here we have to give more salt. 2, sometimes where there is a cardiac dysfunction, we'll say no, but generally fluid restriction. Here we have to give more fluid, more salt, more fluid, because it is a volume constricted state. So in preparation may 7 to 10 days, and we will start alpha blockers, either prazosin, doxazosin, or very potent phenoxybenzamide. And one important thing we all know from medical school, that we shouldn't start beta blocker. It can be a problem because you get a crisis, Dale's motor reversal phenomena. So patient can get into problem. So this preparation, recently there is a study from Mumbai saying even you can use calcium channel blocker like amlodipine to prepare this patient. So fluid, salt, alpha blocker. Then later you add beta blocker.
In our patient, he was planned for a surgery for managing his abdominal tumors. After adequate blood pressure control and preoperative preparation, he was taken up for a laparotomy and the lesion was excised. Histopathology confirmed the diagnosis of right adrenal pheochromocytoma, and the other 2 lesions were paragangliomas. So this is his intraoperative picture. As you can see, a large tumor being excised during the surgery. And his histopathology. On the right side, it's the histopathological feature is also known as cell Bolen appearance. This is a group of spindle-shaped cells are arranged in nest. That appearance is known as cell and Bolen appearance. On the left side, this is immunohistochemical staining, which is showing chromogranin positivity. So post-operatively, he was off antihypertensive drugs and had maintained a normal blood pressure. His urine metanephrine and normetanephrines were found to be normal.
So moving on to the next question, which is about what about if the blood pressure does not come back to normal? And I think, again, preoperative counseling, again, a very important role of the physician, that if the blood pressure has been high for a very long time, it's important to counsel the patient that there may be vascular changes, there may be renal changes, parenchymal changes that may have set in, which may not let the blood pressure set back to normal. So we may be able to reduce some antihypertensive drugs, but we are definitely going to prevent further progression of the disease, and that's important. Yes, at times, if there is a complication during surgery, if there's a rare possibility of a ligation of one of the renal arteries, or if there is a residual lesion, the blood pressure may not come back to normal. But it's most often because of many times long-standing undetected secondary cause of hypertension that we may have blood pressure not coming back to normal. So what should be the follow-up plan for a patient? And the protocol that we follow at Vellore is that after surgery, we call back all our patients for review at 3 months. We do a biochemical testing at that time. We don't do imaging if the biochemistry is normal, and thereafter a yearly follow-up. I think that is also very important. We've had patients who come back to us after 5 years, some even after 10 years with a recurrence of a lesion. So I think long-term follow-up is important in these patients.
So coming to the key learning points from our case, this is a young patient requiring multiple antihypertensives, secondary cause to be ruled out. The choice of antihypertensives in young patients to be carefully selected. Genetic testing is helpful in identifying syndromic association, clinical progression, and familial screening. The role of MIBG, functional imaging, is still needed in some patients. Pheochromocytoma, if identified, surgical removal has more benefits than just for blood pressure control.
So the key point is, yes, we keep our eyes open for secondary hypertension when we have young patients, and we treat the cause, because many times that treatment is very gratifying. We'll stop here, but I believe there are a lot of questions in the chat box, and we can take those questions. No, these are answers to the previous questions. So if there are any questions from anybody in the audience or anybody here, I'd be happy to take. No questions.
Thank you, Dr. Nitin. Thank you, Dr. Anish. So first grand round problem solving has been completed. Now the next one will be from
JIPMER team, and I request Dr. Satish.
Dr. Satish and team to come over stage to have the presentation. This presentation is on a 60-year-old lady with a sodium of 124 milliequivalent per liter. Over to you, Dr. Satish.
Good morning, ladies and gentlemen. We have been given to analyze this case of a 60-year-old lady with sodium of 124. So we have prepared a case scenario based upon that, and our resident Dr. Varun will present the case scenario, and we will move forward with the management of that case as we go on. Yeah. First, Dr. Varun will present the case, and we will see the management of the case as we go on.
Good morning, all. So the second case for the clinical grand rounds, she is a 60-year-old lady. She was brought to emergency services with chief complaint of altered sensorium for 4 days duration. For the preceding 2 weeks before this current presentation, there was a history of malaise and forgetfulness. And on the day of presentation, she was taken to a local hospital, and some IV fluids were given, following which she had an episode of seizure. There was no history of fever or preceding headache prior to this presentation. And there was no history of nausea, vomiting, or any diuretic usage. And there was no history of decreased urine output. She was a known diabetic and hypertensive for past 10 years, and she was compliant to medication. According to the history, it was well controlled. She had a history of ischemic stroke 5 years back, and she was on aspirin for that. There was no other medication intake according to the history. And on examination, she was conscious. She was not oriented to time, place, and person. She was weighing around 50 kgs. The pulse rate was 86 per minute, and the blood pressure was 118/86 millimeters of mercury in right arm in supine position. There was no pallor, icterus, sinusoidal clubbing. There was no pedal edema, and the tongue was moist. On examination of central nervous system, she was not oriented to time, place, and person. There were on examination, there were no appreciable meningeal signs, and there was no appreciable cranial palsy or motor deficit. And the cardiovascular system examination was normal, and jugular venous pressure was also normal. The examination of respiratory system and gastrointestinal system was unremarkable. To summarize, this 60-year-old lady who was a known case of type 2 diabetes mellitus, hypertension with a past history of cerebrovascular accident, now presented with altered sensorium for 4 days, and then one episode of seizure, which was probably precipitated by intravenous fluids without any obvious pointers towards CNS infection. So the possible etiology could be metabolic encephalopathy.
So this is a garden variety case of metabolic encephalopathy which presents to emergency, and we allow to have a particular management plan so that we reach the etiology. So first we'll have to have a baseline plan out of which we get the clues out of it and move on. So what will be our management plan based on this?
So in a patient who presents with hyponatremia, the first step in hyponatremia evaluation is serum osmolality. Is to assess the tonicity, and the measurement of osmolality can be done in direct method or indirect method. Indirect method is the calculated osmolality, which is calculated using this formula of 2 into serum sodium plus glucose by 18 plus blood urea nitrogen by 2.8. However, the more exact version is direct method, which is freezing point depression method. And the difference between direct method and indirect method is osmolar gap, which suggests additional osmolytes.
So how else can you classify hyponatremia and how to take it forward?
So depending upon this serum osmolality, the normal serum osmolality, it is 275 to 295 milliosmol per kg. In a patient of hyponatremia, if the serum osmolality is in normal range, then we have to think of pseudo-hyponatremia, which is laboratory error, which occurs because of either paraproteinemia or hyperlipidemia. And in case the osmolality is more than 295, we have to think of hypertonic hyponatremia, wherein the causes are because of additional osmolytes like hyperglycemia or other additional osmolytes. And if the serum osmolality is less than 275, then we have to think of hypotonic hyponatremia, and the causes will vary depending upon the volumic status of the patient.
So can you further explain on the different
Yeah.
types, especially isotonic and hypertonic?
So first coming to hypertonic hyponatremia, in hypertonic hyponatremia, the serum osmolality is more than 295, and it is a result of additional osmolates like glucose, mannitol, glycerol, sucrose, etc. And of these scenarios, the more commonly seen one is the hyperglycemia-induced hyponatremia, wherein the correction that we can take is for each 100 milligram per deciliter of increase in glucose, we can take a correction factor of 1.6 milliequivalent per liter. When the blood glucose is even higher, say more than 400, a different correction factor of 2.4 milliequivalent per liter was recently proposed. And an elevated osmolar gap gives a clue about the presence of additional osmotically active substances.
So what is osmolar gap?
So osmolar gap is the difference between the calculated and the direct osmolarity. Usually it is less than 10. If it is more than 10, then we have to think of additional osmotically active substances, and the cause for it is most probably the cause will be hypertonic hyponatremia.
Further, you can explain on isotonic hyponatremia.
So the isotonic hyponatremia, also called as spurious or pseudohyponatremia, it is seen only with the indirect measurement of measurements for sodium measurement. Seen in case of severe hypertriglyceridemia or paraproteinemia, it is as a result of an increased solid fraction of the serum. And in most of the standard centers, now we are using ion-specific electrodes. So such presence of such artifact is somewhat rarer.
So now that you have ruled out isotonic and hypertonic, what we have is the hypotonic hyponatremia. Hypertonic hyponatremia is the commonest cause of hyponatremia, and we have to analyze it in particular in a much more detailed way. Can you go about the analysis?
So hypertonic hyponatremia is the most common of these causes of hyponatremia. So the causes of hypertonic hyponatremia depends upon the volemic status of the patient. In a hypervolemic patient, clinically who is hypervolemic, the common cause will be congestive heart failure, cirrhosis, nephrotic syndrome. And in a euvolemic patient, the most common cause is syndrome of inappropriate diuretic hormone secretion. And other causes include hypothyroidism, hypocortisolism, and primary polydipsia. In a patient who is clinically hypovolemic, then we have to think of renal and extrarenal losses. The common cause for renal losses are most commonly diuretics, or in addition to that, salt-losing nephropathy, cerebral salt wedge syndrome are the other causes. For extrarenal causes, we have to think of GI losses like vomiting and diarrhea, and third spacing.
So, what is the natural further course on to take hypotonic hyponatremia further on? So, and what happens in our case?
In our patient, coming to the baseline investigations at emergency, the serum osmolality was 260 milliosmoles per kg, suggesting hypotonic hyponatremia. Sodium had been 124 milliequivalent per liter, as has already been told. Blood glucose was 96 per milligram per deciliter, and renal function tests and liver function tests were normal. And urine routine examination was not showing any pus cells. So, in addition to these investigations, so considering this as a hypotonic hyponatremia, we went ahead for the causes of hypotonic hyponatremia, which include urine osmolality, urinary sodium potassium, thyroid function test, ATM cortisol, and uric acid, basically to delineate the causes of euvolemic hyponatremia. In our patient, the urine osmolality was 208 milliosmol per kg. Spot urinary sodium was 56 milliequivalent per liter, and spot urine potassium was 40 milliequivalent per liter. The thyroid function test and ATM cortisol was within normal range.
Can you interpret each of these? What do you analyze from these results?
So for the patient's osmolality, the urine osmolality is somewhat inappropriately elevated, and the urinary sodium is that also is inappropriate. For this degree of tonicity, we expect lower osmolality and urinary sodium if it is a hypovolemic hyponatremia.
And additionally, both the thyroid function and cortisol levels are normal. So in a way, you have ruled out predominant causes. What are the causes of you have ruled out?
So hypothyroidism and hypocortisolism have been ruled out, and with a urine osmolality of 208 milliosmoles per kg. So this primary polydipsia is very unlikely. We are.
So what you are left out is likely
SADS.
So further on to characterize SADH, what all, how will you have the criteria satisfied for SADH, and what happens further to prove it? What further you can do?
Before going to the diagnostic criteria, we'll just see the as we have already told, the patient was having hypotonic hyponatremia with osmolality of less than 275. She was evolemic, and the urine osmolality was high with normal thyroid function test and cortisol, serum cortisol, suggesting we are left with SADH. So coming to the diagnostic criteria for SADH, this was originally proposed by Barter and Schwartz. This includes decreased effective osmolality, that is a serum osmolality of less than 275 milliosmol per kg, and inappropriate urinary concentration for the serum osmolality, that is at least more than 100 milliosmol per kg, and clinical euvolemia. The patient has to be clinically euvolemic for SIDH. Although over and above SIDH, patients can have diuretic intake or additional comorbidities, but we will not be able to diagnose SIDH till we treat that etiology. And elevated urinary sodium while on normal salt and water intake, and absence of other potential causes of euvolemic hyposmolality. And a modification of this original Barter and Schwartz criteria has been proposed. Apart from the essential criteria, no recent use of diuretic agents had been added as an essential criteria, and additional supplemental criteria have been added, that is serum uric acid level of less than 4 milligram per deciliter, serum urea of less than 21.6 milligram per deciliter, and failure to correct hyponatremia with normal saline, and fractional sodium excretion of more than 0.5%, fractional urea excretion of 55%, more than 55%, fractional uric acid excretion of more than 12%, and a therapeutic trial with which is successful is also an additional supplementary criteria.
So fits in with all these criteria?
Yes, her serum osmolality was 268, urine osmolality was more than 200. She was clinically euvolemic, and serum sodium concentration was 56 milliequivalent per liter. And the thyroid function test and cortisol have been shown to be normal. All the essential criteria is.
So now that you have SADH diagnosis made, further on in this particular case, in addition to this, what is the treatment principles we will follow? Okay, first you can dwell on the etiology and causes of SADH, and then further go on to treatment.
So coming to the causes of SADH, most commonly the drugs. There are many drugs which can cause SADH. Of these drugs like tricyclic antidepressants, nicotine, and phenothiazines, they cause SADH through stimulation of release of AVP. And drugs like desmopressin or oxytocin, they cause direct stimulation at the renal level and cause SADH. And there are many other drugs of which the common causes SSRI or antiepileptics like carbamazepine. These cause through multiple mechanisms. In addition to drugs, pulmonary pathologies, malignancies, CNS disorders have been also described to cause SIDH. And recently, nephrogenic syndrome of inappropriate diuresis, which is basically a gain of function of vasopressin 2 receptor with low levels of ADH also has been described. Now, coming to the diagnosis of this particular patient, it is chronic hyponatremia due to SIDH with acute exacerbation of hyponatremia caused by hypotonic intravenous fluids and poor oral intake. And coming to management, overall in a patient of hyponatremia, the clinical decision of when to treat and how to treat depends upon these important factors, that is degree of hyponatremia, whether the patient is symptomatic or not, and chronicity of hyponatremia. So the degree of hyponatremia, a serum sodium level of 135 to 130 is described as mild, and 125 to 130 is described as moderate, and less than 125 is taken as severe or profound hyponatremia. And patient can have a mild symptom in terms of mild cognitive deficits or simple malaise with mild hyponatremia. And they can present with falls or other slowing of activities. Whereas moderately severe symptoms include nausea without vomiting, confusion, and headache. Whereas severe symptoms include vomiting, cardiorespiratory distress, abnormal and deep somnolence, seizures, and coma. And the chronicity is based upon the duration of hyponatremia. That is, if it's more than 48 hours, it is labeled as a chronic hyponatremia.
So, how do you place the treatment in our particular patient? What would you have the principle as?
So, our patient had a severe degree of hyponatremia. She was symptomatic, and the presentation looks like acute and chronic. Since she's symptomatic, so all symptomatic patients should be given hypotonic saline for improvement in the acute symptoms. So the treatment of choice will be hypotonic saline at initial presentation. And
how will you go about?
So in this patient, the free water excess, calculated free water excess is as has been total body weight into 0.5 into 1 minus 140 minus serum sodium by 140. So it comes to 2.75 liters. And to correct to it, target sodium of
actually, if it is just the chronic component alone, maybe this free water excess could have been calculated, could have been just corrected just with the restriction of fluids. But there is an acute component added on to it. So you'll have to calculate how much 3% you will have to correct. Yeah.
So to correct it to target range of 130, the total sodium to be replaced to reach is 150 milliequivalents. And since 1 liter of 3% hypotonic saline contains 513, so the usually available hypotonic saline are available in as 100 ml vials. So each 100 ml vial contains 51 milliequivalents. So 3 vials of hypotonic saline will be needed to correct it to 130 milliequivalent per liter. And she received 2 boluses of 3% hypotonic saline, followed by an IV infusion of hypotonic saline at 30 ml per hour over next 3 hours. And her sensorium had improved over when she was on infusion, and the infusion was stopped. At that point of time, sodium was repeated after 4 hours, and the sodium was 132 milliequivalent per liter. And then the hypotonic saline was stopped, and the patient was followed up with fluid restriction alone.
So this is with regard to acute treatment. Had there been just a chronic SADH like presentation, what would have been your course of management?
So in a chronic case, the initial cornerstone of management will be fluid restriction alone. So fluid restriction to less than 1 liter per day would have been done. And in addition to that, high sodium diet with high protein diet can be additional use. However, giving high sodium can stimulate the thirst. That we have to keep in mind. And the fluid restriction is more likely to be beneficial when the urinary sodium and potassium by plasma sodium is less than 1. As we can see, the free water clearance formula for free water clearance, if the value of urinary sodium plus potassium divided by blood sodium becomes more than 1, the free water clearance becomes negative. So in such patients, if we have to keep a free water clearance, then we will have to restrict to less than 500 ml, which is not practically possible. In such patients, fluid restriction is likely to not to be successful, and we have to choose other options.
So this is very important. So estimation of urinary sodium and potassium will give us a clue as to whether fluid restriction would be beneficial to us or not. So if we are getting anything of negative free water clearance, it's less likely to be of benefit, and we should see towards alternative options to get sodium up.
Apart from this ratio, there are other predictors of fluid restriction, which include high urinary osmolality, that is more than 500 milliosmol per kg, and 24-hour urinary volume of less than 1.5 liter per day at presentation. And with therapeutic trial, if the increase in the serum sodium is less than 2 millimole per liter, then also the fluid restriction is unlikely to be helpful.
So with regard to, is there anything specific indication when to go for 3% saline?
Yes. So the hypotonic saline is indicated in all patients with who have symptomatic hyponatremia, whether it is acute or chronic hyponatremia, and also in acute severe hyponatremia, even if it is asymptomatic.
So what is the rate of correcting this with 3% saline?
So the optimal rate of correction in the first hour is usually a 5 millimole per liter, and this an increase in 5 millimole per liter of serum sodium will usually cause symptomatic improvement. Or if the symptomatic improvement occurs before that, we can safely stop hypotonic saline. Along with that, we had to give additional other additional measures. And over the first 24 hours, the overall rate of sodium correction should be less than 10 millimole per liter, and over the first 48 hours, it has to be less than 18 millimole per liter. And if it reaches,
so how do you give this in the first hour? You want to achieve 5 millimole increase. So how do you achieve that? How do you give it?
We can calculate according to the initial.
Sorry. How do you give it as a continuous infusion? Is favored, or as a bolus? What is favored in the first hour?
So the initial presentation for acute symptomatic improvement, initially bolus is preferred. This has been shown in recent publication 2021 in JAMA SALSA trial, wherein the duration of rate of improvement of symptoms was better with intermittent bolus as compared to continuous infusion, and the adverse effects were not significantly different between bolus and continuous infusion.
Fine. So now that you are given the optimal rate, there is a chance that you sometimes overcorrect at a faster rate. So what is the risk involved of overcorrecting it, and what is the what happens when you overcorrect?
So to see like what happens in overcorrection, we had to understand the pathophysiology behind that. So we had to understand the adaptation of brain with respect to change in sodium. Acute hyponatremia will cause cellular edema because of an excess of since the cranium is a closed space, it can cause cellular edema and can cause lead to herniation. And when in terms of treatment, in terms of like adaptation to an acute change, there will be loss of sodium, potassium, and chloride only. Whereas for a chronic hyponatremia, in addition to these electrolytes, there will be a loss of organic osmolytes. And this loss of organic osmolytes will take time. So in a patient of acute hyponatremia, if you are treating with the hypertonic saline, the adaptation can be faster, so that will not be a problem. However, in a patient of a chronic hyponatremia, wherein the organic osmolytes are also lost, in such a patient, if you are treating at a rapid rates, in such a patient, the cerebral adaptation will not be able to occur to that fast, and it can lead to osmotic demyelination.
Fine. So when you overcorrect, what are the things which you can do to reduce the overcorrection?
So coming first to this osmotic demyelination syndrome, this ODS is a biphasic condition with which can occur following rapid correction of at least more than 6 milliequivalent per liter from baseline. There will be a transient improvement in mental status followed over next 2 to 3 days with the clinical manifestations, which range from simple extrapyramidal and cerebellar involvement. It can range up to akinetic mutism or coma. The risk factors for osmotic demyelination include hypokalemia, elderly, and alcoholism, etc. And if we have overcorrected, then we can consider reloading of sodium in selected patients, especially in chronic hyponatremia. And further, infusion of 10 ml per kg body weight of electrolyte free water over 1 hour under strict monitoring of urine output and fluid balance can be done with frequent monitoring of sodium.
So what is the role of Vaptans in this case in hyponatremia treatment?
So overall, Vaptans are vasopressin 2 receptor selective antagonists. And the overall in hyponatremia, the Vaptans can be considered in patients without severe symptoms because in a patient with moderate to severe symptoms, the hypotonic saline is preferred because of acute rapidity of improvement of symptoms. And also, in addition to that, the improvement in sodium is predictable with hypotonic saline, unlike tolvaptan. And it is indicated in patients with inability to tolerate fluid restriction or predictive failure with moderate symptoms. And in case we are giving tolvaptan for severe degree of hyponatremia, that is less than 120, since it is less, the increase in sodium is not that predictable, we have to be careful for risk of overcorrection. And we have to be careful that we should not initiate tolvaptan as an outpatient, at least at initiation, it has to be in hospital. And immediately after hypotonic saline, if we initiate tolvaptan, there is a risk of overcorrection. And current, as such, the tolvaptan is recommended for a duration of less than 1 month only because of potential hepatotoxicity.
So what are the lessons we get from take-home points we get from this case?
So first, the serum osmolality assessment is the first step in evaluation of hyponatremia. And hypotonic hyponatremia is the most common type of hyponatremia. And SIDH is the most common cause of the various causes of hypotonic hyponatremia. And it's a diagnosis of exclusion. In all patients, we have to rule out hypothyroidism and hypocortisolism before coming to conclusion of SIDH. And for chronic SIDH, which is asymptomatic, fluid restriction is the mainstay of treatment. Whereas in acute hyponatremia, since there is lesser risk of osmotic demyelination, hypotonic saline is the mainstay of treatment. However, in chronic SIDH, which is symptomatic, hypotonic saline is the treatment of choice.
As such, hyponatremia can be easily managed if you go about a stepwise organized management plan, and it can be easily treated and managed. Do you have any questions?
how to convert blood urea value to blood urea nitrogen.
So blood urea has a molecular weight of 60, and out of that 60, nitrogen is contributed by 28. So multiplying by 28 into 28 by 60 will give you blood urea nitrogen.
We see many geriatric people with hyponatremia. How to prevent and how to detect early?
The thing is, in geriatric, they are more prone to hypocortisolism. They have a subclinical hypocortisolemic state. This hypocortisolemic state, as well as hypothyroidism, leads to a state of low effective extracorpuscular volume, and also they have a low resistance, arterial resistance, which predisposes them to hyponatremia per se. So these elderly people, we'll have to suspect their symptomatology will be so subtle that we'll have to suspect hyponatremia, and you will have to direct it. What else there is?
Why sodium excretion occurs in SID inappropriately elevated? Why urine sodium is elevated in SID?
Why urine sodium is?
SID.
Urine sodium. So reabsorption of sodium is impaired, is poor in SADH, and hence it's elevated. Okay.
The same question, sir. Continuation.
Could I ask a question?
Yes, sir. Yes, sir.
Congratulations for an excellent presentation. I would like to know your experience that after using hypertonic saline, is there a role for using isotonic saline and then coming to water deprivation?
It all depends upon calculation of our free water clearance. So depending upon the free water clearance, we can decide whether we need to give water deprivation is required or not. If water deprivation is found to be not useful, then we can give isotonic saline. If it is coming zero, then isotonic saline, if he is hypovolemic, and isotonic saline can be given. If there is a free water clearance is there, then water restriction would be benefit to that patient. If you have a positive free water clearance for the formula, it means he can benefit from fluid restriction.
What is your experience with demiclocycline, lithium? You think that's still a place in today's setting?
Personal experience wise, I have no experience with demiclocycline, but if you go by literature, they say that the side effects with them is significant enough that it's better not to utilize them.
Do you think the edible urea should be available in India shortly? Urea.
To be used, urea is actually an ineffective osmole. So it's not of much utilization in our use, and its palatability is also a big question mark. So, and it's also not available. So at this point of time, we need not think of using urea. Yes.
I think there was an article in 2015 on the demiclocycline.
Yes.
And showed that they had increased nephrogenic diabetes insipidus. That is why they stopped it. Now, I want your experience on Vaptans. How long you will continue Vaptans? Because sometimes the patients are discharged with Vaptans.
Yeah, it's not a good practice. No, you should not use it as an outpatient. Its licensing itself is for maximum of 30 days. You should not take it beyond 30 days. So on a long term, it's not a good choice of treatment.
What will happen if you give long-term Vaptans? What is the side effects?
The chance of them going into the reverse, it can lead on to just because they were given hyponatremia, the other side effects can set in. Yeah, hepatotoxic, yes, sir.
So in case of tuberous SADH, what will be the only fluid deprivation for a long time? In tumorous causes,
yes, sir.
SADH, water deprivation, what is the line of management in the future? What is the hyponatremia due to that cause?
So water
Inoperable
water
cases.
deprivation, I showed that formula, no, sir, in which we see whether free water clearance will be of use or not. So if on the if it so happens that the free water clearance is something negative, or that is more than one, then it's less likely to be of water deprivation alone is less likely to be of benefit. In those cases, we will have to bank on maybe something like Vaptans. And a lot significant of these people also might have something of poor osmolar intake. Normally, our osmolar intake would be something of 700 to 1000 milliosmoles per day. Sometimes these people have poor osmolar intake, which contributes to hyponatremia. So maybe something of good high protein diet would be of benefit to these people. That would be one way of.
What is your experience with cerebral salt wasting?
As such, we are suspected, but never gone on to prove it that this is this entity.
Thank you, sir. Excellent talk. Actually, it's a continuation of Dr. Sundaraman's question. I've seen many oncologists use as a sort of a part of a palliative care in many patients, more like as an outpatient basis, patient who have tumor-induced hyponatremia, using of tolvaptan at various doses and titrating as an outpatient. In those patients who are more for like palliative care, off license, any thoughts on that?
So at least if they are doing that intermittently, they should have the electrolytes checked, and their maybe liver function test at least should be intermittently checked and kept on follow-up.
Thank you.
Thank you. It was a wonderful that we had given this case so that we had to just build up a case and we had to analyze it. Thank you.
Thank you so much, Dr. Satish. It was very, very wonderful, and just the way you went through the whole case. I also like to take this opportunity to thank the CMC team for their wonderful performance as well. Moving on to the final session of the morning, we have got Dr. Shanmugha Sundar to moderate the session, and we have got panelists Dr. Arul Prakash, Dr. Narayanan, and Dr. Manikandan. Yeah.
Good morning, everyone. At the outset, I thank the organizing team for giving us this opportunity. So today we are going to discuss about inpatient diabetes management common mistake. Whether Dr. Manikandan is online?
Can you hear me? I can.
Okay. So we have three panelists. Dr. Arul Prakash sir, he is a senior endocrinologist from Thuthukudi, and Dr. N.K. Narayanan, he is again a senior consultant endocrinologist at Apollo Hospitals, Chennai, and Dr. Manikandan, senior consultant endocrinologist, Apollo Hospitals from Madurai, and myself, Dr. Shanmugha Sundar, again endocrinologist from Chennai. So there are a lot of things can happen during inpatient management. Most of the times the errors are due to the miscommunications. Like 8U can be misinterpreted as 0, so the patient would have been given 80 units, or sometimes it may be a 40 units, but the patient would have been given only 4 units due to the poor handwriting. And sometimes there may be miscommunication between the U100 and U40 vials in the insulin. There are 2 cents available, 100 unit per ml and 40 units per ml. That would have been miscommunication can be there. Sometimes over the phone call, we would have said 15. The intern would have understood it as 50. So the patient would have been given 50 units. And wrong calculation in insulin infusion because it comes like a unit per ml. So there may be some miscommunication because there are 50 ml syringe, 100 ml syringe. There may be wrong calculation in insulin infusion. Sometimes you would have asked to monitor the blood glucose. The sister would have not have done it. And another thing is very strange miscommunication. And it has been reported in literature. So SSI, sliding scale of insulin, has been misinterpreted as strong solution of iodine. And the patient has been given iodine instead of insulin. So the blood glucose was continuously not under control. So these are the common miscommunications. We are not going to discuss about this because it's mainly for the postgraduates. So we are going to, what are the errors can happen with respect to the management decision making. So approximately 1/3 of the inpatients have been found to have hyperglycemia, and many have pre-existing diabetes prior to admissions. And these are the common indication for hospitalization in patients with diabetes, newly diagnosed, particularly in patients in pediatric age group present with DKA, acute metabolic decompensation like DKA or hyperosmolar or non-ketotic coma, severe chronic complication of diabetes, uncontrolled diabetes during pregnancy, and many times problems unrelated to diabetes like any acute infection or patient may be admitted for surgery, etc. So due to acute illness, there will be increased stress of hormones and there may be usage of steroids. And again, the physical activity is going to be very less and oral intake will be modified. So the patients are prone for hyperglycemia, and again, it leads to various consequences like poor healing and increased surgical infection rate and increased hospital stay. The cost of the therapy will go high. And what are the barriers to glucose control during hospital admissions? The increase in insulin requirement and variability in subcutaneous insulin absorption, particularly if the patient has hypoxia or hypotension, then again, there can be variability in the subcutaneous insulin absorption. Very important, very, very important. The patient may be under NPO, or the patient may be having poor oral intake due to vomiting, or maybe skipping meals due to procedures. The patient may be going for CT, MRI, or maybe planned for surgery. The surgery would have got delayed. And the patient has been on NPO, but the patient would have got the instructions like we would have taken the oral drugs or insulin. So the patient is prone for hypoglycemia also. And the care of diabetes per se becomes secondary to the care of the primary diagnosis. It's very, very common. So if you have admitted for infection, so we'll be concentrating on only giving antibiotics and monitoring fever, other parameters, but diabetes control would have been missed. And finally, decreased physical activity. So if the patient is already very active, if you got admitted, there is a decrease in physical activity. So there is more chance of increase in the blood glucose. So we'll go to the 3 or 4 cases. According to the time, we'll discuss whatever possible. So where the management decision is wrong. So this is the first case. So this is about 60-year-old male diabetes admitted to the general ward with fever and vomiting, and he has been diagnosed with acute pyelonephritis. And before admission, he was taking metformin and sulfonylurea, but he is not following his doctor properly. He is obese, 100 kg, and his HbA1c, present HbA1c is 10.6. And inpatient glycemic values are between 250 to 350, and he is continuing the OHS, metformin and sulfonylurea, and he has also been given SOS insulin, that is a sliding scale insulin. And there are episodes of hypoglycemia also in between. So you can see this chart. There are multiple episodes of hyperglycemia, 300, 400, 377, etc. And he has been given oral drugs like vildagliptin, metformin, glipizide, etc. And in between case also hypoglycemia, like readings of 45, 36, etc. So coming to the discussion to Dr. Manigandan, whether the treatment given is correct. And second question is, what is the best regimen while such kind of patients when got admitted in the hospital?
Can you hear me, Dr. Sundar?
Yes, we can hear you.
Thank you so much for highlighting the most common problems and starting with a very important patient scenario whom we see quite regularly, because this patient has been put on a sliding scale regime where we tend to give insulin only when the sugars are high. And when the sugars are normal, we leave it and the sugars keep fluctuating. And the risk of hypoglycemia is also quite high, which you have highlighted. Because if we go back to the previous slide, when we look at the glucose levels, I don't think there's even a single value which is within the reference range. So there's only 178, which happened at 7 p.m. on the second day. Otherwise, all the readings are more than 200. And this is the problem which happens with sliding scale. And when we tend to give a higher dose, people end up having hypoglycemia, which has happened 3 occasions. So normally, most of the hospitals, they use a sliding scale as a simple step because they feel that it will get the things under control, but it's not. And usually it creates more problem because the sugars will fluctuate a lot and people will end up having hyperglycemic excursions and hypoglycemia. And it invariably delays the discharge of the patients and also causes significant delay in getting treated from the primary illness. So I think we should avoid sliding scale in most of the setting. There is a small role for sliding scale in inpatient setting where we can use it to gauge how much the patient requires in the first 24 hours when we don't know how much their insulin requirements might be, how much they're going to eat and other things. But using it as a only treatment option might not be a good choice. And using sulfonylurea when someone is not eating well might increase the risk of hyperglycemia, as you rightly pointed out as well. So to answer your first question, is the treatment given is correct? I think this is not the optimal treatment which should have been given to this patient. And coming to the next question, what is the best regimen while in hospital? I think insulin is the safest medicine to be given, but rather than given as a sliding scale, it needs to be given preferably as a basal bolus regime, either with a NPH insulin and a short-acting insulin, or the newer analogs can be also used. But the main thing is we need to titrate the doses depending upon the sugar levels. So that's also very important. So using a basal bolus regime would be ideal, and observing their glucose levels more frequently and adjusting the insulins accordingly would be the best way to get a good glycemic control in the patients.
Yeah, you just spoke about this sliding scale insulin for calculating the dose in the first 24 hours. Just to carry forward that one, if there are any difference in patients with already established diabetes, like for say this patient is already established diabetes with HbA1c of 10 and now he's got admitted, versus newly detected hyperglycemia during the hospital stay, and we don't know the HbA1c, whether there is any difference. For example, if already established, directly start with the basal insulin with calculated doses. And if a newly detected diabetes, then go with the sliding scale and decide the dose. Any difference in that?
Definitely, there will be in someone who's newly detected. We don't know whether it's a acute hyperglycemia which has happened because of stress from the illness. So always, someone who's got established diagnosis of diabetes with such a poor control will require a higher dose of insulin. We know for sure. For someone who's newly detected, we don't know how much their requirements might be. So in that scenario, having a sliding scale for 24 hours might be helpful. Or for someone who's got established diagnosis like this person, going away to a basal bolus regime might be helpful. But the problem is, even when someone has got established diabetes, we don't know how much they're going to eat when they come to the hospital, how unwell they are. So those are the other things also we need to consider. So along with whether they got established diagnosis, are they eating well? And how is their renal function? Because if someone has got a poor renal function, that's going to alter the way insulin is going to be absorbed in our system and excreted away. So it's going to increase the risk of hypoglycemia when someone has got renal failure, acute kidney injury. So all the parameters need to be looked in. I completely agree with your point, because we need to take into consideration other points as well, whether it's established diagnosis or new onset. And also we need to look at other parameters as well. That's what will help us to diagnose. So we can't use a box standard formula for everyone. So we need to individualize, and the safest bet would be to go on to a basal bolus regime and use a basal regime, say use 0.1 unit or 0.2 units per kilogram. If you're going to use NPH, split it into 2 doses. If you're going to use a basal analog, use it as a single dose and then use short-acting insulin along with it.
Okay, for the postgraduate shake, let's take this case as an example. He is 100 kgs and his HbA1c is 10.6 and he has been admitted with the infection in the general ward. So how will you start with the insulin? What dose will you give for this patient? Basal insulin, what dose will start, and bolus insulin? And also main thing is the correction insulin. This is the one thing which in most of the hospitals they don't do. So calculate the correctional insulin dose based on the pre-meal glucose levels. So what will you do for this patient?
So I think because this patient is 100 kilos and he's got infection, the insulin resistance is going to be high. We can start at a higher dose. We can start either at 0.4 units per kilogram or 0.5 units per kilogram per day. So for simplicity, if I use 0.4 units, so it will be 40 units per day. Use 20 units as basal. And if you're going to use NPH, we can use 10 units in the morning and 10 units at night. Or if you're going to use glargine, then use 20 units, preferably at night, or I tend to give it when I see them, and then I'll gradually move the dose towards nighttime, rather than make them wait till the evening time, because most of the time the rounds happens around 10 o'clock, 11 o'clock in the morning. I tend to give a stat dose at the time, and then next day I can give it at lunchtime, the following day in the evening, and then take it to the bedtime. So half the dose will be given as bolus, and the rest of the half, so the 20 units, we can split it as 6 units, 3 times of short-acting insulin, either analog insulin or regular insulin. Both are very efficient, and we can use that. And then see how the patient responds in the next 24 hours, and then titrate the dose of insulin accordingly.
Okay, so after 2 days, the patient feels better with IV antibiotics and he starts eating well. The last 24 hours, his blood glucose values are between 180 to 220. So what is the best approach now? Restart the OHA and stop the insulin, or you continue with the insulin plus OHA or only insulin? So what will be the best approach now?
So I think as the patient gets better, we might need to change the regimen, but continuing insulin until they're well enough to start eating is very important. So I assume this patient is starting to eat well. That's what it says in there. So in that scenario, we can introduce OHAs. So if the renal function is good, then I tend to use gliptins, which I find, sorry, 1 second. Can you hear me?
Yeah, yes. Proceed.
If someone is able to eat well, gliptins might be a better option in those patients. So I tend to add in a gliptin. If the renal function is good, start on the full dose of whatever gliptin which we prefer. If someone's got a renal function is reduced, then reduce the dose appropriately and use a gliptin. And metformin can also be used, but it's a bit controversial. So I tend to use it a lot during inpatients. But if someone is really unwell, we can wait till they get discharged, and it can be started after they become well enough. Insulin, if the renal function is not good, I would continue the insulin. If I feel that they're not going to follow a basal bolus regime, it can be switched on to biphasic insulin, or continue the basal bolus regime until they get discharged. And during the first follow-up, we can change to OHAs. But if they're really well, if they already have a good control with OHAs, an established type 2 diabetes, we can put them back on their old medicines, provided that the renal function is good, before they discharge. If not, if the control is not good, consider sending them home on insulin and then changing it when they come back for the first follow-up.
Okay. So you talk about this one, premixed insulin. What your take on this when the patient got admitted? If the patient is already taking a premixed insulin, or we do see some patients prescribed a premixed insulin after admission. What your take on using premixed insulin in patients admitted patients?
It's not as easy to manipulate a premixed insulin like by a basal bolus regime, but I think in someone who's having a good control with biphasic insulin, who's able to eat and drink well, we can continue the therapy. A basal bolus regime is easy to manipulate because if we can just increase the doses where it's required, and we can delay the doses depending upon whether they eat or not. and how much they eat, it can be changed. With biphasic, we can't do that. That's the problem with this. But if someone is well enough, if they're eating well and they got a good control of this, I tend to continue. Otherwise, switch them over to a basal bolus regime during their hospital stay. And when they're well, we can go back to biphasic insulin.
I think that's very, very important point for the postgraduates. So premix insulin, it may be easy to use because we have this intermediate and short acting in the same insulin, but the flexibility is not there. If you want to adjust the dose based on your pre-meal and fasting blood glucose or after meal glucose, adjusting with premix insulin is not very easy. The patients are prone for both hyper and hypoglycemia, but with basal bolus, it's always easy to manipulate the insulins. So what are the recommendations for the following situations? Patients on OADs, not eating and eating. Any take on that?
I think if someone is on OADs and not eating, going on to a basal bolus regime would be the best option. And on someone who's on OADs but eating well, it depends upon what OADs they are on. I'm always cautious with sulfonylureas because of the risk of hypoglycemia. If at all, if I want to continue, depending upon the control, adjust the dose. If someone has got a very good control, I tend to reduce the sulfonylurea doses. But if it's for surgical patients, I tend to avoid it. And if someone is unwell, septic, then avoid sulfonylureas if possible because of the increased risk of hypoglycemia. And as I said earlier, DPP-4 inhibitors are really safe. Metformin, provided that the renal function is good, I tend to continue on most of my patients because it does reduce the insulin resistance quite a lot. SGLT2 inhibitors, most of the time during admission, I tend to stop it because it increases the risk of euglycemic decay and also other problems associated with SGLT2 inhibitors like dehydration. So I tend to avoid it. But gliptins, metformin, I'm comfortable. Sulfonylurea, use it with caution. Insulin would be the safest for most of our patients.
I think the next thing, two things we can discuss over the next cases. Thanks, Dr. Mani. So second case is about a 64-year-old female admitted with ICU for severe community-acquired pneumonia with ARDS, and she's on mechanical ventilator, and no past history of diabetes before admission. It has not been checked. But the glucose measurement in the first 6 hours ranged between 200 to 400 milligram, despite on sliding scale with regular insulin. To Dr. Arul Prakash, sir, whether this approach is correct, and if not, what should be the further treatment regimen? So she is on ventilator, so she is not, obviously she is not taking orally, she is on enteral nutrition.
So yes, as you put it, the patient is very sick, actually. He's in ICU, obviously needs insulin, but in a way it should be titrated very easily. But the subcutaneous sliding scale is not a very wise option. That's what Manikandan also was mentioning. Again, the patient was not a diabetic to begin with. She didn't have a label of that, but the sugars are obviously high, 200 to 400. In the first 6 hours, I presume that it was repeated on few occasions. So, but whatever the case may be, any hyperglycemia, I would think it's 200 to 420. It's a moderate to severe. Hyperglycemia has to be controlled in ICU setting. So in order to improve the patient outcome, whatever may be the etiology, maybe admitted for community-acquired pneumonia or whatever. But the patient is also in ARDS. So we need the best choice could be continuous insulin infusion, the IV insulin infusion. So that's what I will think. I will not recommend the subcutaneous sliding scale.
Okay. So again, you can enlighten because the postgraduates are hearing. So what are the indications for insulin infusion and what dose you will start and how will you titrate the insulin infusion?
Yeah, but when the patient is severe hyperglycemia, it's one in this particular situation, and again the patient is little over, above 60 years, who is having that's again aging is a risk factor for hyperglycemia. Patient may not be eating. So there are certain risk factors in ICU where the patient is prone to have hypoglycemia. So there's kind of patients with severe hyperglycemia, very sick, the patient who may develop a hypoglycemia eventually, are the candidates for insulin infusion therapy.
Okay, so
IV insulin.
what dose you start with and how will you monitor this patient? And how frequently we need to do the blood glucose level and adjust the dose?
Yeah, it depends. Every institution use a different kind of algorithm. So we need to take into consideration of the stress, a degree of hyperglycemia and so on. But generally, to begin with, we can just start with the low dose. It's 1 unit per hour. Obviously, you just pack the insulin 50 units in 50 mLs of saline to be pumped as a syringe through syringe pump, and then you parallelly run your fluids. And then you just monitor the blood sugar every hour and see whether we tend to achieve our target blood sugar values, whatever you fix, between 140 to 180 or whatever. So then if you don't seem to have the control with 1 unit per hour, then you may have to shift it to the next scale, that's 2 units per kg. And then you can titrate up to 3, 4, 5 units per kg. It depends on the situation. So that's how we start.
Again, 2 points, very important point, Keto, that one is we need to avoid hypoglycemia in sick patients, particularly elderly patients. So the target is different because it's a patient is in medical ICU. Even if you keep it below 180 milligram per deciliter is enough. No need to target less than 140, something like that. Because the hypoglycemia is more dangerous than the hyperglycemia. So the target for medical ICU and surgical ICU is completely different. There are a lot of landmark studies published on that. So the two things are very, very important. What you said, sir, very important for the postgraduates. And once the patient is improved and he starts taking the shifted to the ICU from the high dependence unit or the ward, and how to shift to the subcutaneous insulin regimen.
Right. So as the patient is on insulin infusion, it needs close monitoring, which is quite possible only in ICU setting where you have good nursing care and everything. But when you are planning the patient to go to the high dependency or the ward, by the parameters, where the patient is stable with a blood sugar level for the past 6 hours, reasonably stable with an infusion of fixed infusion. The patient starts to eat, and the basic problem, just pushing the patient to the ICU, is settling down. The basic problem is settling down. Maybe the infection is settling down and so on. So you just take into consideration various parameters that the patient is settling down and the blood sugar may not fluctuate very well. And then you may consider putting the patient on subcutaneous insulin. So you calculate the last 12 hours need. Suppose the patient is, you are running in 3 units per hour, that's or 2 units per hour. For the 12 hours, then you can calculate 3 into 12, that is 36 units. That's the requirement for 12 hours. Then you can just extrapolate to 24 hours, to maybe it rounds into 64 units. So you just make the same calculation as Dr. Manikandan mentioned. So just make the basal as 50% of the total requirement as basal long acting. And then you may the rest of the units you calculated divide into 3 and just make it as a prandial insulin if the patient is eating. Otherwise, you may just put it as a correction insulin.
Thank you, sir. So let's go to the case number 3. 44-year-old male, diabetes on metformin 1 gram per day, glimepiride 4 milligram per day, and dapagliflozin 10 milligram per day. And he has phimosis and he also has history of recurrent balloon prostatitis. So he was admitted for circumcision surgery. And day before the surgery, he has taken all the OHS, including the glimepiride and metformin at night. And patient was kept NPO in the morning for early morning surgery, but the surgery was delayed for quite few hours. And he had hypoglycemic episode while waiting for the surgery. To Dr. Narayanan. So what are the instructions should be given to the patients the day before the surgery, while the patient on OHS or on insulin? So what are the instructions should be given to the patients?
I think this case nicely highlights why it is important for the patients to be referred to the diabetologist beforehand as an OPD. It's important for us to know the patient, how the diabetes control is. Once the glycemia is under control, then if they take them up for surgery as an elective procedure, it's much easier to control the glycemia peroperatively. Just in case if it's an emergency surgery, it's a different situation. For example, this patient who has got a phimosis recurrent melanocytitis, presumably this is related to the SGLT2 inhibitor, the dapagliflozin, which he is on. One of the side effects of the SGLT2 inhibitors is because it chucks out a lot of glucose through the urine, they are prone for melanocytitis or vulvovaginal infections. So genital hygiene and increased oral fluid intake is one of the important instructions we give to the patients when we put them on. Now, the day before the surgery, when people are on such medications like strong sulfonylureas or the SGLT2 inhibitors, the general advice for SGLT2 inhibitors will be to avoid at least 2 days prior to the surgery due to the risk of what we call as euglycemic DKA. Although the glycemia would look normal, patients may be prone for ketoacidosis due to the acute stress, whether it is because of surgery or trauma, whatever the causes. So generally, if it's a planned surgery, we would advise the patient to avoid the SGLT2 inhibitors 2 days before surgery, on the day, and at least 2 days after the surgery. Once the condition is stable, you restart them on. With regards to the sulfonylureas, because the patient is on 4 milligram of glimepiride, which is still going to act if the patient is suddenly kept NPO, nil by oral. Generally, we want to make a dose reduction the night before at least. Maybe instead of 2 milligram, he could have been given 1 milligram. Again, it depends on how his glycemic control was beforehand. But presumably it's a normal control, then we want to do a dose reduction. With regards to insulin, we would, let's say, for example, the patient is on a basal bolus regime, then the night before he would take his normal short-acting insulin at the same dose, but the long-acting insulin, we would decrease by at least 50%. Such scenario is not uncommon that the patient is planned for an elective procedure early in the morning, but the surgery is getting delayed. So proper preparation for the surgery is vital for a good outcome, especially when it is an elective case.
And on the day of the surgery, or when the patient is planned for imaging procedure like CT scan or MRI, where they have to be on fasting for at least 4 hours, and many times it get delayed also. So what are the instructions should be given to the nursing staff on the day of the surgery, whether the patient is taking OH or insulin? So what are the instructions should be given?
So assuming that the patient has been prepared, that the dose reduction, appropriate dose reduction has been done the night before, the insulin or the OHs, then the morning they monitor the sugars. Despite all this, the patient may develop a hypoglycemic episode. So it's very important to monitor for that. Or the patient may develop a hyperglycemic episode. It could be the acute stress of the patient getting admitted to the hospital, or the stress of the illness with which the patient is getting admitted. So we want to monitor the sugars and maintain at least less than 180, maximum up to 200 milligrams per deciliter on the morning of surgery. If it is showing hypoglycemic range, like what this patient has developed morning of the surgery, then it's important that we first monitor it frequently, correct it, because this patient is nil by oral. We won't be able to give anything as a oral preparation to correct the hypoglycemia, which we do in other situations when it is a mild hypoglycemia. Here it has got to be an intravenous replacement or intravenous correction. So ideally, if it is a significant hypoglycemia, then a 25% dextrose bolus of about 50 ml given. Then we recheck it after 10 to 15 minutes to make sure that the hypoglycemia is corrected. If the patient is still having hypoglycemia, or the second episode of hypoglycemia, then we would give another bolus of 50 ml, but then it should be followed by a continuous infusion to maintain the glycemia. And in that scenario, the recommendation would be to at least monitor the sugars once in 30 minutes for the first couple of hours. If it is stable, then we can go for an hourly monitoring, depending on when the surgery is scheduled. And once the patient develops hypoglycemia prior to surgery, it's important they are monitored perioperatively as well. So the instructions handing over to the anesthetist is also important, especially when it is a prolonged surgery. I mean, circumcision, it would be finished in 30 minutes, but for other surgeries, it's important that the anesthetist is aware that the patient has had a hypoglycemic episode. With regards to hyperglycemia, when it is more than 200 milligrams per deciliter, again, an intravenous insulin infusion ought to be started. Because the patient is nil by oral, it's an intravenous insulin continuous infusion. There are various calculations that we can use. One simple calculation I use is we subtract 80 milligrams per deciliter from the current sugar value. Let's say the patient sugar value on the morning is 280. You subtract 80, then it's 200. Multiply that by 0.02. which would be about 4 ml. So we'll start with 4 ml per hour, monitor the sugar after an hour to see whether there is an adequate reduction. If there is an inadequate reduction, then you increase it to 0.03. Or if there is a significant reduction, then you decrease the infusion to 0.01, which is either you go to 2 ml per hour or 6 ml per hour.
Any difference for the type 1 diabetes in the morning of surgery or any procedure, imaging procedure where you want to give the long-acting insulin or something like that?
So type 1 diabetes, as we all know, the patient should be on the long-acting insulin, even if the patient is going to be nil by oral. For example, more often the patients are on long-acting agents like Glargine. So the long-acting insulin should never ever be missed, even if the patient is going to be nil by oral. The short-acting insulin, definitely the patient should not be taking on the morning of the surgery.
Okay. Thanks, Dr. Narayanan. So last case, we'll discuss briefly. Now, last 1.5 years, we are seeing this lot of this kind of cases where COVID positive patients, when they are admitted, they have been given a steroid dose at appropriate or more than the appropriate dose. So this patient, 36-year-old male, known case of pre-diabetes, COVID positive, admitted with desaturation, breathlessness. He was started on O2 remdesivir and injection dexamethasone 8 mg OD. And he had steroid-induced hyperglycemia, started on glipizide and put on sliding scale. Still, his blood glucose varies from 300 to 400 mg per deciliter. Because of the time, let's stick to the one question: how to choose the insulin based on the type of steroid used? Because we know that different types of steroids are used for COVID management, like dexamethasone, methylprednisolone, visolone, etc. Any thought from the panelists on this?
Would you like to take it?
Listen, why don't you start, John, in, sir?
Okay.
So it's important to understand the pharmacokinetics of the different steroids that are used. Some are short-acting agents like hydrocortisone, which acts for about 8 hours. Some are intermediate acting like prednisolone, for example, and some are reasonably long acting like the dexamethasone. So it depends on the steroids that we use. The typical scenario that we see with hydrocortisone is that there is a big blip in the blood sugars which goes high and then tends to start coming down after 8 hours, assuming the patient has had a stat dose. If the patient is on prednisolone, given and as in a morning dose of prednisolone, then it acts for about 16 hours or 20 hours, depending on the patient's metabolism. But in general, the effect wears off at the tail end, which is about 6 to 8 hours time period. Therefore, the typical scenario is the patient starts with a fasting sugar of 80 to 90. Then the postprandial goes up to something like 200 to 20. And then the maximum sugar that we see is by the late evening or by the nighttime. Pre-dinner sugar will be something like 350. So the typical scenario is a rising profile whole through the day when the morning prednisolone is given. And then by early morning, even if the dinner time sugar is 350, by morning time, if you check, it drops down to 80 or 90 because the effect of prednisolone wears off and there is no endogenous cortisol also because the exogenous steroid has been given, the endogenous cortisol has been suppressed. So based on this profile, we can use whichever insulin we are comfortable with. Given scenario of prednisolone, maybe we can use a NPH in the morning and a short acting to correct the post breakfast sugars. And they will need a huge or a larger dose pre-lunch, plus or minus the OADs that we can combine along with this. With dexamethasone, the effect tends to be much longer. So you may need to use a mixed insulin, like a premixed insulin morning and night, or you give an NPH and a short acting and an NPH and a short acting at night. Again, either you can combine along with your OADs.
Yeah, that's a very important message because based on the type of steroid what we are using, it's very important because as he rightly told, there is sometimes there will be hyperglycemia and at the same time they may be prone for hypoglycemia also. So we have to choose the insulin appropriately.
Can I add in one thing? Can I add one? One of the, it's an excellent point what Dr. Narayanan sir pointed out. One other thing is always ensure that the steroid is given in the morning, because what happens is, say a patient gets admitted at 6 o'clock in the evening, they get the first dose of steroids at the time, and the following days they're given dexamethasone at 6 o'clock in the evening, which mucks up the physiology completely. If they give it in the morning, then we can adjust the dose of insulin accordingly. But if they're given at night, it can affect their sleep pattern also. So it's very important that we encourage our staffs to give the insulin first thing in the morning, and then we can adjust the dose of insulin accordingly.
Yeah. Thanks, Dr. Mani. As already discussed, the sliding scale is alone is inefficient. It's morely like a reactive rather than proactive. So don't go for a sliding scale other than the what indication Dr. Mani has said. So basal bolus regimen achieves better control than the sliding scale alone. There are studies in medical patients and surgical patients also. So clearly this landmark study shows that basal bolus insulin, the control of hyperglycemia is also very fast in the both the studies and also persistent. And again, hypoglycemia risk is also same. So recommended glycemic target for hospitalized patient already we discussed. So in critically ill patients like medicine ICU patients, if you target less than 180, it's enough. Don't target less than 140. And perioperatively 90 to 180. And in acute coronary syndrome, target between 126 to 180. And recommended frequency of CBG testing, people who are eating before meals and bedtime. The patient is NPO every 4 to 6 hours if the patient is on basal bolus regimen. But if the patient is on insulin infusion, as already discussed, monitor every 1 to 2 hourly based on the hospital protocol. So to summary, continue pre-hospital diabetes regimen if appropriate. If the patient is stable, the illness is not very severe, and the patient is taking the meals at appropriate time, continue. Otherwise, please start insulin as the treatment of choice and do not use sliding scale insulin alone. Do use basal bolus plus correctional insulin regimen. Again, it's very important. It's not only about basal bolus. You also calculate the correctional insulin dose and give that also. And if required in a certain situation, as discussed, we need to go for the IV insulin regimen. And always try to avoid hypoglycemia. Again, very, very important. Hypoglycemia is a very much a danger thing. It increases the mortality rate. As much as possible, try to hypoglycemia. Thank you very much. I thank all the panelists for the wonderful discussion. Thank you very much. There are few questions. One question from Devi Gayatri. What is the use of insulin and dextrose dip for perioperative period? Dr. Narayanan, you spoke about this IV insulin regimen if there is a prolonged surgery or the patient is on NPO. So she has asked giving insulin infusion along with the dextrose drip.
So I think what she means is the GKI, which we used to use before. I don't use it a lot. I tend to use it separately. I tend to use the insulin via the pump rather than giving it as a drip, because often mistakes happen with the number of drops. There's too much going on, too less going in. So the insulin, I always want to use it along with the pump. And then I keep the dextrose and the saline separately. And depending on the hourly sugar monitoring, they can adjust by giving either dextrose or normal saline or adjusting the insulin infusion.
Again, it's a very important message for the postgraduates on interns. So it's not only the insulin drip, because the patient will go for the hypoglycemia. The patient is on NPO. So always it's better to give the 5% dextrose in the separate infusion as a separate infusion and adjust both the insulin drip and the dextrose drip based on the blood glucose monitoring. There are no more questions in the chat box. Any questions from the all? There are no more questions. Thanks the organizing team.
Just one more point for the postgraduate. So even the patient is on basal bolus or any moderate regime, before adjusting the prandial insulin, you need to just look back and say what was suppose if you're giving insulin for supper, during the supper, just see what happened yesterday during the afternoon short acting. So probably you need to go back and just correct rather than just correcting at that point of insulin.
So we need to know the trend, how they are responding to the insulin before they.
Yeah, see the trend and what happened before, and just see what insulin made the effect, and just go back and just correct.
Very valid point, sir. Thank you very much. With this, we'll end this session. I think now it's lunch time, and we will assemble back. We'll assemble back at 1:30 for the post lunch session. Thank you. 1:35 p.m. Thank you.
ஸ்பீக்கர்ஸ் எல்லாம் போடுங்க. மூஞ்சி பார்க்கலாம். ஆனந்த் மூஞ்சி காட்ட மாட்டேங்கிறாரு. இது கொடு. இதுல
எவ்வளவு பேர் இப்ப லைவ்ல இருக்காங்க?
ஸ்டார்ட் பண்ணலாம்ல.
நான் ஒரு இன்ட்ரோடியூஸ் பண்ணேன்.
Good afternoon, my dear friends. We welcome you back for the post-lunch session. We have three interesting topics to be discussed. One on incretin analogs, osteoanabolics, and MR antagonist. To chair this session, we have Dr. Suresh Damodaran, who is the Vice President of ESI, and he requires no introduction because all of you are well aware with him. Another chairperson with him, I have Dr. Arun, who is a very close friend of mine, and he's a consultant endocrinologist from Madurai. Over to chairperson, Dr. Suresh.
Thanks, Dr. Kumarvel, and I just welcome Dr. Anand Kumar Annamalai just to give a talk about incretin analogs. Now, I think for the next half an hour or so, we got more of a therapeutics area where I think it is very important to know about pros and cons of the drugs, and it is the challenges that what we face. It's just not the drugs we need to prescribe. Incretin analogs, osteoanabolics, MR antagonists, all are extremely interesting. So I'll just hand over to Anand, please.
Good morning, good afternoon, Suresh. Thank you very much. So do you want me to start?
Yes, please. Yes, please. Yes, please.
Okay.
Three speakers are ready.
Okay, good afternoon. So before I start, I hope you can see my slides and I hope you can hear me clearly.
We can, yeah, thanks.
Okay, so today's a very interesting session we have, and my topic is on incretin analogs. My conflict of interest is none for this talk, but I am on the advisory boards for a lot of these companies. So we have evolved a lot from the time when we speak about glucose homeostasis, and glucose and the gut has a huge role, and specifically endocrine transmission in terms of hormones has acquired a huge role. The GIP, GLP-1, these two particular hormones have been held the spotlight for more so recently. The GLP-1 has a predominant action, not just in the pancreatic area, but also in the extrapancreatic area. In terms of the islets, where it increases the insulin biosynthesis, it promotes beta cell proliferation, it decreases the beta cell apoptosis, and it improves the insulin sensitivity in the peripheral tissue, both at the liver, at the muscle, and also the adipose tissue. And as far as the extrapancreatic
There is a streaming issue.
There is some network issue with Dr. Anand, sir.
Okay, great. So he was just talking about GLP-1 introduction. So should we go for the next speaker, or should we wait for him to get it ready? Either way, it's fine. So as I mentioned, I think all these three drugs of GLP-1, osteoanabolics drugs, and then MR antagonists, which is getting much more hype now with spironolactone and eplerenone in serious challenge. And the new drugs are coming up. And I just met one of the guys who are mainly, he spent his life in hyperaldosteronism, especially primer. Is called John Wonder from Australia. Now, he was just saying to me that if you can, I can make you a millionaire tomorrow if you can make 7.5 of spironolactone in India. So that much value these kind of drugs has got. And for example, MR antagonist, John Conley, one of the guys from Glasgow,
If you remember that he presented in as a presidential oration in Endocrine Society, British Endocrine Society meeting, Society for Endocrinology. Anand, are you ready?
Yeah, sorry, I just had a power outage. Apologies.
So,
I'm back.
so he was just came up with the concept of subclinical hyperaldosteronism. So it carries that much amount of, so if you have hyperaldosteronism to maximum level, then you cause as a cons. But if you have a level just very less than that, it's normal. And in between is called subclinical. So he came up with the concept, and a lot of blood pressure, hypertension patients have been given a mineralocorticoid androgens. So I just leave it, and I'll ask Anand to continue. Thanks.
I'm sorry about that, Suresh. So I just had a power outage and I'm back again.
Absolutely
so
no issue.
I'm not sure where I left, but yeah.
No,
so I'll
I think
just
it's
go
just
back
the
to
action of
role
GLP-1. Yeah.
Okay, fine. So the action of GLP-1. So we were talking about the islet cell effects in terms of both the alpha and the beta cell. Specifically, it is a glucose-dependent action, and that makes a huge importance compared to other therapies. And this in particularly in terms of increased insulin biosynthesis, the beta cell proliferation, and also the decreased beta cell apoptosis. And in terms of action, both in the liver and the muscle, it enhances the insulin sensitivity. Apart from this, extrapancreatic effects, particularly in the brain, in terms of appetite regulation, and also in terms of the heart, in terms of cardiac protection, there are multiple effects which actually GLP-1 has. In terms of contribution of the gut-derived factors in postprandial secretion, the predominant secretion regulator is actually the GIP, followed by the GLP-1, and obviously glucose by itself is basically a sensor for stimulation for postprandial insulin secretion. So lots of molecules have been derived from this pathway, the incretin pathway, and the GLP-1 receptor agonists have basically come into being. So we have two varieties, one, both depending on the backbone of the GLP-1 receptor agonist. If it is a native human GLP-1 backbone, it's a human GLP-1 based therapy, and if it's an exendin-4, it's a little bit different. So for the human GLP-1, we have multiple therapies like dulaglutide, which is weekly once. We have once daily liraglutide, and semaglutide, which is both oral and also an injectable. As far as the exendin-based therapies, we have exenatide, which is the weekly once injection, and also we have the once or twice daily exenatide. We have the albiglutide, which is not available in India, and the lixisenatide, which is basically a more prandial regulator. What do they do? As far as the clinical trials of GLP-1 receptor agonists, if you were to summarize, there's an improved reduction of HbA1c of close to 2%. And that is from baselines of between 7 to 8. And that's why it is a very important tool in the armamentarium of type 2 diabetes. And a mean percentage reduction of HbA1c of less than 7 is up to 40 to 79%. Coupled with this, we also have a weight reduction. And these numbers can actually go up in clinical practice. So this is the spectrum of the various trials, the phase 3 trials, with various agents, with liraglutide, semaglutide, lixisenatide, dulaglutide, etc., as far as the HbA1c. The common denominator here you could see is from a HbA1c of 8.5, you get reductions of greater than 1.5, close to up to 2, which is phenomenal. Apart from this, you also have a good efficacy in weight reduction. And the weight reduction in trials have been predominantly between 4 to 6 kilograms and sometimes lesser, depending on the agents we use. The phenomenal effect has been in the cardiovascular outcome trials. Now, almost all the GLP-1 receptor agonists have shown multiple benefits, including superiority, and also in terms of primary prevention in terms of cardiovascular outcome trials. So starting from the leader with liraglutide to the latest sustain and pioneer with semaglutide, or the harmony with the albiglutide, we've had multiple benefits. As far as the primary prevention, we have the rewind with the dulaglutide, which also showed a good effect in terms of primary cardiovascular outcomes. So this is an important reason why most associations across the globe now have included these therapies, not only for glycemic lowering, but also for cardiovascular outcome trials in terms of outcomes. The other important aspect has been in terms of weight. So recent trials, which was published even in NEJM just a few months ago, the once-weekly semaglutide in overweight or obesity showed phenomenal results with percentage weight loss of up to 18% for up to 68 weeks. Apart from this, you also had reduction in blood glucose, blood cholesterol, and also in terms of lipids. Semaglutide once a week with obesity, with overweight, and also in type 2 diabetes also had phenomenal effects. So these therapies are making type 2 diabetes treatment increasingly more attractive in terms of a holistic approach of HbA1c, weight, and also in terms of lipids. So this is the A1C reduction from a baseline of 8. And this is, again, as I said, a common denominator with these incretin analogs, where you see with HbA1c of 8, you can get as low as 6, 6.5, and this is sustained. And along with this, you have also a weight loss effect. And important aspects in relation to the waist, hip circumference, and systolic blood pressure. All this could mean good cardiovascular outcomes. So this is the reason why the ADA has included GLP-1 receptor agonists upfront, apart from metabolic issues and also for atherosclerotic cardiovascular disease. And cardiology guidelines have also concluded this. It's important for a clinical practitioner to know certain things for starting a GLP-1. It's important to start low. Smaller meals, people need to be advised to eat slowly. We have to advise them about the nausea vomiting issue, which could occur with any GLP-1 receptor agonist. And also we have to tell people that you have to reduce food consumption initially. The risk of hyperglycemia when used concurrently with other agents have also need to be addressed. Independently, GLP-1 receptor agonists will not cause hyperglycemia. But if you were to use it with insulin or sulfonylureas, because these agents increase insulin in a glucose-independent manner, this basically could cause increased risk of hyperglycemia. So it is important to reduce the dose of other agents like sulfonylurea or insulin. Oral GLP-1s, which is yet to set off in the Indian market, the oral semaglutide, which is co-formulated with an agent called SNAC. It's important that you wake up in the morning and take it in the morning with half a glass of water on an empty stomach. Wait at least 30 minutes before eating, drinking, or taking any of the other oral agents. So if you look at the efficacy of these agents in terms of glycemia, very high. Risk of hypo, it's very low. Weight change causes good amount of weight loss. Cardiovascular effects, benefits are there, some are neutral. Unfortunately, it's costly, it's an injectable, there's only one oral. The renal effects, although we don't have a direct renal trial yet, most of the cardiovascular outcome trials have shown albuminuria outcomes, and basically it could be even used in eGFRs of less than 30. And in certain agents like liraglutide, semaglutide, and dulaglutide, there's no dose adjustment needed for renal impairment. Certain FDA black box warnings of thyroid C-cell tumor, specifically in rodents, human relevance has not yet been determined. Pancreatitis has been reported in trials, but no causality has been established. And the most important issue of the GI side effects like nausea, vomiting, and diarrhea. It's important to understand that we need to discontinue if pancreatitis is suspected. But what about the newer incretin analogs? So what could be an ideal partner for GLP-1? There's a host of agents which could actually act as co-agonists. The most important aspect is the GLP-1 and GIP co-agonist. The GIP was initially dubbed as obesogenic, but studies have shown that chronic treatment with GIP decreases body weight. So the GIPR agonism chronically would actually be beneficial. It would actually improve insulin secretion, glucose tolerance, and also decrease the body weight. Keeping this in mind, now we have dual agonists or twincretins, which basically have the GIP and the GLP-1 action. The anorectic effects of GLP-1 may buffer any obesogenic GIP-1 effect. So the twincretins, the latest is tirzepatide, which has phase 3 trials, which shows that the dual GIP and GLP-1 co-agonists lowered HbA1c and weight more than any other comparative GLP-1s. You had weight changes of up to 10 kilograms at the baseline of around 90, and HbA1c baseline 8 dropping down to close to 2.5, which is phenomenal. Apart from that, improved insulin resistance and beta cell function markers, with HOMA-IR improving, intact insulin, pro-insulin ratios, and an appropriate reduction in glucagon. All these are very, very beneficial. So to conclude, this particular area, the incretin analogs or the incretin mimetics, the GLP-1s or the core agonists, basically are predominantly lowering the blood glucose in people with type 2 diabetes without increasing the risk of hypoglycemia, because these have glucose lowering effects that are glucose dependent. The GLP-1 receptor agonists also have extrapancreatic effects in terms of reduction of cardiovascular disease in people with type 2 diabetes and high cardiovascular risk or with underlying cardiovascular disease. It's important that patient education is key with GLP-1 receptor agonists, that GI side effects are common. It's important that we tell people that they need to anticipate nausea, and this could be transient. And when you're administering it with any other agent, especially like sulfonylurea or insulin, it's important to make people understand that they need to reduce it. When using oral GLP-1 receptor agonists, a correct usage will ensure the maximum bioavailability. I'll probably stop there, and thank you very much for the opportunity.
Thank you, Anand. And I think the questions will be taken in the end of the session. And next is by Dr. Suresh Prabhu, and he is a consultant in endocrinology in Coimbatore, and he's got his training in CMC Vellore, and he's going to talk about MR antagonist. And
Arun, good afternoon, Arun. My talk is on anabolic agents, osteoanabolic agents. Am I audible?
Yes, sir, you're
you
audible.
are audible.
Yeah, thank you. Outset, I thank the organizers Enrich team for this opportunity. For the next 10 minutes, I'm going to discuss about the updates in osteoanabolic agents. So any agents that increase the bone mass are called as osteoanabolic agents. These anabolic agents have the potential to increase the BMD. And another important thing is they restore the microarchitecture and restore the fracture risk to a greater extent compared to anti-resorptive. So this is the basic difference between the anabolic and anti-resorptive. They actually restore the bone microarchitecture. So who are the candidates for anabolic therapy? So any patient who have high risk for fracture with prevalent vertebral fracture are candidates for anabolic therapy. And a patient who have very low BMD of less than 3, or patient who incur fracture or bone loss, or persist to have osteoporosis despite therapy are candidates for anabolic therapy. So it is important to understand the difference between an anabolic and anti-resorptive. Normally, in a young adults, the bone remodeling happens slowly. At an older age, particularly postmenopausal, there is increased number of bone remodeling units, and this in turn leads to negative remodeling balance. So what does the anti-resorptive therapy does? It reduces the remodeling compared to anabolic, where the modeling happens initially, followed by increased remodeling and positive remodeling balance. So this is what happens. So this is the increase in BMD obtained with anti-resorptive therapy result from preservation of the existing bony structure, a closing down of the remodeling space, and increased mineralization of the structure. In contrast, the anabolic agents in turn leads to a positive modeling initially for the first 6 months to 1 year, and later they increase the remodeling by increasing the number of remodeling units. So this is what we call the concept of the anabolic window in any anabolic agents. Initially, if you see the bone turnover markers, there is increase in the bone formation markers for the first 6 to 12 months. Later, the resorption markers also increase, and at around 24 months, it actually comes. And that's the reason why we use these medication for around 18 to 24 months. So this is the basic difference between an anti-resorptive. If you see alendronate, both the formation and resorption markers are suppressed, and it is suppressed throughout the period of treatment, compared to teriparatide, which is an anabolic agent, where the formation markers increases initially, which is followed by the resorption marker. The romosozumab, which is a sclerostin antagonist, it initially have an anabolic agent followed by anti-resorptive. It is a mixed agent, has been classified under anabolic therapy. So this is the classification of anabolic therapy. It is classified into two groups depending upon whether it improves organic bone tissue or inorganic bone tissue. The organic bone tissue is improved by calcium and vitamin D. Inorganic bone tissues are improved by the PTH-mediated therapy, anti-sclerostin therapy, and strontium granulate, out of which both the teriparatide, abalo, and romosozumab has been approved for treatment for osteoporosis. So this is the PTH superfamily. The PTH is an 189 amino acid which acts on both PTH1R and PTH2R receptor. Another closely resembling substance is a PTHRP, which is basically increased in malignancy, causes hypercalcemia. The other unrelated protein is TIT39, which acts on the PTH2 receptor. When we see the teriparatide, which is a recombinant human parathyroid hormone, the first 34 amino acid of the N-terminal, which have the potential, most of the potential of the teriparatide, compared to abaloparatide, which is PTHRP-mediated synthetic analog, contains first 34 amino acids. It is identical to PTH, has the first 122, but later the amino acid differs. So this is basically how they differ. There are two configurations of PTH receptor. One is PTH-R0 and PTH-RG. The PTH teriparatide acts on the PTH-RO conformation, but the PTH-RP acts on the RG configuration. It is characterized by the more transient and rapid increase in the cyclic MP that happens with PTH-RP. We all know about the mechanism of action of PTH. It increases the number of osteoblasts, decreases the osteoblast apoptosis, and also increases absorption of calcium from the gut. So leads to increased bone formation. And this is the data we get from the fracture prevention trial, how the PTH improve the bone quantity compared to the bone quality. So in that study, it was proven that it increases the trabecular bone volume, increases the connectivity density and cortical thickness in the patient in a significant way, which is confirmed by both 2D and 3D analysis of the bone, which has been used PTH. So this is the micro CT scan of iliac crest biopsy at baseline and 21 months of therapy. If you see, there is increase in cortical network, increase in cortical thickness, trabecular thickness, and also increase in cortical thickness. So teriparatide improves both cortical and trabecular thickness in patients with osteoporosis. So for postgraduate, it has to be administered 20 micrograms daily, either in the morning or evening. It have a fracture risk reduction at vertebra and non-vertebral structures. It has to be given subcutaneous injection. The adverse drug reactions are very mild, where hypercalcemia and arthalgia can be seen in around 5 to 6% of patients. And important to understand the efficacy of this medication. It is in the fracture prevention trial, 20 microgram reduces the vertebral and non-vertebral fracture by 65 and 53% respectively. And it should not be used in patients with Page disease, which is one of the common association in elderly patients, any patient who have prior radiation therapy, any patient who have metastasis, such as, or any primary skeletal malignancy, such as multiple myeloma, and patients who have elevated PTH or hypercalcemia. In contrast, abaloparatide is administered 80 micrograms subcutaneous daily. And in the abaloparatide comparative trial in vertebral endpoints, it actually reduces the fracture risk in the vertebral fracture risk by as high as 86%. And the non-vertebral fracture also is reduced, but that doesn't meet the statistical significance. And it is actually marketed as Thymolos in Western countries, but it's still not available in India. So other possible future applications or experimental application for teriparatide is include the hypoparathyroidism. We commonly use in post-operative hypoparathyroidism, where patients have a transient hypoparathyroidism, or in patients have permanent hypoparathyroidism following surgery. It has been experimentally used for fracture healing in distal radius and pelvic fracture. It seems to improve the fracture delayed healing or non-union and improve the prosthesis adhesion in patients who undergone a TKR and other thing. And it is used in patients who have very low bone turnover because of treatment of bisphosphonate, who present with atypical fractures or osteonecrosis of the jaw. So second group is the WNT signaling. These pathways are a group of cell wall transduction pathway. They regulate several aspects of cell growth. And there are three types of WNT signaling, but the canonical beta-catenin pathway has been shown to increase the bone mass through renewal of stem cells, stimulation of pre-osteoblast replication, and induction of osteoclastogenesis. So this is the simplified model for WNT signaling. The WNT pathway are activated by binding of a WNT protein ligands to a frizzle-related receptor. This is the frizzle-related receptor. Several factors tend to influence these interaction, and one is the sclerostin, which has been used for treatment of osteoporosis. So it actually passes the biological signal to the Disher protein, which in turn release the beta-catenin into the transcription for gene expression. And there are several factors has been possible future therapeutic targets for treatment of in both cancer and also in osteoporotic treatment. The commonest thing is sclerostin, it is secreted by osteocyte, which inhibit WNT signaling. The WNT inhibitory factor, secreted frizzle-related protein, glycogen synthase kinase, proteinolytic system, and histone deacetylase. So romosozumab has been approved for treatment of osteoporosis. It is a monoclonal antibody against sclerostin. And it has to be given in a subcutaneous injection of 120 milligrams per day for at least 1 year. And in that study, the FRAMES trial, it was shown to reduce the fracture risk, the new vertebral fracture risk by 75%. And it doesn't have a significant effect on the hip or non-vertebral fracture. It has been marketed as Evanity and still not available in India. So it has to be administered 220 milligrams subcutaneous in 2 syringes for 12 months. It has been shown to improve the vertebral fracture. But the adverse drug reaction there is a raised incidence of myocardial infarction, stroke, and cardiovascular death. There's a slight increase in risk compared to the placebo. The regulatory bodies have issued warning regarding this one, that hence it has been approved for treatment of osteoporosis when other therapies are not available or not tolerated by the patients, and the patient have with vertebral fracture. So strontium relenate is an alkaline earth divalent. It's a trace element in the human body. I think it was introduced in 2006 when I'm doing my DNB in Vellore, and it has to be given in 2-gram granules every day. Its structure resembles calcium, but its molecular weight is twice that of the calcium. It stimulates both bone formation, and inhibit the bone resorption. It gets absorbed and predominantly deposited in the trabecular bone, and it acts on the calcium sensing receptor and promote bone replication, differentiation of human primary osteoblast. In the 2 phase 3 trials, the SOTI and TROPOS trials, it has shown to relative risk of developing vertebral fracture is decreased by 41 and 39%. But because of its increased side effects, particularly the cardiovascular and skin side effects, there is a morphea-like skin lesion developed in patients taking these medications. And also, in post-marketing studies, it was shown to increase the myocardial infarction in patients taking these medications. So it was withdrawn by the original promoter of this drug, Servier, but it is still available in several countries, which is marketed by other companies. So it is important to know that when a patient is on anabolic therapy, when they complete the therapy, it has to be followed by anti-resorptive therapy. Otherwise, whatever gain they have achieved over the first 1.5 to 2 years will be lost by it. In the PATH study and data study, it was confirmed that it should be followed by an anti-resorptive therapy to maintain the gain which is got by the anabolic therapy. So this study, which was published in Benjamin Leader, which is optimizing sequential and combination therapy, we see there are 3 groups of patients. One is PTH with alendronate, PTH with zoledronate, and PTH with denosumab. If you see, when bisphosphonate was used, the combined treatment therapy is actually similar or lesser compared to the individual therapy. So when they combine with a teriparatide with denosumab, then the combination therapy is shown to increase the BMD better compared to bisphosphonate. So this is the importance when we want to combine or when to increase the bone density much more faster. It is rather useful to combine denosumab and teriparatide. This is for the postgraduate. What is denosumab? So we know that there is a rank ligand system is happening in the bone. The osteoblast secretes a rank ligand, which actually activates a rank which is present on the osteoclast by increasing formation and activity and survival. The rank ligand, the denosumab, is a monoclonal antibody against this rank ligand. It actually suppresses the rank ligand and subsequently lead to osteoclast apoptosis. So it has to be given as 60 milligram every 6 months. As the fracture risk reduction has been shown in all 3 sites, vertebral, non-vertebral, and hip, and it should be administered subcutaneously, not intramuscular. And adverse drug reaction include body pain and back pain, and also hypocalcemia. So this is my last slide. These are the experimental agents which are available, are in the market to be available. This is a PTH bar and arrestin pathway selective agonist for parathyroid hormone. And other things include the growth hormone therapy, tissue growth factors and bone morphogenic proteins, neuropeptide Y, and WNT signaling pathway. So in future, we may get these medications for treatment of osteoporosis. Thank you.
Thank you, Dr. Suresh. And the next talk is by Dr. Anjali Satya. And she is going to talk about MR antagonist.
Am I audible?
Yeah, you are audible.
And my screen visible?
No, ma'am, your screen is not visible.
Not visible? Screen is visible.
You're visible, madam. Madam, can
Is
go
it-
ahead, please.
Okay, yeah. Very good afternoon. Yeah, so the next 10 minutes, I'm going to talk about melanocorticoid antagonists. At the outset, I would like to thank the Enrich 21 team for this
Ma'am,
opportunity.
sorry to interrupt, but the
Yeah.
screen is not visible.
Oh, sorry. Now is
You
it
need
visible?
to you need to share your screen, ma'am. You can open your PPT first, and then you can share
Yeah.
that screen. Yeah.
Is it visible now?
Yes,
Yeah,
yes.
now it's visible. Just put it
Okay.
in a slide mode and
Yeah, sure. Is it
Thank you.
okay?
perfect.
Yeah, thank you.
Please,
Thanks.
please go ahead.
Sorry for the, yeah. So this next 10 minutes, I'm going to speak on melanocorticoid antagonists. Now, these are a group of drugs which antagonize the actions of the endogenous melanocorticoid aldosterone. Now, aldosterone, as we know, it acts on the melanocorticoid receptor, which is an intranuclear receptor. And what it does is it works on the distal nephron, the distal tubule, and it increases the expression of the epithelial sodium channels that leads to increased sodium reabsorption from the tubule. And it also increases the expression of the sodium potassium ATPase on the basolateral membrane, leading through which the sodium is pushed out and potassium is brought in. So this particular melanocorticoid in this way starts exerting its action and leads to sodium and water retention and potassium secretion. Now, aldosterone, in addition to its epithelial actions, has also been found to have non-epithelial actions. So what you saw was the renal action now. It also has important actions on the vascular endothelium, where it causes shrinking and increased mechanical stiffness, leading to endothelial dysfunction. It has a prominent effect on the cardiac and vascular system. It causes fibrosis, mainly by expression of procollagen genes and fibroblast-dependent interstitial and perivascular collagen deposition, leading to myocardial fibrosis and also fibrosis in the vessels. A very important effect which we like to block in reducing cardiorenal outcomes. It has an important effect in hypertension by causing arteriolar vasoconstriction and indirect effects on gluconeogenesis, dyslipidemia, where it has adverse effects. So to summarize, melanocorticoid receptor activation through its action on sodium potassium ATPase channel, it causes salt and water retention, and that leads to worsening of both systemic and pulmonary hypertension. It also causes endothelial dysfunction, as is seen by an increase in oxidative stress. And this leads to atherosclerosis, aortic sclerosis, stroke, and MI. It causes more, it's a pro-inflammatory agent, and that is seen by increase in MCP1, IL-6. These are the markers of inflammation. This is found to be elevated, and by causing inflammation, it causes LV and RV dysfunction. It leads to fibrosis, which leads to cardiac arrhythmias. So the uses of MR antagonists would thus be seen in the following conditions. It has a very important role in resistant hypertension. Resistant hypertension is a condition where hypertension is not controlled with 3 agents, including a diuretic. MR antagonists have got a very important role there. It also has an important role in heart failure, both with reduced EF and preserved EF. It has a role in primary hyperaldosteronism, any cause for secondary hyperaldosteronism, and also in post-MI complicated by reduced EF. So what are the benefits of using MR antagonists in these conditions? Now, we know in heart failure, we predominantly use loop diuretics. An MR antagonist therapy reduces the risk of hypokalemia when used concomitantly in these patients. Locally produced aldosterone in the failing heart is blocked by mRNA. Now, aldosterone synthase is, it is expressed even inside the ventricular muscle, and that can lead on to fibrosis and secondary arrhythmias. And by using MRA, we can block this action. It reduces markers of collagen synthesis, as I had mentioned earlier, as is seen by reduced levels of propeptide type 1 and type 3 procollagen, and reduces fibrosis. And it downregulates tissue markers of inflammation and fibrosis like galectin-3 and TGF-beta. So thus having very important effects. So where does this MRA come? We know that RAS inhibitors, we have studies to prove that RAS inhibitors have a very important role. SGLT2 inhibitors have come a very, in a very important way. Now we have got several studies, including recent DAPA heart failure and DAPA CKD trials showing very important role of SGLT2 inhibitors in cardiorenal syndrome. And MRAs is only going to add to these two agents. How? Now, if you look at the inhibition of RAS blockade and SGLT2 inhibition, the RAS blockade causes efferent vasodilatation. SGLT2 inhibition causes afferent vasomodulation. Both of these essentially leads to reduction in glomerular pressure. And because of this, there is reduction in albuminuria. So renal protection has been proven with these two group of agents. And when used together, there is an additive effect. Now we know that there is a bidirectional crosstalk between the kidneys and the heart, as is seen in the cardiorenal syndrome. And this essentially happens because of risk factors like diabetes, hypertension, obesity, which leads to RAS activation, stimulation of the sympathetic nervous system, and other pro-fibrotic pathways, which leads to fibrosis in both the heart and the kidneys. And so the emerging treatments for diabetic renal disease now, in addition to the RAS inhibitors, SGLT2 inhibitors, now MRAs are going to come in a very big way to treat these patients. So what are the current medications that is available? So spironolactone was the first drug that was launched as an MR antagonist, but it was introduced into the market as a potassium-sparing diuretic. This is a steroidal type of mineralocorticoid receptor antagonist, and this has predominant action on the kidneys, and hence hyperkalemia is a major risk factor. But its action is not very selective. It also works on the progesterone. So it is a progesterogenic agent. It is an anti-androgenic agent. So it also has multiple other effects, and that leads to the adverse effect profile of spironolactone, namely breast tenderness. It causes menstrual irregularities in women. It can cause weight gain, water retention, and so many other reasons. So the next group that has come in the market is eplerenone, which is more selective, but again a steroidal MRA. Its action on kidney is almost 3 times, it's not compared to spironolactone, which is 6 times potent. Here it is 3 times action is seen on the kidneys. No effect is seen on the other steroid hormone production, and hyperkalemia risk is definitely there, as is seen with spironolactone. The newer agent is the finerenone, which is a non-steroidal mineralocorticoid antagonist. It has less effect on potassium because it has equal effect on the heart and the kidneys. Highly selective, and its affinity is also high, but it does not have much BP lowering action. The BP lowering effect of finerenone is only to the tune of 1 to 2 millimeters, but it has equal effects on the heart and the kidneys. So if we compare the three, this table highlights it. Spironolactone and eplerenone are the steroidal groups of the mRNA. Finerenone and the newer class of agents, some in the pipeline, are non-steroidal in nature. Potency of spironolactone is very high. Selectivity is low. It also has other effects. And tissue distribution in kidney is seen almost like 6 times than that seen in the heart. Eplerenone, lesser, 3 times seen in kidney than in the heart. Selectivity is medium. And when we look at the newer finerenone, which is a non-steroidal MRA, it has very high potency, very high selectivity, and no active metabolites, and it has equivalent action on the heart and the kidney. So I'll come to the other drugs in the pipeline later. So just to talk about the properties, spironolactone is 100% bioavailable, 90% protein bound. Its mode of excretion is primarily renal, half-life of 1 to 2 hours. And metabolites, because it is converted to metabolites, it has an extended half-life of 10 to 35 hours. There is a need for a small dose spironolactone, as was mentioned earlier. So we start with a smaller dose of even 12.5, then step it up to 25 milligram. Before we start these MRAs, we should always monitor the serum potassium levels, see the GFR of the patient, and these are very important before we initiate therapies. Regarding eplerenone, it is 50% protein bound, and its mode of excretion is also primarily renal. It is starting dose of 25 milligram once a day, and then it is stepped up to twice a day. but it has got several drug interactions with the CYP348 substrate inhibitors or stimulators. So drug interactions are very common in eplerenone. Regarding finerenone, which has equivalent action on the heart and the kidney, again, we need to monitor the serum potassium, see the GFR of the patient before we initiate. The starting dose of finerenone is 10 milligram once a day. And once it is started, we need to monitor the GFR. If GFR has reduced by more than 30%, stay at the same dose. Don't double the dose. Otherwise, usually it's stepped up. If serum potassium is also going up on therapy, again, we need to consider either reducing the dose or interruption of therapy when the potassium exceeds 5.5. Now, we need to look at the evidence where there are several important trials that were conducted with these agents. So a RAL study was done in 1999 with spironolactone. This was studied on patients with heart failure for more than 6 weeks with an ejection fraction of less than 35%, where they were already on ACE inhibitors, beta blockers, loop diuretics, and potassium supplements, where spironolactone was initiated with 25 milligram for 2 months and then finally stepped up. So the outcomes, in addition to cardiac benefits, all-cause mortality in this RAL study, the risk reduction was to the tune of 30% when spironolactone was added to standard therapy. The other studies which are done in eplerenone, the two standard, I think this you should be aware of for the postgraduates, the EPHESIS study which was done in 2003 and emphasis heart failure in 2010. The first study, EPHESIS trial, was done in post-MI patients with ejection fraction less than 40%. And these patients were also already on other medications like ACE inhibitors, beta blockers, diuretics, where eplerenone was started with 25 milligram and stepped up to a tolerated targeted dose of 50 milligram, and the follow-up period was only 1.3 years. The emphasis trial was not on post-MI patients, but with patients with frank failure, NYHA class 2 with ejection fraction of less than 30%. So what was seen in these studies, in the EPHESIS trial also, the relative risk of cardiovascular mortality and cardiovascular hospitalization due to reduction in heart failure admissions were definitely less with eplerenone compared to placebo. Now, finerenone initial studies, phase 2 studies, were done in smaller number of patients where it was compared to the cousin molecules, spironolactone and eplerenone. So in this initial study, phase 2 trial, where 457 patients with heart failure were enrolled, these had ejection fraction less than 40%, where finerenone was compared with spironolactone. The effect on reduction in proteinuria was very similar. Also, the reduction in markers were also similar, but the incidence of hyperkalemia with finerenone was much less compared to spironolactone. In the second trial, where over 1,000 patients with heart failure patients and CKD, it was compared with eplerenone. Here again, it was found to be superior. Especially this was not very, they had seen at 12 weeks, the outcomes were much better compared to eplerenone. But again, the effect on proteinuria, reduction in proteinuria and the reduction in markers of inflammation was similar. Now, this was again a third study where patients with proteinuria were studied with finerenone, and it was documented that the reduction in albuminuria was dose dependent. So different dosages of 10 versus 20 milligram were studied, and it was found to be dose dependent. The recently published trials, one was a Figaro DKD, where cardiovascular outcomes were looked at in patients with diabetes and kidney disease. Here, patients who are in stage 2 to 4 DKD with microalbuminuria and GFR between 30 to 90, or those with macroproteinuria and GFR of at least 60 were included in the trial. The primary outcome was to look at a composite of cardiovascular death from cardiovascular causes, non-fatal MI, non-fatal stroke or hospitalization, and the secondary outcome was a composite of kidney failure or a sustained decrease from baseline of at least 40% of the GFR or death from renal causes. And what was seen was this: in the finerenone group, it was definitely much less. The hazard ratios were definitely less in all the primary as well as the composite of secondary outcomes. The second trial study, which had again recently been published in NEJM, is the Fidelio DKD, where they looked at the effect of finerenone on the renal outcomes where over 5,000 patients were enrolled with type 2 diabetes and CKD. Here, the primary outcome was to look at the renal failure with more than 40% decline in GFR over a 1-month period or death from renal causes. And here, the secondary composite outcome was the cardiovascular mortality. And it was very well seen when finerenone was compared to placebo that after a 2.5-year follow-up, that there was definitely a reduction in primary outcomes by 17% seen in finerenone group and 21% in the placebo, and also in the cardiovascular mortality in the finerenone group. So this is seen here. Both the primary outcomes were much lesser in the finerenone group, and also the secondary composite outcome was much lesser. The second and the third graph are the follow-up graphs. That is, they were followed up for a period of 4 weeks, and these effects were persistent in the finerenone group. In the pipeline are the newer drugs. Interestingly, this aperinone has been, this is in development by a Japanese company. And this has been studied in not only in patients with diabetic nephropathy, where they have looked at reduction in proteinuria, but they have also looked at aperinone in patients with NASH. Here, they looked at the markers of fibrosis in the liver and also reduction in ALT levels. This was a 6-month phase 2 trial where they found benefits, but it's still not in the market. Another group of MRA is exacerenone, again developed by a Japanese country. This has a very strong antihypertensive effect, and it is also a non-steroidal selective MRA undergoing phase 3 trials in diabetic kidney disease, yet to come in the market. So now looking at the side effect profile of the MRA, the first generation spironolactone, as I said, because of its low specificity for mineralocorticoid receptors and its progestogenic and anti-androgenic effect, it causes gynecomastia, erectile dysfunction, menstrual irregularities, and significant hyperkalemia compared to the newer agents. The second generation eplerenone is more selective for MR with 40 times more lower affinity, but it reduces the adverse effects, but the clinical efficacy comes down with reduction in the adverse effect profile. The third generation, as I said, finerenone has a very high potency, high selectivity, has equivalent effect on both the heart and the kidneys, so the side effect profile is much superior. Now, what are the risk factors for hyperkalemia when we use MRA? So, hyperkalemia,
Madam, just the time factor, madam.
Sure. Now, MRA, the significant side effect is hyperkalemia, and we need to watch. I think this is the second last slide. One is this adverse effect of hyperkalemia seen with much higher doses. Also, if the pre-therapy serum potassium is more than 4.5, we have to be watchful. If they are already on high potassium diet, again, we need to be careful. Patients with diabetic kidney disease, if they have a low GFR, especially if the GFR is falling below 30, please stop these group of agents. Volume depletion can happen because of concomitant use of loop or thiazide diuretics, and one needs to be watchful about this electrolyte disturbance. Older age individuals, again, we need to be very cautious when using these agents. So the message in this slides are: one, we know that RAS inhibitors and SGLT2 inhibitors are highly effective in slowing the DKD progression in diabetes, but there is an unmet need that is essentially preventing inflammation and fibrosis that is not acted upon by the other two agents. Though we do have some data showing that SGLT2I also may have anti-inflammatory effects, but MRA targets these two things. So it targets the underlying pathway of inflammation and fibrosis that drives DKD or progression to end-stage renal disease. So it has a great role to play. In future, instead of saying MACE outcome in validating drugs for cardiorenal syndrome, we need to now have medications with beneficial effects on both heart and kidneys, and that's going to be the mainstay of future. So with that, I conclude my presentation and I'm happy to take the.
Thank you very much, madam. I think we crossed the time. I just want to ask just a simple question. Can I see any questions there? Okay, I can't see any questions there. But I just want to ask, I mean, you mentioned about finerenone, which is like a non-steroidal, you mentioned. I just want the disadvantages of these drugs. There are so many disadvantages of the drugs, and MR antagonist is going to be probably after the Rawls trial, the spironolactone usage is improved. And I think eplerenone is being used more by cardiologists, I should say. But after that, I think finerenone is making an impact even in diabetes conferences. So I want your view on the challenges or the disadvantages of finerenone in terms of being a non-steroidal action.
Yeah. So the finerenone, as I think I mentioned it very clearly that these drugs, hyperkalemia is the most important electrolyte abnormality we see. Now we are going to use these group of agents in sicker individuals, people who are already having diabetic renal disease with an underlying cardiovascular problem or an established atherosclerotic cardiovascular disease. So here these patients are likely to be volume depleted. They are not on MRA alone. They are already going to be on loop diuretics. They may be already on RAS inhibitors. So in these patients, following up the especially GFR monitoring and electrolyte monitoring is important. Now, in addition to hyperkalemia, hyponatremia is also a very important side effect in finerenone. Especially they say give a black box warning in elderly individuals, SIADH, if it is already present, may actually be worsened when we use finerenone.
Yeah,
so I think when we use these medications, these are coming with very great promise because of its effect in cardiorenal syndrome. But as clinicians, we have to be very, very vigilant. The data is very, very overwhelming, but we need to look at both the sides when we use it.
As a specialist who treat diabetes, I think this is like very exciting drugs, which probably it is not in our radar for a very long time, and that should be used appropriately if we can. As you rightly pointed out, there will be multiple other drugs will be there already in the pipeline when you try to use these drugs. So that's a challenge I think you need to put on the right people. Coming to Suresh, strontium usage, you mentioned very clearly, it has got its own side effects. I just want to know what are the main advantages? I know there are a lot of challenges with bisphosphonates and anabolics, but strontium has got its role, and even the NICE guidelines had got a strontium in a role. But I just want to know your views, whether it will be available as a metal. It's a metal, strontium is. It is whether it is available in India, whether there's any chance of getting it.
Yeah, I checked with in the net. I think certain companies are still marketing strontium in India. Certain not by the innovator. The surveyor is the innovator who actually introduced the strontium, but other companies are still marketing this one. But since we don't have any guidelines for treating these medications, because the guidelines for treating osteoporosis doesn't include strontium recently because of its side effects. So for that reason, when other agents are not applicable to the patient, when they develop more side effect, this can be tried, but we have more agents which have better side effect profile and better efficacy in terms of osteoporosis treatment are available. That's the reason I think the usage has also gone down. That's one of the reasons why the surveyor has also stopped that one. Since we have a good agents available, I think better we should go to that one rather than strontium.
Just quickly, in terms of postgraduates, the cost, I mean, bisphosphonates, we know the cost, weekly ones and yearly ones. But I think in terms of strontium, what is the cost?
Exactly, I don't know. I think the daily cost crosses around 120 rupees. It's what that was, and way back in 10 years back when I used in CNC.
How much is it? Sorry?
Around 120 rupees. That's what I remember. I think.
So coming to Anand, just very quickly, I want to ask. Oh, you want to ask something? Please go ahead.
One small comment on strontium. I think as Dr. Suresh pointed out, the couple of companies were marketing this in 2005-6 in Chennai, and they used to meet us regularly. The one another point, I'm sure it would have been mentioned, I missed the talk, is strontium. Theoretically, as an MCQ question, it can be answered as both anabolic and anti-resorptive, but it deposits on the bone and it increases the bone density. So fallaciously, you cannot monitor BMD.
Yeah.
That's another major problem. Cost is also, as he put it rightly, in 2005, it was not less than 100 to 150 rupees per day.
But it's a very useful drug in terms of, I mean, FDA has not approved it. European countries had it. But in terms like when you
there is one NEJM paper, if I recollect correctly, on fracture and the two vertebral fracture. Hip fracture data, dicey. What has happened in this? Because people lost interest, and I think, what is not marketed and what is not, science is not vociferously spoken also goes out of people's mind. Out of sight is out of mind.
Has to be.
As Dr. Sriram has correctly mentioned, we have a correctional factor for when the patient is on strontium. There is a formula to correct for the BMD when the patient is on strontium. So I have not mentioned because of the time, but it is there. We have to correct it for that one when the patient is on strontium to know the exact BMD gain when the patient is getting. It overcorrects the BMD because of its metallic nature and deposit in the cancellous.
Anand, very quickly, there's in terms of time is just almost gone. It's gone. Just very quickly, the GLP-1, GIP, Lilly drug, it sounds too good to be true. I mean, the A1C reduction, the weight reduction. So what is your view on that?
Yeah, I think, right from the phase 1 and phase 2 trials, I think it has been creating waves in terms of the efficacy. So the efficacy is phenomenal. I think, once we get the CV outcome trial data and also in terms of tolerability data, that's going to be the key. Because if you look at the side effect profile, obviously the GI side effects seems to top. So it's like, it's pretty high. It's pretty high. So how much people are going to tolerate these doses are questioned. So if you look at, not only just in terms of, diabetes, in terms of weight reduction, also it is just phenomenal in terms of things. So it looks like a wonder drug, and I think all these, co-agonists or triple agonists, whether it's GLP, GIP, glucagon, the triple agonists also, all these look very, very impressive. So, time will answer.
Thank you very much for this a wonderful presentation. Give a big hand to all the 3 speakers, Dr. Suresh Prabhu, Dr. Anand Kumar Annamalai, and Dr. Anjali Satya. Thank you very much for being a really informative talk and just clarifying our doubts. Thank you.
Thank you.
Thank you. Thank you very much, sir.
Thank you, Dr. Suresh Damodaran, Dr. Arun Kannan, for nicely conducting the previous session, which was highly informative, and thanks to all the speakers. Quickly going on to the next session, may I invite Dr. Vijay Bhaskar Reddy for the next discussion, and he will take over the mic now.
Good afternoon. Welcome to today's expert panel discussion on thyroid dysfunction in pregnancy. It's an important topic, and awareness about thyroid dysfunction in pregnancy is increasing. There are a lot of changes in guidelines and recent updates. It's very important for us to have this expert panel discussion, which will be case-based. So I invite the panel members, Dr. Kumaravel, endocrinologist from Madurai Alpha Hospital and Research Center. He'll be available here along with me. Dr. Sivan Arul Selvan. Dr. Sivan is there?
Yes, I'm there.
Yes, Dr. Sivan, welcome. Dr. Sivan is endocrinologist from Tirunelveli, and Dr. Kripa Elizabeth Cherian from CMC. Dr. Kripa. Good afternoon, welcome.
Yeah.
So thyroid dysfunction in pregnancy is common, and we know that pregnancy itself causes alteration of various thyroid function tests. We have to differentiate the changes due to pregnancy versus disease, because this is what will make us decide whether we want to treat it or not. So if we do not identify thyroid disease, it can affect pregnancy and fetus, whereas pregnancy-induced alterations tend to get better on its own. So early detection treatment is beneficial. So we know this untreated hypothyroidism, which is the most common thyroid dysfunction in pregnancy, can have adverse maternal and neonatal outcomes. In the maternal side, we can have premature delivery, low birth weight, pregnancy loss, and gestational hypertension. And from the neonatal side, low IQ, which is a very well-recognized entity, and with severe hypothyroidism, fetal death. These are all well established for overt hypothyroidism. But for subclinical hypothyroidism, the linkage is not very clear, but still there are sufficient data for us to treat. So I'll move on to few case scenarios about thyroid dysfunction pregnancy, and we'll discuss this with the help of the panel members. So the first case, 28-year-old lady, primigravida, 2 months gestation. Just routinely, she had a TSH done. TSH was 3.3, and the patient was referred to us with a TSH of 3.3. So we know that over the years, the guidelines have changed about what is the normal range for TSH in pregnancy. So I request Dr. Kumaravel to discuss what is the normal TSH during pregnancy. Before that, I would like to highlight this changes during early pregnancy. We know that HCG and TSH, they belong to the same family, and the HCG levels typically peak around 10 weeks. And when the HCG goes up, HCG itself stimulates the TSH receptor, increasing the T4 levels, and gradually there is a reduction in the TSH level. This is an important physiology which we need to understand in early pregnancy. The elevation of the HCG levels, typically peaking at 10 weeks, is associated with suppression of the TSH level. So we know this. It's important physiology to understand the changes in thyroid function test in early pregnancy. We can see after 12 weeks, the HCG level starts coming down and TSH level starts going up. So with this review of the physiological changes in early pregnancy, I request Dr. Kumaravel to discuss about what is the current normal TSH during pregnancy.
Thank you, Dr. Reddy. I think the physiology of thyroid keeps changing in pregnancy. Even in pregnancy, every trimester, the physiology changes. So similarly, your normal TSH value also changes. I think in our case, it's a primigravida with a TSH of 3.3. And as rightly said by Dr. Reddy, also the guidelines have changed. I think still many of us are using the guidelines 2011. I think in 2011, when you try to look at those guidelines, this TSH is definitely abnormal because that guidelines said in first trimester, your TSH should be less than 2.5. Second and third trimester, it should be less than 3. And these data was based on a very limited population of roughly around 5,800 or 6,000 patients. But then in 2017, ATA came with a revised guideline, which was based on data of roughly around 60,000 subjects. And they also included subjects with the iodine status, anti-TPO antibody levels. They also looked at the BMI. And based on that, the TSH cutoff, they changed the TSH cutoff. And what they said is, whenever feasible, you should always have a population space-based TSH normative data. Unfortunately, in our setup, we don't have a population-based normative data. So in such scenario, we are based on other data which is available. In such scenario, what they say is that if you don't have a population-based normative data, you can take a TSH of less than 0.5, the upper limit of normal, which is 4.5. So when it is less than 0.5 and 4.5, your TSH normal in first trimester of pregnancy, current guidelines is roughly around 4 for our subjects. So anything up to 4 could be normal, and our patient, it is 3.3. So I would definitely consider this as normal for this pregnancy of first trimester.
Thank you, Dr. Kumaravel. I think he has rightly pointed about the changes in the American Thyroid Association guideline between 2011 and 2017, where they have changed the cutoff from TSH of 2.5 to TSH of 4. Yes, Dr. Sriram.
I think one more point is, I'm sure you would have mentioned probably is timing of sample, lab quality. I think that also should be mentioned because we are discussing minute differences of 0.5, 0.6. There is not less than 2 papers in both in pregnancy itself. Time of taking the TSH, postprandial TSH, etc., are also being commented. And we were fortunate to do one meta-analysis on pregnancy and TSH. This was published 3 years back in Indian Journal of Endocrinology. That time, pooling all the Indian data, the higher limit of TSH was even up to 6. We have commented that. So rightly pointed out by Kumaravel, is that this 2017 ATA includes Indian Dr. Marwaha's paper, which looked at the higher TSH. I think we are behaving differently. I think it's absolutely correct. 3.3 could be for all practical purpose normal.
Thank you, Sriram. I think he highlighted about the timing of TSH. I think that is routinely for all thyroid functions. So next we move on to ethnic and population-specific criteria. I request Dr. Sivan Arul Selvan to highlight about do we have an Indian cutoff for TSH value during pregnancy, Dr. Sivan?
Yes, am I audible?
Yes, Sivan.
Yes, there are a few studies from India. There are at least 7 studies I could go through. The initial study was done in 2003, which was not published, available in abstract form. And then, as Dr. Shira mentioned, there is a study from Delhi in Marwa, in which the upper limit goes up to 5 in the first trimester. Then we have several studies from North India as well as South India. The most recent one is from West Bengal, 2018, published by Pramanik et al. The recent cutoffs is more or less similar to the ADA guidelines. In the first trimester, the upper limit was 4.3, and the second and third trimester, the upper limit was around 4.6 in the latest study. But it is difficult to compare all these studies because the methodology is different. Initial studies were done with ELISA, currently with chemiluminescence assay. And then we are iodine in the transition phase. Initially, the iodine insufficiency might be higher in 2008. Now we are becoming more and more iodine sufficient. So because of this iodine transition state, it is difficult to compare all these results. But the most recent ones suggest it is more or less in correlation with the ADA. It is around 4.3 for first trimester and 4.6 for the second and third trimester.
Thank you, Dr. Shivan. I think you're also highlighting the same factors which Dr. Kumaravel was telling. We need more studies in the Indian context so that we can establish a clear cutoff. Until then, we would take TSH 0.5 below the upper limit of normal of 4.5. So moving on to the case, Dr. Kripa from CMC Velur. So this case, a 28-year-old lady, primary gravida of 2 months gestation, routinely done TSH 3.3. So would you say that TSH is normal and you leave it, or would you do any other tests, or would you consider treatment in this case, Dr. Kripa?
So thank you, sir, for that question. So as we all were discussing about the change in guidelines, so currently the upper limit of normal is taken as 4. So for this lady who has presented right now, at this juncture, her TSH is normal and she does not warrant treatment. However, the guidelines also do mention that for a TSH that is more than 2.5, the anti-TPO antibodies will need to be measured. So if at any point of time such a lady has a history of an anti-TPO antibody positivity, she does not warrant treatment at present, but she is at risk of a subclinical hypothyroidism as gestation advances. So if there is a history of anti-TPO positivity, it is required that her TSH be monitored every 4 weeks. And if at any point of time it is more than 4, then that would warrant treatment. At this juncture, she does not require treatment.
Thank you, Dr. Kripa. So I think she has clearly told that if we have anti-TPO antibody positive in this case, we might consider treatment. Otherwise, this case does not require treatment. So this is the approach given by the American Thyroid Association guidelines of 2017. So where they recommend that any TSH less than 2.5, no further workup is required. But like in our case, TSH of 3.3, which is between 2.5 to 10 or 2.5 to upper limit of normal, that's 2.5 to 4. If we have a TPO antibody positive, then we might consider treatment with levothyroxine. Otherwise, we do not require treatment if TPO negative. But whether to do TPO antibody routinely in all our cases, whether it is cost effective or not, that is the question. So we do not do usually TPO antibody in all the cases, but TPO antibody is available. It will help us in decision. Thank you, Dr. Kripa. We'll move on to the second case, 30-year-old primigravida, 6 months gestation. The gynecologist referred for an abnormal thyroid function test, TSH of 0.7, which is clearly in the normal range, and a free T4 of 0.5 nanogram per deciliter. So Dr. Kumaravel, would you highlight how would you approach this case and what will be your diagnosis?
Yeah, I think here we have a patient with low free T4 and normal TSH. If this patient has not been pregnant, our first diagnosis would be to rule out central hypothyroidism. But having this is a pregnant state, it could be a isolated hypothyroxemia of pregnancy where you have a low free T4 and your TSH is normal. And in pregnancy, naturally your free T4 could be low, which could be a normal physiological adaptation also. So my diagnosis here would be isolated hypothyroxemia of pregnancy.
Thank you, Dr. Kumaravel. So I think this entity is coming up. So isolated hypothyroxemia is low free T4 with a normal TSH. Kumaravel also pointed out in another setting, we might even have to consider central hypothyroidism, that is due to pituitary cause where the T4 is low, but due to pituitary disease, the TSH does not go up. So we have a lot of assays and labs do a lot of panels, including free hormones and total hormones. So Dr. Sivan, would you highlight free T4 versus total T4 in pregnancy? And are there any issues with free T4 estimation in pregnancy? Would you do a free T4 or a total T4? Dr. Sivan?
Yes. Actually, there are problems with the free T4 assay in pregnancy. The free T4 in pregnancy generally goes down as the pregnancy progresses. There is a problem because of the elevated thyroid binding globulin. The TBG increases in pregnancy, and there is also a fall in the albumin level, and there is also hemodilation. All these can affect the free T4 assay because free T4 assay in the chemiluminescence assay is not a direct test, it is the indirect assay using a T4 analog test. So this T4 analog test can be affected when the thyroid binding globulins are not in equilibrium state and when the albumin is low or TBG is high. This T4 analog test can be falsely low or falsely high according to different patients. So free T4 generally goes down in pregnancy even without any actual hypothyroidism. It is a lab assay problem. So apart from this chemiluminescence immunoassay, there are other direct methods like gel filtration or equilibrium dialysis or LCMS. In all these tests also there is slight decrease in the free T4 levels, but not to the extent which is seen in immunoassay. So that is why the ADA recommends it is better to go for total T4 rather than free T4 in pregnancy. And total T4 you need to increase in pregnancy because of the increase in TBG. Total T4 increases from 7 to 18 weeks, and after 16 weeks, you have to multiply by a factor of 1.5. So it will be around 19, will be the upper limit of normal after 16 weeks. But having said that, generally I don't do free T4 or T4 itself in patients with subclinical hypothyroidism. Only in the thyrotoxicosis it becomes more important. I will like to ask the panelists whether you do routinely free T4 in patients with subclinical hypothyroidism.
Thank you, Dr. Sivan. Thanks for highlighting the problems with the free T4 estimation by the indirect method and the changes in total T4 due to change in TBG in pregnancy. So this is what Dr. Sivan has told. The first graph shows the total T4 which increases during pregnancy. The total T4 goes up by around 1.5 times, and the free T4 assays by different methods come down during pregnancy. That's why it has to be low free T4 has to be interpreted with caution in pregnancy. The serum TBG keeps on peaking up to 20 weeks of gestation, and the total T4 peaks at around 20 weeks of gestation. So it's around the total T4 value in pregnancy is 1.5 times the non-pregnant range. So Dr. Kripa, this case, low free T4 with normal TSH, does this lady need thyroxine, or would you consider doing a total T4 in this case before deciding whether you want to do treatment with thyroxine, Dr. Kripa?
Thank you, sir. So isolated hypothyroxanemia in pregnancy, this has been an area of contention like we discussed. So some studies have actually shown that isolated hypothyroxanemia in pregnancy is associated with some adverse neonatal outcomes in the sense that they are born with smaller head circumference, they have some delay in the motor and language development, and poor and lower IQ scores. So with this background, there have also been studies that have looked at treatment of women with isolated hypothyroxanemia in pregnancy with levothyroxine. But even treatment has not demonstrated conclusively an improvement in these outcomes. So current recommendations do not warrant treatment of this condition. Having said that, like Dr. Shivan was also mentioning, in our clinical practice, we do not do a free T4 alone. We always do a free T4 in conjunction with a total T4. So which will provide corroborative evidence of what really is happening in that particular patient. And the total, and if in doubt, the total T4 can be maintained at 1.5 times the upper limit of normal. So isolated hypothyroxanemia in pregnancy per se does not warrant treatment.
Thank you, Dr. Kripa. So we highlighted that free T4 may be low in pregnancy due to assay problems, and isolated hypothyroxanemia is not yet well established as indication for treatment during pregnancy. So we move on to the third case. 30-year-old lady, 2 months gestation, post-IVF, TSH is normal 2, but TPO antibody was positive, 205, normal range was less than 34. Dr. Kumaravel, would you highlight whether you would consider treatment in this case and why?
Yeah, I think here we have a patient with a positive anti-TPO antibody with a normal TSH. So if it has been a normal gestation, probably I would have not treated this patient, but this is a post-IVF patient. So there are 2 scenarios where we treat positive anti-TPO antibody even with normal TSH1 when there is a previous history of recurrent pregnancy loss or post-IVF. So in this patient, since it's a post-IVF and positive anti-TPO antibodies, I would definitely treat this patient with low dose of thyroxine, say roughly around 25 micrograms. But definitely she has to be monitored. It's the starting treatment is not going to solve this issue. You have to monitor these patients very frequently.
Thank you, Dr. Kumaravel. As he highlighted, TPO antibody positivity in a post-IVF pregnancy has been associated with miscarriages and requires treatment with low-dose thyroxine. So in this note, we know that TPO antibody positivity is thyroid autoimmunity. And Dr. Sivan, any immunological treatment for TPO antibodies available? I have seen some prescriptions of steroid glucocorticoids given for TPO antibody positive. What is your advice? Any immunological treatment is available for this?
Generally, there is no routine immunological treatment for TPO antibody positivity. It is just a marker of background autoimmunity, and you don't. There is no indication to treat immunological therapy for TPO antibody positivity. However, when I went through the literature, there are some usage of IV immunoglobulin in pregnancy for TPO antibody positivity in recurrent pregnancy losses. However, the outcomes are not much impressive and very small reports, and definitely there is no role for any steroids. And there are some studies which show that if use of selenium may bring down the level of TPO antibody positivity. So that could be a reasonable thing, but routinely there is no need for any treatment, and don't use steroids for isolated TPO positivity.
Thank you, Dr. Sivan. Thank you for highlighting the fact that we do not have any specific immunological treatment. Only low-dose thyroxine therapy is required despite a normal TSH. Dr. Kripa, moving on, how will you monitor this case? Should we just start low-dose thyroxine and leave the patient, or do you think the requirements will change? How often would you like to monitor this patient, or repeat a TSH value, or would you repeat a TPO antibody during pregnancy in this case?
So any patient who has been initiated on treatment requires to be monitored, and she will require to be monitored at least every 4 weeks up to mid gestation. targeting a TSH of less than 2.5. And after mid-gestation, that is well beyond the second trimester, she should be monitored at least once at 30 weeks. So any patient who's been initiated on treatment needs to be monitored frequently in pregnancy.
Thank you, Dr. Kripa. I think she has rightly pointed out that because TPO antibody is positive, over time the pregnancy, the thyroxine requirements will increase. If the patient has got TPO antibody positivity, then the required increase in thyroxine may not happen by the patient's thyroid. So we may have to increase the dose and keep the TSH below the required range. Thank you. So we move on to the next case, case 4. So this is a case of second gravida, 2 months gestation, early pregnancy, known case of hypothyroidism of 10 years duration. Patient was already on thyroxine 100 microgram per day and TSH is 2.8. So what is the target TSH? We saw that the normal TSH now during pregnancy, instead of 2.5, we would consider 4. So what will be the target TSH for patients who are already on thyroxine therapy? So would you maintain it at 4 or you want to go down, lower down? Dr. Kumarvel, what will be the target TSH and would you consider dose alteration in this case or would you continue with thyroxine 100 microgram per day?
I think the normal TSH varies in a patient who is a known case of hypothyroid or who has been newly detected to have a hypothyroid in pregnancy. So if this patient is not a known hypothyroid, this TSH of 2.8 in first trimester, I would consider it to be a normal. But since this is a known case of hypothyroidism, the TSH target in first trimester pregnancy should be less than 2.5. The reason because your fetus thyroid starts functioning only by around 6 months. So initially your fetus is totally dependent on maternal thyroxine. And since this patient TSH is 2.8, which is well above the cutoff of 2.5, I would definitely want to increase the dose of thyroxine to at least 25 micrograms so that the TSH is maintained to less than 2.5.
Thank you, Dr. Kumaravel. So he's highlighted the fact that during treatment, we try to maintain the TSH level of less than 2.5 in early pregnancy. Dr. Sivan, once Dr. Kumaravel has told we would like to increase the dose of thyroxine by around 25 micrograms to 125 micrograms per day. And once we increase the dose, how often do we monitor the TSH in pregnancy? Sivan?
Yes. Before that, I'd like to ask Dr. Kumar, suppose the same patient had a TSH of 1, would you still increase the dose, anticipating a near future increased dose requirement?
Yeah, I think if the TSH is 1, I would definitely not increase the dose of thyroxine. The reason is because initially I think whenever your pregnancy is confirmed, the recommendation was to increase the dose to 25 to 30% till you meet a doctor. And because that might take, suppose most of the data are Western data where your appointment with the doctor would take at least 15 to 20 days. So till then you increase the dose. But now our accessibility to a medical care or accessibility to the thyroid testing is easily reachable. So in such cases, if the TSH is 1, definitely I will not increase the dose. And since the TSH is 2.8, I would consider increasing the dose.
So how often to monitor, as mentioned by Dr. Kripa, it should be at least once in 4 weeks till mid-gestation and at least once between 28 to 32 weeks or once a month in first 20 weeks and then at least once in second trimester and once in third trimester. That should be the time to monitor TSH.
Thank you, Dr. Sivan. He has highlighted that towards the later half of pregnancy, the requirements stabilize and we don't have to monitor too frequently later on. But in the initial stages, we have to monitor around at least 4 weeks once. So Dr. Kumaravel also highlighted, in case the patient is not able to come to us for follow-up, then we would blindly increase the dose by around 25%. But if the patient is able to come and we have monitored a TSH, then we go by the TSH level. Over to Dr. Kripa. Do you think only TSH is enough for monitoring or doing a T4 or free T4 in addition helps us in deciding the dose of thyroxine to be given during pregnancy?
So as far as monitoring is concerned, it is enough to monitor a patient on treatment with levothyroxine only with TSH every 4 months. We do not routinely need to monitor T4 and free T4 in a pregnant patient. However, in those rare circumstances, for example, in thyrotoxicosis, we would want to monitor T4 and free T4. Otherwise, a TSH would suffice.
Thank you, Dr. Kripa. She's highlighted the fact that only a TSH is sufficient. We don't need the whole panel for monitoring and adjusting the thyroxine dose during pregnancy. So moving on to case 5, we have only one more case. So this 28-year-old lady, primigravida, at 8 months gestation, and 3 months she was detected to have TSH of 5, for which she was started on thyroxine 50 microgram per day. Patient is curious to know whether thyroxine has to be continued after delivery. Dr. Kumaravel, would you like to highlight, does she require thyroxine after delivery, or is it enough if she takes only till delivery?
I think this is a patient with hypothyroidism detected during pregnancy. So many attempts in such patients, once after your delivery, your thyroid status reverts to normal. So this patient is already on 50 microgram. So we would stop thyroxine once after the delivery is done. And then you recheck your thyroid function test after 6 weeks. In such scenario, probably your thyroid antibody levels would give you a clue whether to continue even after gestation or not. But first time when you detect it in gestation, you can stop thyroxine after delivery and then reassess after 6 weeks.
Dr. Sivan, would you do it any differently, and how will you follow up this patient after delivery in case you decide to stop thyroxine?
Yeah, if the treatment has been initiated for the first time in pregnancy, and generally if the initial pre-treatment TSH has been less than 10 and the dose requirement has remained within 50 micrograms, you can constantly stop the treatment and recheck after 6 weeks, or you can bring down the dose from 50 to 25 if you're not sure, and then recheck after 6 weeks and then decide.
Thank you, Dr. Sivan. So I think we would stop thyroxine and recheck after 6 weeks or 3 months. Like that, we can do the test again. So Dr. Kripa, this postpartum thyroid dysfunction is increasingly recognized, and sometimes we see that they had mild hypothyroidism, subclinical hypothyroidism during pregnancy, and after pregnancy at 6 months, they come with postpartum thyroiditis and severe hypothyroidism. So what is the spectrum of postpartum thyroid dysfunction, and when does it typically manifest, Dr. Kripa?
So usually postpartum thyroid dysfunction is typically seen in the first year postpartum, typically in the first 6 months. So particularly this is more common in women who have positive anti-TPO antibodies, because after pregnancy, there is a rebound of immune suppression that normally occurs during pregnancy. So typically it has a triphasic pattern. That is, the patient can have a transient thyrotoxicosis followed by a transient hypothyroidism with return to the euthyroid state. Otherwise, it can take other forms also. For example, there can just be a transient hyperthyroidism which returns to euthyroid state. Sometimes there is only a transient hypothyroidism. So it can manifest in different ways. 30% of women tend to be permanently hypothyroid. So as far as the problem with postpartum thyroid dysfunction is that because it occurs in the early postpartum period, it is often confused with symptoms of postpartum depression and may not always come to medical attention. So if the patient has subtle symptoms, anxiety, tremors, some palpitation, this requires monitoring of thyroid function tests. Usually it is self-limited, it does not require treatment, but if the patient is severely symptomatic, then she might benefit from low-dose beta blockers. When she has presented with postpartum thyroiditis in the thyrotoxic phase, this requires a distinction from Graves. Of course, Graves is far less common, and in such cases, the distinction can be made based on the TSH receptor antibody and the fact that usually postpartum thyroiditis resolves, whereas Graves might require antithyroid drugs.
Thank you, Dr. Kripa. So we need to watch out for postpartum thyroid dysfunction in these cases. So the last case, a 30-year-old primary gravida, 2 months gestation with hyperemesis. The gyne obstetrician did a TSH level 0.01, referred to us. Dr. Kumaravel, how do you approach this case?
I think here we have a first trimester pregnancy with a TSH of 0.01. I'm sure even in pregnancy itself, your TSH could go down. As we have discussed earlier, how high your TSH could go, it could go up to 4, and how low your TSH could come, even 0.01 could be normal of pregnancy also. But again, whenever you have a hyperemesis or you have a twin pregnancy where you expect your HCG levels to be very high, your TSH could go very, very low. So this could be a thyrotoxicosis of pregnancy. The only choice here is to differentiate between your Graves' disease and your thyrotoxicosis of pregnancy. Going by clinical symptoms is very difficult because pregnancy itself is a hyperdynamic state where you can have a tachycardia, palpitation, tremors, anxiety, sweating, everything is possible. So going by clinical thing is very difficult unless otherwise you have a thyroid orbitopathy or you have a dermopathy, which could be a telltale sign. It could still be a Graves' disease. Otherwise, clinically differentiation is very difficult. And since it's pregnancy, you cannot do a nuclear imaging also. So you are dependent on other investigations like TSH receptor antibody for the diagnosis. And I'm sure my other panelists would highlight on the role of TSH receptor antibody. And Sivan, do you have any comments on TSH receptor antibody in diagnosis?
The TSH receptor antibody in pregnancy can be used in 2 situations. One, as the previous speaker mentioned, when you're not able to decide on the etiology of the cause, whether it is hyperemesis, pregnancy-related or Graves' disease. When you're not sure about the etiology, you can do TSH receptor antibody to decide on the necessity of treatment. Second thing is in Graves' disease per se, the guidelines mention you need to do TSH receptor antibody to assess the disease activity at 3 timings. One is at diagnosis, second thing in mid-gestation, and third in the 30th week. Doing it 3 times is not very practical because it is costly. Initially, you need to do TSH receptor antibody at confirmation of pregnancy to assess the disease activity. Even in those who had past thyrotoxic Graves' disease who have been ablated or underwent surgery, even in those patients, you need to do TSH receptor antibody at diagnosis to assess the disease activity. If it is more than 3 times elevated or above 5, you need to recheck again at 20 to 22 weeks. Checking at 20 to 22 weeks is to assess the risk of fetal toxicosis. So if it is elevated at 20 to 22 weeks, you need to monitor frequently by ultrasound for signs of fetal toxicosis like tachycardia, goiter, etc. And again at 30 to 32 weeks, you need to recheck again. This is to assess the risk of neonatal toxicosis. If it is very high at 30 weeks, then you need to monitor for fetal neonatal toxicosis after delivery. But checking at 3 times may not be practical. Maybe if the patient is avoidable, you can check once at 20 weeks and decide accordingly.
Thank you, Dr. Sivan, for highlighting the role of TSH receptor antibody. Most often we diagnose transient gestational thyrotoxicosis. So if we make a diagnosis of transient gestational thyrotoxicosis, do we need to follow up in pregnancy? Do we need to do the further thyroid function test, Dr. Kripa?
So usually transient thyrotoxicosis of pregnancy, that is HCG mediated, this is most pronounced in the first trimester, and it is a self-limited condition. If the lady is severely symptomatic, she may be treated with a low dose of beta blockers. Otherwise, treatment is not required. However, if the patient has a thyrotoxicosis due to Graves, then she needs to be initiated on PTU in the first trimester. Thyroid functions need to be monitored every 1 to 2 weeks. The target T4 we keep is the higher range of normal or just above the reference range, because making the pregnant lady euthyroid will result in fetal hypothyroidism. And once it is stabilized, then the patient can be monitored, the thyroid functions can be monitored every 2 to 4 weeks beyond that.
Thank you, Dr. Kripa. I think we had the discussed about thyroid dysfunction pregnancy with the help of these 6 cases. And I thank all my expert panel members to discuss this important entity about thyroid dysfunction pregnancy. I hope the session was useful. Thank you. I thank the organizers for having given me the opportunity.
May I now request Dr. Muthukumaran Jayapal to chair the next session along with Dr. Talabadi. And here we have 3 interesting case-based discussion, one by Satyan and another by Reddy and next by Kumar Tulasidas. And over to Dr. Muthukumaran. And as you all know, Muthukumaran is the secretary of ESTN. He is a senior endocrinologist from Chennai. And Dr. Talabadi is an endocrine surgeon and he is also from Chennai.
Coming on to the penultimate session, the session 7 today, I would like to invite Dr. Satyan from Salem, consultant endocrinologist, to present a case of DKA. Over to Dr. Satyan.
You want to be presenting from here or you want to sit here?
Thank you. Good evening, everybody. Begin with, I would like to thank our ESCN team and Muthukumaran sir for giving me this opportunity. After wonderful sessions, this is basically one of the bread and butter of endocrinology, patients with diabetic ketoacidosis. I have basically chosen a different type of scenario with regard to diabetic ketoacidosis. One of the probably comparatively lesser looked at area of management of diabetes, especially with DKA. Hopefully you can find it useful. Now, obviously, diabetic ketoacidosis is, though it's mentioned as an hyperglycemic crisis, is basically a metabolic crisis. All the major pathways of glucose, lipid, and protein all are affected. Now, the area what I mentioned, like I'm going to do it differently, is we know that around 1/5 of our admissions are only our new diagnosis of DKA. That means nearly we have a very large volume of patients who are really readmission of DKA in known patients of type 1 diabetes. So in this particular patient, we got a 20-year-old who is presenting to casualty with a week's history of lethargy, polyuria, and polydipsia. He had also a history of unintentional and progressive weight loss, a history of nausea and vomiting, and non-localizing abdominal pain. He's had type 1 diabetes for the past 6 years, and he's preferred to be treated with twice daily premix insulin regime. And going through his history, he had a multiple history of admissions only with hypoglycemia, but no definite admissions with DKA. No other significant post-medical history, including other endocrine disorders, no recent travel history, and he denied non-compliance. There was history of alcohol consumption, though he denied any recent intake. There is no history of smoking or recreational drug usage. He does blood glucose monitoring very infrequent. There are only few entries in the diary, and he's somebody pretty much for the current age into the social media, and there is no definite history suggestive of an eating disorder. These are the initial assessments. So the clinical examination, he was conscious, as his vitals are as seen on the screen. He had a BMI of 22. He was hypovolemic with dry mucous membrane, tachypnic. There was no focal neurological deficit. Other system unremarkable. Abdomen was mildly distended with diffuse tenderness, no rashes or joint effusions. He had some enlarged tonsils with erythema and follicles, and he had a bulged tympanic membrane on the right. When you look at the insulin injection sites, they are mainly on his arms and thighs with multiple areas of lipohypertrophy. ECG showed sinus tachycardia. His capillary blood glucose at that point was 360 milligrams. In ABG, showed a severe acidosis with a pH of 6.84 and a bicarb of 9, urine 3 plus glucose and ketones. The sodium was 132 with an anion gap of 13. So clinically and biochemically, he falls into the severe category of diabetic ketoacidosis. So the initial assessment and the treatment plan were that this is a case of severe diabetic ketoacidosis precipitated by an infection, possibly tonsillitis, and the patient was shifted to ICU where a HDU level of care. The standard local protocols were initiated for diabetic ketoacidosis. He was initially kept nil by mouth, was given IV antibiotics, and an ENT opinion was sought. He was initially treated with normal saline first and KCL, and then he was given a start dose of basal insulin subcut, and then a weight-based fixed dose insulin regime infusion was started. His HbA1c was 8, renal function and liver function tests were normal, TSH was 3. A repeat ECG showed just a normal sinus rhythm. The patient was shifted to ward once he was stable, and then there was further detailed discussion with the patient and parents. Now, as I mentioned, this talk is not pretty much about more into the acute management of DKA, but the other part of DKA, which is what's happening next. In this particular patient, what I found curious was that his HbA1c was 8, not particularly high, and also the fact that he's had no previous admissions with DKA, it's mostly with hypoglycemia. Very interestingly, he was trying to lose weight. He had only a BMI of 22. That's partly because he's been so much into social media, and he was somebody who was trying a spectrum of lifestyle measures, going through different diet modifications, playing with his insulin regime, all of this without any advice. The only difference now is that he started cutting down insulin and even skipping some doses as he was trying like something like an intermittent fasting. As I mentioned, there was no backup plan. He did not back it up with any proper discussion with a consultant, with his treating physician, or at least doing some self-monitored blood glucose levels. And he had declined a basal bolus regime previously. So subsequent management, after a very detailed discussion, most of this, even his parents were not aware. And then he agreed for a psychiatric evaluation. There was no formal diagnosis made with regarding like an eating disorder, but there are multiple areas of interventions which were being identified. After a very long discussion, he agreed to a basal bolus regime. He agreed to continuous glucose monitoring down the line. He was given some early introduction on carb counting, and he was given detailed advice on injection technique. And then we revisited the diagnosis. So possibly his severe DKA was not necessarily just infection. There's some partial non-compliance with insulin therapy due to his self-determined treatment plan. So basically, when we reflect on such patients, as I mentioned earlier, obviously maybe a patient first time presenting with diabetic ketoacidosis may not necessarily be preventable, but the remaining 1/4 or 1/5 of patients who are getting readmitted, these are the patients who are likely more significantly preventable. And obviously, though the mortality rates have come down, it is still not zero. And of course, the morbidity associated with this. And also, we always need to be prepared for surprises. In this patient, it is very common that this set of patients may be just given the label that he has had an infection, So it precipitated DKA and then is discharged. There's more likely this patient could have come back again with another such episode of DKA or maybe presented at a different hospital. So we probably should not be content with just a single diagnosis. So the acute management wise, we have pretty much very solid and strict guidelines which help us how to manage any patient in the acute stage. But the big question comes when it comes, once the patient is treated, once the patient is stabilized, what sort of advice we are going to do, what are the post admission planning, which is also part of the overall glycemic plan for any patients with type 1 diabetes. So that is where I think we need to be more careful with all these patients. We really need to identify individualized causes for why this patient has entered into DKA. It can be just a problem with injection sites. It can be just a problem with a change in diet not backed up properly. It is possibly the regime where the patient is exposed to a long period of no insulin in the system, predisposing them to DKA. So while the patient is in the hospital, the strategies are there very clearly laid out, whereas there are many areas when the patient leaves the hospital which are beyond the control of our area, where the possibilities and challenges are enormous. Thanks very much for listening. I'll stop.
Thank you, Dr. Satyan. Can you please open the chat box, please? You can sit here if you wish. I think you have touched upon the psychological aspects. What are the most common psychological problems you encounter as a doctor in your real life practice?
Thank you, sir. I hope the question is probably related to type 1 diabetes. Clearly, these are the young group of population where the very first introducing to insulin, the diagnosis, the initial counseling, that itself makes a very big difference. I think any patient newly present with DKA, they really need one-to-one sessions, both individually and with the parents, and a genuine psychological issues need to be identified, especially the importance of continuing insulin, the importance of monitoring when to get help, and ensuring the patient genuinely accepts and understands the problems rather than just nods in front of us and leaves with a different idea. I think this can be only addressed by reinforcement, and there is a lot of myths around using insulin, like large volume of patients still think that using insulin can lead to renal failure. These may sound so ridiculous to us, but from the patient's point of view, these can be very valid fears. So the important thing is about clearing the fears of insulin and the fact that we are endowed with much better insulins, which are more efficacious with less risk of adverse events. So it has to be a holistic approach. Thank you.
Thank you so much. You can sit here if you, whatever you're comfortable with. I would like to welcome friend and colleague, Dr. Vijay Bhaskar Reddy, to the dais again. We have got the next case coming, which is a 30-year-old female with carpopedal spasm. Unfortunately, Dr. Karthik couldn't attend and Dr. Vijay Bhaskar Reddy is stepping in. Thank you, Dr. Vijay Bhaskar Reddy.
Thank you. So I'll be discussing this case. A 30-year-old lady with carpopedal spasm. Hypocalcemia. So this is a 30-year-old lady presented with the spasms of hands on and off, especially while working. And this is when patient was seen in clinic with Trosso sign. So we can see this is the carpal spasm where there is flexion of the wrist with extension of the fingers and adduction of the thumb. This is a typical presentation. This is typical textbook teaching. All of us have been seeing this since our MBBS days. This is a typical carpal spasm, flexion of wrist with extension of the fingers and adduction of the thumb. So no, most often we see this carpopedal spasm due to neuromuscular irritability due to hypocalcemia. This is the most common. Sometimes we see this with hyperventilation, patient presenting with hyperventilation mainly due to anxiety, and patient goes into respiratory alkalosis precipitating hypocalcemia. This is another condition which can cause carpopedal spasm and tetany. So the signs of hypocalcemia include Chvostek's signs. So all are due to neuromuscular irritability. I'm focusing mainly on hypocalcemia because that's what is related to endocrine practice. Hyperventilation, sometimes it can present to emergency setting with alkalosis and carpopedal spasm. So Chvostek's sign is neuromuscular irritability, which is elicited by tapping over the facial nerve, and you can get twitchings of the perioral muscles. And Trousseau's sign is we induce the carpal spasm by tying the blood pressure cuff around 20 millimeters mercury above the systolic blood pressure. And carpopedal spasm already showed the picture. Even the leg, you get similar extension of the toes and adduction of the foot. So this case, most important history we need to elicit is past history of thyroid surgery. And this case had a history of thyroid surgery 5 years back for multinodular goiter. Although she was found to have post-op hypocalcemia, the patient had stopped her calcium supplementations after a few months after surgery. So what are the points to ponder in this case? So this case, we had hypocalcemia leading on to carpopedal spasm and tetany. So what are the common causes of hypocalcemia, and any precautions to be taken while checking for calcium levels? How to replace calcium levels? Like in this case, in a post-op thyroidectomy setting where the possible diagnosis is hypoparathyroidism, is there which calcium preparation to use and which vitamin D preparation to use? And in endocrine practice, we tend to replace the hormones. And in hypoparathyroidism, is there any role for replacement of PTH in this case? So the parathyroid paradox is ideally in a case of post-thyroidectomy, post-op hypocalcemia should not occur, because parathyroid gland, we know it's not a single gland. We have more in number, usually 4. Sometimes it can be supernumeric and sometimes ectopic also. But still it gets affected frequently after neck surgery, especially for thyroid. And the most important aspect is to prevent the parathyroid affection during thyroidectomy. So it is like when you're doing thyroid, preservation of parathyroid is a very important step in thyroid surgery. So the major causes of hypocalcemia, we know calcium is closely regulated by PTH. We can classify causes of hypocalcemia as calcium with low PTH and hypocalcemia with low PTH and hypocalcemia with high PTH. Hypocalcemia with low PTH is usually hypoparathyroidism, mostly autoimmune hypoparathyroidism. And then we can have rare genetic disorders also. And we have post-surgical, like this case, post-parathyroidectomy. Post-thyroidectomy, the patient is got post-op hypoparathyroidism. Sometimes we can have hypocalcemia with high PTH. Most commonly, it is vitamin D deficiency. And sometimes with pseudo-hypoparathyroidism. Also, we get this with renal disease and loss of calcium from the circulation. Some drugs also cause hypocalcemia, like bisphosphonates, denosumab, especially in a setting of vitamin D deficiency. Disorders of magnesium metabolism also can alter the PTH levels and cause hypocalcemia. So what are the factors associated with hypoparathyroidism post-thyroidectomy? So when we are doing extensive thyroid surgery, there is more often you get hypoparathyroidism, bilateral, simultaneous or sequential thyroid procedures, autoimmune thyroid disease, also surgery for autoimmune thyroid disease often is associated with hypoparathyroidism, If you're doing central neck dissection as part of malignancy, substernal goiter, low volume thyroid surgeon. So we need to do this thyroidectomies by a high volume thyroid surgeon, prior gastric bypass or malabsorptive state, simultaneous thyroid and parathyroid surgery, prior neck surgery. So all of these are associated with hypoparathyroidism and more caution needs to be exercised. What are the symptoms of hypocalcemia? Already we saw this. Low calcium symptoms are related to serum ionized calcium levels and baseline neuromuscular excitability. Symptoms may occur even at low normal calcium values, even 0.1, 0.2 milligram per deciliter less, the patient may have symptoms. And the other extreme, patients may be relatively asymptomatic even with quite low calcium levels. Earlier symptoms usually occur in patients with anxiety, tachypnea like pain, associated hypokalemia, hypomagnesemia, which causes low ionized calcium levels, pre-existing vitamin D deficiency, and low total body stores of calcium. Clinical features, already we have seen this. Patient presents with muscle stiffness and spasms like carpal and pedal spasm, and they can have tingling and numbness due to neuromuscular irritability with perioral paresthesias and tingling. And extreme cases, patients can present with stridor also. Signs, already we have seen Chaucer's sign, Trosser's sign, and they can have normal or depressed reflexes. Lab investigations. So we need to get an accurate serum calcium level. We know that calcium levels are not accurate in many labs, so we need to do it from a reliable lab. Always we should correct for the serum albumin adjusted calcium, because the patient in ICU or in a patient who is sick patient, their albumin levels will low, which will show falsely low calcium. So we need to correct the calcium levels for albumin. And where in doubt, like ICU setting, we should do ionized calcium. ECG, the QTC interval is a surrogate marker for ionized calcium. And in critical settings, we may have to do potassium, magnesium, bicarbonate, and pH estimation. To establish the etiology of hypocalcemia, we may have to do phosphorus, PTH, and 25-hydroxy vitamin D, and a creatinine level also. How to replace the calcium level? So we need to replace calcium, ideally 50 to 75 milligram per kg per day in 3 to 4 divided doses. Ideally, we should restrict to around 500 milligram per dose. Now, most commonly we use calcium carbonate, but we need to understand that acid is required for absorption of calcium carbonate. If the patient is on proton pump inhibitor or H2 blockers, which suppresses the acid in the stomach, it's preferable to use calcium citrate. Other preparations are available, but we do not use most commonly. We need to understand that in a patient who has hypoparathyroidism, like post-thyroidectomy, giving vitamin D for absorption of the calcium. In cases of severe symptomatic tetany, then we may have to give bolus doses of IV calcium gluconate, but we need to give activated vitamin D also simultaneously. So in endocrine practice, whichever hormone is less, we tend to replace it. So what about this hypoparathyroidism? The hormone deficiency is PTH, and we have PTH analogs like teriparatide and PTH 1 to 84 and abaloparatide, but we do not use this in this endocrine setting. We do it with calcium and activated vitamin D like calcitriol. Because one is these injections are costly and we do not have long-term studies, we give calcium and activated vitamin D. So in this setting, giving cholecalciferol alone is not enough. We need to give calcitriol 0.25 to 0.5 microgram 2 to 3 times a day along with calcium supplementation. How to monitor? In short term, we look for clinical improvement, symptomatic improvement, the tingling, the perioral tingling and carpopedal spasms. And we have to look for Chaucer's and Trosser's sign to disappear. Biochemical, we look for improvement in corrected calcium value. We should not try to target high calcium levels. Even low normal calcium would suffice if it doesn't cause symptoms. No use of monitoring the PTH levels. Hypocalcemia, like in our case, post-thyroidectomy, if hypocalcemia persists for more than 3 to 6 months, then parathyroid recovery is unlikely, then long-term follow-up is required. Around 3 monthly, we can do calcium albumin, and yearly once we can do urine calcium creatinine ratio, and we might consider adding on thiazides in this case to improve the calcium level. So the key recommendations of how to prevent post-op hypoparathyroidism, like in this case, conduct surgery so as to avoid removal. We have to preserve the parathyroid. We might consider auto-transplanting the devascularized normal parathyroid gland and treat at-risk patients empirically with calcium and look for calcium in PTH levels. Hypoparathyroidism, we give calcium with calcitriol. For resistant cases, we may consider using PTH analogs. Thank you.
Thank you, Dr. Vijay Bhaskar Reddy. Just before we move on to the next session, can I just ask you a couple of questions?
Yes.
When you say calcium supplements, what is your best thing, what you look for and what do you provide for your patients? And is there a choice in your selection of vitamin D as well?
So in this setting of hypoparathyroidism, normally I would prefer to use routine calcium carbonate, around 500 milligram 4 times a day, and along with calcitriol, 0.25 microgram thrice a day. So that's what I would prefer. And further, depending on the calcium level and symptoms, we would adjust. If the patient is on proton pump inhibitor or H2 blockers, then I would prefer to use calcium citrate.
One of the things which I find even in the COVID period is we get a lot of abnormal calcium. So we need to double check it before we act on it. That's what you brought it to the point as well, because most labs do not calibrate their calcium levels adequately. So that is probably why they end up with a very low calcium often. So the calcium is a very, very unstable molecule and needs more frequent calibration in the lab, which is adequate. Is there anything you would like to point out?
Yes, I think calcium assays are very difficult to do, even in big institutes where I did my MD and DM like PJ Chandigarh and SGPJ Lucknow. Calcium assays were very difficult to believe, and that's why we need to do a reliable lab, and calibration has to be done properly. In ICU setting, we may have to do a calcium, albumin adjusted calcium and even ionized calcium before we act on.
Thank you so much.
Thank you.
Thank you. Yeah. Okay. I think we've come to the last talk of the session. We have got Dr. Kumar Tulasidas on the line. He is going to talk about how to approach a 70-year-old lady with hypothyroidism and worsening sensorium. Dr. Kumar Tulasidas is a consultant endocrinologist based in Chennai, and he works part-time in Sri Ramachandra Medical College and currently at Global Hospital. Kumar, are you there?
Yeah, good afternoon, Dr. Muthukumaran, and everybody there. I'm there. I am sharing my screen. Is it visible? The slides, please.
Yes, sir, it's visible.
It's visible. Okay, cool. One second. So
you can get it to full screen, Kumar.
I guess it's full screen now, right?
It's
not
being
yet.
Loaded.
You have shared the screen.
Yeah.
Yeah, so just come down, move the cursor down, and you.
So probably
Yeah, go down. Yeah. No, over to your left. No, this extreme down.
Where is it? Sorry.
Come to the right. No, that's a zooming. You're trying to zoom it. Move to the 2 points before. There is a screen coming down. No. Onto your left. Yes. The next one. No. The next.
This one.
Next.
Yeah,
that's it.
Yeah, I did that already. This is just for the
No,
slide.
it might not have worked. Do that again. Try that.
Yeah, I've done it again, second time. I did the same actually. Now, I mean, it's seen full screen for me.
Okay, go ahead in that case. Yeah.
Fine.
Try F5.
F5. Right. Any different?
No.
So just you can reshare the screen, and then I think it will be visible.
Okay, so I'll exit and then share it again.
First, you need to put it in a slideshow mode, and then you can share that portion.
1 second. Yeah, first I'll put now in the.
Yeah, exactly.
Okay. Not able to go back. I'm sharing again. I put in the, yeah. How about now?
No.
Right. Okay. So what do I do? I'm doing all the right things, I think.
So you need to put.
How is it visible for you there? Is it just the not? I mean, it's not in the slideshow mode, is it?
It's not in a slideshow mode. You can put it in a first slideshow mode, and then you can share that part of screen.
So once you put
Or
in the
else you
slide,
can also share your wall screen, and then you can open your PPT, and then you can put it in a slideshow mode. Then it will be work.
okay, I'll do that then. Yeah, the other one is also in the slideshow mode already. So I
Sir,
don't know why.
you can share your wall screen. Wall
Wall.
screen. Yeah, full screen.
How do I do that? Sorry.
Yep, just click on a share screen button, and then click on a screen option, and then you just push to share button.
Oh, screen option. Okay.
Yeah, yes, exactly.
Okay.
Okay, now open your PPT.
In the slideshow mode, right?
In the
That
slideshow
one.
mode, yeah.
Now?
Perfect. It's visible.
Cool. Oh, okay, thank you. Okay, thank you. So, good afternoon, everyone, and warm welcome to all the postgraduates and other physicians who are attending the meeting. So we're going to discuss about the 3-year-old lady with who's a known hypothyroid presenting with worsening sensorium. So this elderly lady has primary hypothyroidism for the past 20 years duration and systemic hypertension 15 years. She presented with 2 to 3 weeks of progressively worsening confusion and now quite drowsy upon presentation, very drowsy on presentation. She has been on Thyronorm 100 micrograms daily and indapamide for her hypertension. On clinical examination, her pulse was 54 per minute regular, blood pressure 180, respiratory rate was 10 per minute, oxygen 93%, and the temperature was quite low with 94.8 degrees Fahrenheit. And she was very drowsy, but still arousable, GCS calculated to about 10 by 15. Extremities were quite cool, but the pedal pulses were felt as she was not in shock. Skin was dry, there was loss of lateral half of the eyebrows. The eyelids were quite puffy, and there was no goiter clinically. So then on CNS examination, she was localizing to painful stimuli, and she was opening her eyes to verbal command. There was no neck stiffness. Bilateral plantar was equivocal, and the ankle jerk during CNS examination was found to be delayed. Chest revealed right basal crackles. Otherwise, cardiovascular abdominal examinations were quite unremarkable. So the possible diagnosis, what would you like to consider here with this background and presentation and the clinical features? One is, yes, infection. It's quite very common, and especially in the elderly, it can knock them off their consciousness levels very, very quickly, even with mild infection. Yes, we have to consider infection. Hypoglycemia, yes, very much so. That can cause an altered sensorium. Electrolyte disturbances, these are all the common ones, like hyponatremia, very commonly, especially in the elderly people, can produce an altered sensorium, and this patient is being on indapamide, very much a possibility. CO2 retention, hypoxia, respiratory failure, we noted that the respiratory rate was quite low, like she was hypoventilating. So CO2 retention is very much possible. She may have CVA or in CNS infection, and anything else also we should consider connected to her background clinical conditions like hypothyroidism, hypertension related issues leading to. So upon blood workup, the total count was 9,800. Neutrophils were predominant with 90%. Creatinine 1.4, sodium 122, it was low. Potassium was normal, and CBG was normal. Free T3 was low. Free T4 was low as well, quite low. And TSH was much elevated at 128. And serum cortisol random was 22 microgram per deciliter, denoting stress response as she was presenting in that situation. ECG showed bradycardia, sinus bradycardia, and X-ray of the chest showed right basal pneumonia patch. So now what would you consider as a differential diagnosis with the history and clinical features in the background and the lab workup of? So one, yes, pneumonia, we have a basal patch, and patient is maybe having an infection that may be causing altered sensorium. And also we noted the sodium was quite very low, 122, which can very much cause altered sensorium in an elderly person. The patient was also quite hypothermic. Hypothermia can cause obtundation of the consciousness levels, which is possible as well. And also we should consider myxedema coma. So this patient being hypothyroid, and she's an elderly patient, long-time hypothyroid. She presented with altered sensorium, and it's worsening progressively. And clinically, this patient has got puffy eyelids and loss of eyebrows, a loss of scalp hair, and she is having a pulse of bradycardia and poor ventilated respiratory rate, as well as hypothermia. And we have a lab evidence of a raised TSH. So very much we should consider myxedema coma. And the pneumonia was quite obvious in the X-ray and stuff, and sodium was very low. And people should not stop thinking beyond that point, like pneumonia and SAIDH is a possibility. But we should take these clinical features into consideration, and the clinical diagnosis can be myxedema coma, pneumonia, hyponatremia. All these things can be distractors or a red herring, and they are not individual. They may be precipitating factors or coexisting factors. And this is the point I would like to stress in this presentation. So myxedema coma is a rare condition, of course, but that doesn't mean it shouldn't be in your backyard. It can be so. So it's estimated about 1 per million roughly per year is the incidence, quite very rare, but it's life-threatening. You can't afford to miss it. So it's basically it's a severe hypothyroidism with physiological decompensation, complete physiological decompensation. Usually occurs in patients with long-standing undiagnosed. So majority of the patients who present, they are not diagnosed to have hypothyroidism, but in this lady, she was a known hypothyroid. And that's how they present. So mostly the precipitating factors which tip them off the balance is infection or cerebrovascular accident, or heart failure, or severe trauma like a road traffic accident or something, exposure to cold temperatures in the temperate climate conditions, electrolyte disturbances, especially this low sodium or low glucose, or drugs like sedatives, hypnotics, tranquilizers, and the barbiturates and the stuff, and anesthetic agents sometimes, and even common drugs like beta blockers, which we use for hypertension, can precipitate this condition in untreated cases. So this just this picture of a lady with a myxedema coma, and she has got this puffy, dull facies, and the eyelids are puffy and overhanging, and eyebrows are lost, scalp hair is lost, and the skin appears to be quite very dry. And so that's how they look like. So clinical examination: altered sensorium, low temperature, hypotension, bradycardia, periorbital puffiness, large tongue, coarse and thinning of the hair, dry, thick skin, cold extremities, non-pitting edema, brittle nails, and bleeding like purpura and ecchymosis are also possible. On CNS examination, you can have a spectrum of presentation. They can vary from lethargy to delirium to being frankly stuporous or comatose. Cardiovascular examination can be most commonly bradycardia and decreased pulse pressure, low BP, elevated diastolic blood pressure, normal systolic BP, so decreased pulse pressure, poor cardiac contractility, and very soft and distant heart sounds, and pericardial effusion can be the range of things we can get. The lung findings can be ranging from decreased respiratory rate to tongue obstruction causing obstructive symptoms, or respiratory muscle weakness, or pleural effusion. And abdominal findings commonly poor bowel sounds due to low peristalsis due to low thyroxine levels, paralytic ileus and megacolon are possible. Ascites is possible. Hematologically, these patients have increased bleeding risk because of the acquired von Willebrand. Because of low metabolism, the liver production of these factors, factor 8 appears to be producing in tiny amounts, which can be corrected with thyroxine therapy. And decreases in other factors are also noted, like clotting factors, the 5, 7, 9, 10 are also diminished. The total count, as I earlier said, may be normal because of the hypothermia. The total count doesn't increase much. The differential count will show neutrophil predominance, which we earlier saw in this case. So workup, so total count, as I said, creatinine commonly is elevated because of the poor renal perfusion, which is corrected with thyroxine therapy. Electrolytes, hyponatremia. Basically, hyponatremia is in this case is dilutional. The heart pumping is poor, so poor cardiac output causes increased secretion of ADP. So ADH, so antidiuretic hormone increased secretion prevents the free water excretion from the body, thereby causing dilutional hyponatremia. Of course, T3, T4 low and TSH is elevated to the thyroid function test. Morning serum cortisol or even random serum cortisol, because we have to rule out a concomitant another autoimmune condition like hypoadrenalism, adrenal insufficiency. This may have a bearing when we treat the patient, which I'll mention later. ECG shows will commonly show bradycardia, but they can show heart blocks, and that may need to be treated. Can show inverted T waves or prolonged QT and related arrhythmias are also possible. X-ray, pleural effusion and pericardial effusion, cardiomegaly can be picked up. Blood gas due to poor ventilation, hypoventilation, hypercapnia, type 2 respiratory failure, that itself causing obtundation can happen. And echo, decreased contractility, pericardial effusion. So these are the parts of the workup. And management-wise, airway maintenance, if the GCS is below 8, you've got to be intubated and they got to be connected to ventilator. Treatment of hypothermia should be passive, slow rewarming using blankets or a warm room. There is no rush to increase the temperature very quickly. Thyroid hormone replacement, of course, we're going to discuss this. Glucocorticoid therapy. So this has to be administered before the thyroid hormone replacement. Just a glucocorticoid therapy of 50 to 100 milligram IV 8 hourly will be good to do, because one is if they have adrenal insufficiency, if you give thyroxine before the steroids, that may precipitate adrenal crisis. So first steroid, then thyroid hormone, always. And also, even if this cortisol is 22 in our estimation, when you give thyroid hormone, that can metabolize, accelerate the metabolism of cortisol, and any relative adrenal insufficiency will be precipitated. So better give steroid first and then the thyroid hormone replacement. And of course, correct the correctable factors like correct hyponatremia. Here it's dilutional, so free water excretion, hypertonic saline if needed to slowly bring up the sodium. Correct hypoglycemia with dextrose, and hypotension usually becomes normal with thyroxine therapy, but sometimes may need a short-time inotropes support. And IV antibiotics, of course, for the treatment of the pneumonia she's having. So thyroxine therapy, the ideal mode of treatment and the doses are quite controversial still, but generally it is preferred IV intravenous therapy. American Thyroid Association recommends both combination of T4 and T3 intravenously to treat the myxedema coma. the intravenous thyroxine is preferred rather than oral because the gastrointestinal absorption, poor peristalsis, all these things will be there in mixed hemochroma. There's the blood, there won't be enough absorption of the orally administered dose. So intravenous is preferable. T4, the loading doses recommended are 300 to 600 microgram, and then followed by daily 50 to 100 microgram. But it's preferred to keep the dosage to the lower end of the normal recommended dosage, because most of these patients are quite elderly and they won't tolerate if you give a big bolus dose. And the T3 therapy is 5 to 20 micrograms bolus dose, followed by 2.5 to 10 micrograms 8-hourly daily. So every 2 days once, you have to keep monitoring the free T3, free T4 and TSH while they are on intravenous treatment. And once their consciousness level improves and they are able to orally take the tablets, then it's time to switch to oral thyroxine and then monitor the patient clinically and biochemically. So basically, I want you to take home just one message: is not to miss the diagnosis, not to failing to recognize should not be there. Because in intensive care setting, when somebody is admitted low sensorium, low sodium and pneumonia, and quite commonly we don't do the thyroid function test in intensive care units because it can many patients can have sick euthyroidism and they are acutely unwell. The cytokines impair the hypothalamic pituitary thyroid axis, and so T3, T4 will be low, and TSH may be low or even in the low normal range. You may it may cause confusion. We don't do generally thyroid function test in intensive care unless clinically indicated. This is why the clinical findings in this patient are quite important. The typical hypothyroid phases, hypothermia, hypotension, bradycardia, and raised TSH. So all these things put together establish the diagnosis, because the intravenous thyroxine treatment should not be delayed. It should be started promptly to improve the mortality rate. Even in hospital treated patients, the mortality is quite high, like 30 to 35%. And if you delay the treatment, delay the diagnosis 2 or 3 days, that can significantly increase the mortality rate. So clinical features, clinical findings, assessment, even in intensive care setting, very important regarding this condition. That's the message I would like you to take home. Thank you.
Thank you so much, Kumar. It was a very, very clear and crisp presentation. More and more women, older people are living alone. So what precautions do you tell our patients or their carers, main carers, to watch out for?
Absolutely.
As in the Western world, hypothyroidism has become more common, as well as our patients are also have started living alone, especially when their sons and daughters are living abroad. So what should we take care?
Yes, absolutely. I thought of adding a slide to that also. So this patient should be, after the acute situation is over, then we should have a counseling session with the family as well as the patient together, and the sort of ways how this patient can be, should be taking. Obviously, this patient didn't take it properly, and that is the reason she ended up in this condition. So the family can be asked to, if she is living alone, we have to check whether they can give any care arrangements, like a carer or somebody going in the morning for administration of the tablets and ticking in the diary or something and sending it to the relatives. So that kind of arrangement can be done. Or the family, if they can't do all such special arrangements, at least the family can ring somebody can take in charge to ring the patient in the morning and remind her about the tablet and make sure she has taken the tablet on an everyday basis. Some sort of backup from other than the patient backup should be done.
I think that this is probably just a warning that the self-care mode has stopped and you need other cares to be established.
Yes,
thank you so much. We have to move on because of time. So
thank you.
Thanks, Kumar. Wonderful talk. Thank you again.
Thank you.
We move on to the final talk or the final session of the day, to dynamic hormone testing. I invite Dr. Srinivasan and Dr. Adlin, who are online, to take care of the proceedings.
Thank you, Muthu, for your introduction, and I congratulate the ESTM team for organizing the hybrid Enrich against all odds. And this is the last session of the Enrich program. And the program is about dynamic testing in endocrinology. As you all know, dynamic testing in endocrinology is needed many times to confirm the diagnosis and or to assess the treatment response. So the first talk is going to be regarding growth hormone excess and the dynamic testing for that. And it is going to be Dr. J.P. Sagu from JIPMER, and he's an endocrinologist, and he is going to talk about the dynamic testing for growth hormone excess. Over to you.
Thank you, sir, for kind introduction. Very good afternoon to all. At the outset, I would like to thank the organizers for giving me this opportunity. Next 15 minutes, I will be talking on dynamic endocrine testing for growth hormone excess. This will be the plan of my presentation. Regulation of growth hormone secretion, screening test for growth hormone excess, confirmatory test for growth hormone excess, what to do when you are getting discordant results between screening and confirmatory tests, and finally take home message. Coming to regulation of growth hormone secretion, the growth hormone is secreted from pituitary and it is controlled by GHRH and somatostatin from the hypothalamus. Growth hormone releasing hormone stimulates. This is represented by the green color, and the somatostatin inhibits the growth hormone secretion, represented by the red color. So this is the basically the principle of OGTT suppressed growth hormone level measurement. The giving excess glucose load leads to inhibition of GHRH and stimulation of somatostatin. So ideally, it should decrease the growth hormone level after giving the glucose load. If it is the state of growth hormone excess, the suppression won't be there. And the second principle for doing the test for growth hormone excess is the measuring IGF-1 level, which is basically the surrogate marker of growth hormone excess, which is produced from the liver by the action of growth hormone on growth hormone receptors present in the liver. So decreasing secretion of growth hormone from pituitary and the increasing secretion of IGF-1 from the liver are the two main components of dynamic test for doing growth hormone excess. So what is the indication for doing growth hormone excess? So if we are suspecting for a patient having either acromegaly, particularly in the adult patient, or in the young patient suspected gigantism, which is defined as either the growth velocity or height or both is more than 2 standard deviation for that age and gender and the population. So acromegaly and gigantism mainly characterized by the clinical features, including both symptoms and signs. The symptoms includes headache and change in the facial appearance, and the signs includes the like prominent forehead, supraorbital ridge, and the fleshy nose, increased sweating and sebum production, and thickened lip, and the prognathism, and the widening gap between the teeth, and associated the metabolic disorders like diabetes, hypertension, dyslipidemia, cardiovascular disease. Sometimes patient can have also obstructive sleep apnea, and also they may have the features of renal calculi because of increased hypercalciuria. So if you are having patients of suspected acromegaly or gigantism, we can consider for doing growth hormone excess test. So there are two types of test. One is screening and second is confirmatory test. Coming to screening test, the screening test is basically done to see the level of serum IGF-1 level, which is the surrogate marker of the growth hormone excess. So why IGF-1 is preferred for screening test? Because it is secreted continuously, has a longer half-life, exhibits more stable concentration in the blood. A level can be determined at any time of day without the need of fasting. And the levels are usually proportional to the mean GH level. So that's why it is selected for the screening test. So before interpreting the IGF level, we should know what are the factors which will affect the IGF-1 level. Other than the physiological condition like puberty and pregnancy, the diabetes, renal and liver disease, and malnutrition, and critical illness, anorexia, and the drugs like oral estrogen intake also decrease the IGF-1 level. Basically, these are the states of growth hormone resistance. And one of the most common problem we face when we are assessing the IGF-1 level in a patient with acromegaly, because acromegaly is usually associated with diabetes in 60% of patient cases. So if the diabetes is not controlled, we may get false low IGF-1 level. So the clinical dictum is at least we should control diabetes as much as possible. So there are some studies showing if the HbA1c is less than 8, that is fair enough to go out for the IGF-1 level. So what are the causes of, what are the pathogens of low IGF-1 level in diabetes? Other than the decreased expression of growth hormone receptor on the liver because of hypoinsulinemia, there is also more degradation of IGF binding protein, and also there is altered IGF-1 level because of glycosylation, which is not detected by few assays. So these are the possible reasons why you are getting low IGF-1 level in diabetes, and other conditions basically associated with growth hormone resistant state because of low GH receptor on the liver, which leads to low IGF-1 production. So we should keep these things in mind, like diabetes, uncontrolled diabetes, liver disease, renal disease, and the oral estrogen intake before interpreting the IGF-1 level. So IGF-1 level below normal range for age and gender practically exclude the diagnosis of excess. And if the patient with clinical features suggestive of growth hormone excess, if you are getting elevated IGF-1 level, that may be sufficient enough to complete the diagnosis. So once in a suspected patient of growth hormone excess, if you are getting high IGF-1, then we'll go for the next test, which is the confirmatory test, that is the OGTT. Usually 75 gram glucose is given, anhydrous glucose, which is corresponding to 82.5 of glucose after fasting for 8 hours, and the growth hormone sample is taken at baseline and 2 hours. However, there are few variations in this test. Some people take GH sample more frequently, particularly at the academic and research setting. They take every 30 minutes for 2 to 3 hours. Even some people also use 100 gram glucose instead of 75 gram glucose. But usually 2 GH samples at baseline and 120 minutes with 75 gram glucose OGTT is the standard method for evaluation of growth hormone level. So here you can appreciate what is the difference between the basal GH level in a normal person in the acromegaly. So in acromegaly patient, not only the variation will be lesser, the baseline itself will be higher. So here you can appreciate growth hormone level is more than 20 to 30 milli-IU, that is equivalent to 6 to 10 nanogram per ml. So sometimes basal growth hormone level also can be helpful, particularly if you are getting value more than 1 nanogram per ml. And here also, as already I have explained, these are the conditions which are associated with increased basal GH level, like puberty and pregnancy, the physiological conditions, and others are the states of growth hormone resistant. So basal GH levels are measured in the morning after fasting, unlike IGF-1, which can be measured at any time of the day. And usually basal serum GH level is more than 1. It can confirm the diagnosis of growth hormone excess. But because of wide fluctuation due to inherent episodic GH secretion from both the normal growth hormone secreting tissue in pituitary and also from adenoma. So basal GH level is less reliable compared to the nadir GH level, which is more reliable for confirmation of the diagnosis. So lack of suppression of growth hormone following 75 gram OGTT, the gold standard diagnostic for the confirmation of GH excess. And this is used in, to confirm the diagnosis in patients with elevated or equivocal IGF-1 level. The growth hormone nadir less than 1 after OGTT practically excludes the diagnosis of GH, but some people use 0.4, particularly if you are using highly sensitive growth hormone assay. But the commonly available assay is there, whatever is there in our country. For that, we can use 1 nanogram per ml for the diagnosis. So to conclude, the test for growth hormone excess, if the IGF-1 level is more than age and gender cutoff, and both the basal and the nadir GH level during OGTT is more than 1, then we can confirm the diagnosis of growth hormone excess. So similar to the basal GH level, these are the factors which can affect nadir growth hormone levels also. So we can get falsely high GH level. Before going to the discordant result between GH and IGF-1 level, I just want to highlight there are few patients whose GH level not only remains static or not able to suppress during OGTT, rather it will increase. So the definition for increase of growth hormone during OGTT, that is called paradoxical GH response, is defined as if there is 50% increase during the first 90 minutes of OGTT. And here left side you can appreciate is the classical acromegaly patients. So you can see there is no suppression of GH. But here there are few acromegaly patients which will respond paradoxical GH. Here you can see GH level instead of remain starting or not able to suppress, it goes up. So what is the importance of paradoxical GH response? It occurs about 1/3 of patients with growth hormone excess, and it is due to the ectopic secretion of GIP. It receptor in the somatotrope adenoma cells, and the peculiarity of these patients are they are harboring smaller adenoma tumors and displays higher IGF-1 concentration, and this is densely granulated tumors, and they have better response to somatostatin analogs. So from the GH response during OGTT, you can predict what type of tumor you are dealing with. So this is the last part of my talk, what to do when you are getting discordant results. Sometimes you can get normal IGF-1 level and elevated GH, and you can sometimes get the reverse also. So if you are getting normal IGF-1 level and the elevated GH, so first thing is the patient is having any growth hormone resistant states like uncontrolled diabetes and CKD or CLD, or malnutrition, or critical illness. And the second DD is if the patient is on oral estrogen, because oral estrogen though increases GH level, but it is simultaneously causes growth hormone resistance of the liver, so IGF-1 level may not increase. Second set of discordant result is normal GH but elevated IGF. So this is particularly seen in older patients, particularly male gender, and those who are having smaller microadenoma, smaller tumors in the pituitary. So if you are getting discordant results and you are not able to get the final message whether patient having growth hormone excess or not, these are the optional tests you may consider, but they are not widely available, are restricted to the research centers. This is 24-hour serum GH level or 24-hour mean urinary GH level, and measurement of IGF-BP3 level, or the measurement of GHRS level, particularly if you are suspecting ectopic GHRS secreting tumor, and the last is TRS stimulation test. But these are not required in the most of the cases because the IGF-1 measurement and the GH measurement during OGTT plus MRI pituitary are usually sufficient to make the diagnosis in most of the cases. So finally, the take-home message is serum IGF-1 level is used as a screening test to diagnose GH excess. The nadir serum GH level is used to confirm growth hormone excess, and the factors affecting both physiological and pathological which affect the both IGF-1 GH level should be kept in mind when you are getting the discordant of findings. Thank you for your kind attention.
Thank you, Dr. Sahu, for your you know crisp presentation about growth hormone access and dynamic testing. I would like to ask one question. I mean, I have a patient, who had a pituitary microadenoma with high, I mean, not very high IGF-1, but slightly high IGF-1 for his age. But his growth hormone level is within normal limit or around 1.2 or 1.5 microgram per liter. So you have mentioned about it, and what would be your approach, like, for that type of patient?
So already I have mentioned in the discounted results, particularly when patients are older and the male gender, and when they're harboring the smaller pituitary tumor, as you have explained, microadenoma, you can get higher IGF-1 level with normal GS. So these are smaller tumors, and these are easy, relatively easy to manage. And the patient is not having other hormone deficiency. The patient is not having the features of optic chiasma compression. So, and the patient is affording, you can try medical therapy like somatostatin analogs. If the patient is not affording for medical therapy, like any other pituitary tumor or the functioning pituitary tumors, whether it is micro or macroadenoma, we can go for transplantal surgery. This is basically not a different type of tumor. This is basically the acromegaly cases which we are detected in the relatively early stage, but it behaves like the classical acromegaly tumors.
Thank you. Thank you very much. Over to the next talk. Adeline?
Thank you, sir, for the illustrious presentation. We will move on to the second topic in the session on dynamic endocrine testing. So to have the second talk on glucocorticoid excess, we may now have Dr. Nayak, sir, Professor of Endocrinology from JIPMED, Puducherry. Over to you, sir.
What is that? Yeah. Yeah. Good afternoon, one and all, and I thank the organizing team for giving me this opportunity. And now I'm going to discuss about the endocrine testing in glucocorticoid excess. To start with, I discuss with a case who was presented recently to us with the increasing history of weight gain, primary infertility, and irregular cycle. The primary reason for referral to endocrine because of newly detected diabetes. She was initially seen in the infertility clinic, and they want to do the ovarian drilling. Before that, they want to have a glycemic control. That is the main reason of referral to this patient. And we have evaluated this patient. You can look at the investigation, which is most commonly we'll be discussing subsequently. That is basal cortisol, LDDST, midnight cortisol, 24-hour urinary cortisol, high dose dexamethasone test, and ACTS. These are the following tests I will be discussing subsequently, how to approach all this investigation. And this patient actually undergone the MRI scan and found to have a small adenoma, and he was operated and now in remission. If you look at the clinical part, symptom and sign in Cushing syndrome, and in the previous patient also, many of the symptoms are characteristically very, very common. If you look at like obesity, rounded face, and facial plethora, which is very typically seen in patient with a case of morbid obesity, diabetes. So as you know that these disorders are very common nowadays, these symptoms can overlap with the patient with constitutional obesity. Similarly, if you look at the next category of symptom, like patient of presence of menstrual irregularity, hirsutism, these kind of symptoms can be largely overlapped by the PCOS. So it is up to us to determine which patient we need to screen, because there will be a lot of overlap of the symptom between various other disorders. To know when you need to suspect a patient having glucocorticoid excess or not. For that, there is a certain discriminating feature has been described. Like if these symptoms or these features are there, patient probably likely to have Cushing is very likely than other symptoms. The common symptoms which are have a high discriminative value are presence of facial plethora, easy ability, proximal weakness, and reddish purple stria more than 1 centimeter. Similarly, in case of children with young adult, if young adult, particularly if they have other features along with hypertension, diabetes, vertebral osteoporosis, thinning of the skin, then likelihood of Cushing syndrome is very likely. And this category of patient usually should be screened for the Cushing. Similarly, in case of children, if there is an increasing weight gain, but there is associated with decreased velocity, in this setting, we need to screen this category, or most likely this patient will have Cushing syndrome. If you look at before screening them with biochemical hormonal testing, the most important thing is to going through the history. We should look at the signs and symptoms of Cushing syndrome and what is the current syndrome patient has, how long the symptoms are there, and how severely the symptoms are worsened over a period of time. And it is always essential to look older photograph that can help you identify whether there is change in the facial characteristic. Like this patient, you can see there is a significant change in the facial characteristic as compared to older photograph that can help you in the help you in identifying the patient that likely to have Cushing. So, with regard to the evaluation of the Cushing syndrome, we should know aware that the most common form of Cushing syndrome we see in practice is the exogenous Cushing. It has to be ideally to rule out before going for the other testing. To exclude the exogenous Cushing, basal cortisol, ideally it is gets suppressed. If you get a basal cortisol ATM, it is mostly suppressed. But sometimes you may find that mild elevation in the cortisol may be found. This can be happen particularly if the patient is already continued on medicine or forgot to stop this medication. Two important questions to be answered when you are evaluating this patient. Does this patient have glucocorticoid excess or not? Second, if so, what is the cause of the glucocorticoid excess? These are the following tests which has been described in the literature. This was based on the three principles. First principle is to assess the daily cortisol production that you can do by the 24-hour inert free cortisol. Whether there is loss of normal diurnal variation in the cortisol that you can do by the midnight cortisol or night salivary cortisol. Loss of the feedback inhibition to cortisol and HPA axis that you can assess by the overnight 1 milligram dexamethasone or low dose dexamethasone suppressed test. But if you look at the endocrine society guidelines, what is I have highlighted as a red color, particularly 24 unit cortisol, late night salivary cortisol, and low dose dexamethasone are most preferred tests as compared to other two tests. But looking at the test like urinary free cortisol, ideally this test should be done 2 to 3 times, and it should be advised the patient to have appropriate collection of the urine, and you should instruct the patient not to drink too much of water. If you're drinking too much of water, it is found that those patients, even the normal patient, they have increased urinary cortisol level if the water intake is more than 5 liters. The sample should be ideally refrigerated, and ideally should measure with the urinary creatinine to look for the adequacy of urinary collection. And positive is defined as, usually we say it is positive when it is more than above the normal, but ideally if it is 2 to 3 times above the normal, only it will have a diagnostic implication. And one more important thing is that you should remember that 8 to 5% of the Cushing syndrome, particularly mild Cushing syndrome, can have a very normal urinary free cortisol level. Similarly, late night salivary cortisol usually is not routine available everywhere. Only few centers have facility to do this late night salivary cortisol. It is a kind of free cortisol. It should be ideally taken between 11 p.m. to 1 a.m. in the night, and doing more than 2 tests ideally give more specificity than doing a single test, and it can be collected either by the passing rolling into a plastic tube or by the using cotton plate, that is salivate. Cutoffs are different, are used different on the different country, have different cutoffs are used. But in India, there is a study which is looking at the normative data on Indian patient with cortisol, salivary cortisol. They have found that in Indian patient, the nadir cortisol, salivary cortisol level is less than 0.25 microgram. But in Western country, they have used a cutoff of 0.19 microgram per DL. And it depends upon the type of assay you are using, because many of the time assay either mostly used by the ELISA, but if you are using a LCMS, that your value may be much lower. This is the way you need to advise the patient to collect the late night salivary cortisol. Actually, it should not have any contact with the the cotton swab when you are collecting the sample. And I should ask the patient to keep the swab in between the underneath the tongue and for 1 to 2 minutes till it get soak with the saliva. There are various precautions should be taken during this test when you are collecting night salivary cortisol. Midnight cortisol only it has to be done between 11 p.m. to 1 p.m. But problem is that patient need to be hospitalized 24 to 48 hours prior to doing this test for because many patients and you need to have a indwelling catheter, indwelling line to collect these samples. Ideally, most of the time patient will be awake. So practically we usually take a cutoff of 7.5 to p rather than using a sleeping cortisol level that is of more than 1.8 microgram per deciliter. 1 milligram dexamethasone test, which is advantage because you can do it in the OPD basis, and patient can take the 1 milligram dexamethasone at night around 11 p.m. and check for the serum cortisol. Usually more than 1.8 indicate that probably patient has Cushing, but this test has a low sensitivity as compared to other tests. Low dose dexamethasone test, where you can give the dexamethasone 0.5 milligram 6th hourly for a period of 2 days, and the minimum time gap between the last dose and the serum cortisol should be 2 to 6 hours, and the cutoffs are similar to that of low dose dexamethasone test. But many studies recommend doing the plasma dexamethasone, but it's a complementary test because most of the time these assays are not available in Indian setting because you need to do it through the LCMS to assess the adequacy of plasma dexamethasone, because there is a difference in the metabolism of dexamethasone in every individual. So that is the reason they suggest to do the dexamethasone, but it's not available in Indian setting. So when you find that this patient have Cushing, or you find that there is elevation of the cortisol level, then always question come whether you are really dealing with a patient with true Cushing or you are dealing with a pseudo Cushing. So certain causes of pseudo Cushing should keep in mind before doing the further investigation, like morbid obesity, depression, CKD, CLD, alcohol difference, poorly controlled diabetes. All this can mimic like a hypercortisolism. Even the biochemical level will be above the normal range, but you need to look carefully before going for the further investigation. And you should keep certain pitfall of screening test. Like there are many conditions you can get a false positive or false negative. Like all tests can be false negative if you have a cyclical Cushing, and urinary free cortisol can be elevated in case of pregnancy and pseudo Cushing. So these all things you should keep in mind. Similarly for dexamethasone also, there are various drugs which can increase the binding levels of the cortisol, so that also can give a false positive result. So you should keep in mind the various pitfall of this assay when you are screening this patient. Similarly for late salivary also, there are various other conditions where also you can have increase the late night salivary cortisol can be false positive, particularly incorrect collection, and there are various drugs which can inhibit the enzyme like 11 beta HSD, or if there is blood contamination. But this test is not very suitable for particularly the patient like those have nocturnal or shift worker, and this was test also they found that particularly patient with uncontrolled diabetes and hypertension, and those are age more than 60, they can have a mild elevation in the late night salivary cortisol. So which test should we prefer? You should have a very strong pre-test probability when you are screening for Cushing syndrome. Ideally, 2 out of 3 tests should be positive to indicate there is a glucocorticoid X. I have shown that which test you should ideally choose, like obesity, maybe midnight cortisol and salivary cortisol are much preferred, and like depression and midnight cortisol and salivary cortisol. In cyclical Cushing, salivary cortisol and 24 urinary cortisols are much preferred as compared to other tests. So you need to choose which test. If you look at the near guidelines, usually recommend even you can do a 1 test, but in practically we usually recommend at least 2 out of the 3 tests should be positive to say somebody has glucocorticoid excess, because there can be a discordance of the result also. Second line of investigation are usually helpful to distinguish between the Cushing and pseudo Cushing, but in practice usually you do LDDST, which is very helpful in differentiating between the Cushing and pseudo Cushing. Other tests are mostly in literature, and it's in a common practice. This CRH and all these things are not routinely available, so routinely not been practiced. So when you have find that somebody has a glucocorticoid excess, the ACTH level at morning maybe guides you whether you are dealing with an ACTH dependent Cushing or ACTH independent Cushing. You can take a cutoff of more than 20, depends upon what kind of assay you are using, because in many centers you may find that you might be using immunites where the ACTH levels may be high in patient, even with the patient with the adrenal Cushing. So that can guide you whether you are dealing with a pituitary or ectopic or adrenal Cushing. To know, if you have ACTH is elevated and you are suspecting you are dealing with a ACTH dependent Cushing, in that setting you need to do a high dose dexamethasone suppression test. Mostly people prefer to do a 8 milligram single overnight high dose dexamethasone test. But in others, some people prefer 2 milligram every 6th hourly, but 8 milligram single dose is much preferred than the using 2 milligram every 6th hourly. And interpretation is ideally, if the ATM cortisol is more than 50% suppression, it has a very good sensitivity and specificity. With regard to that, there is a study from SGPGI which we have looked at the suppression of ATM cortisol following the high dose dexamethasone. And this study found that high dose dexamethasone has a very poor accuracy as compared to diagnosis. And they found that if you look, because there may be some overlap between the cortisol suppression between the Cushing syndrome and ectopic, you can see that in case of microadenoma, only 44% has suppression of suppression on high dose dexamethasone and 76% in microadenoma. Even particularly benign ectopic Cushing syndrome, 50% has suppression. So you should take this test very carefully when you are doing a high dose dexamethasone suppression test. Later on, you may do imaging or IPSS imaging, because largely when you have suppressed ACTH, you're thinking of in the line of adenal cause, then ACTH adenal is before. But when you have ACTH dependent Cushing, because 60 to 70% of the tumors are because of ACTH dependent or pituitary origin, it is ideally most of the time we prefer to go for, but depends upon the clinical presentation. You can decide if your likelihood of you are dealing with ectopic Cushing, you can go ahead with the evaluation for ectopic Cushing. But if you have no obvious finding to delineate whether you are dealing with ectopic or pituitary Cushing, then you may first go ahead with the MRI of the imaging. And ideally 3 Tesla MRI as preferred. And if lesion is more than 6 meter, probably you are dealing with a Cushing disease. But if a lesion is less than 6 millimeter in size, but because in about 10% of patients can have a non-functioning pituitary lesion, that you should be very careful, and depends upon that you can decide whether you have to go for the other investigations. This practice of doing IPSS, CT abdomen, thorax and functional imagings are varied from center to center. So IPSS is predominantly do for the lateralization. It can help you differentiating between the peripheral or central cause, and once you have established whether that is peripheral or central, subsequently it can help you whether that is the right side or left side of the pituitary is involved. This primarily you should not do for the localization. It is primarily used as a lateralization. I have given these various cutoffs for diagnosis, how you need to approach the ACTH, IPSS. There is an entity known as cyclical Cushing, where you can have a 3 spontaneous peak and 2 troughs. Or recently they are telling even 2 spontaneous peak and 1 trough is enough for diagnosis of cyclical Cushing, because this cyclical phase can be irregular or it can be regular with variable cycle length. These tests are mostly preferred either 24-hour urinary cortisol or Saravalli cortisol. Recently some studies are come with looking at hair cortisol and morning urinary cortisol and creatine ratio. For morning urinary cortisol to creatine ratio, you need to have a standardization of this assay before doing this test. But in India, there is a study by Dr. Nitin, who has done the urinary cortisol and creatine ratio, and he has taken the cutoff of 12.7 as for diagnosis of Cushing. So another important cause that most number of the patients we see refer for the Cushing evaluation are adenal incidentaloma. They can have mild hypercortisolism because it can see it in about 5 to 30% of the cases. So different cutoffs are used. Here you will be looking at diagnosis. That's why you need to use a higher cutoff, that is 5 microgram, to say whether they have adenal, whether that is subclinical Cushing or not. This entity also recently known as a mild autonomous cortisol secretion. But in this patient, particularly urinary cortisol and low net light salivary are not very preferred test, because they can be low or it can be low. Mostly they will not be very suggestive of whether that is mild Cushing or not. Another important cause is factitious Cushing syndrome. Sometimes patient may be taking medicine and hiding that he might be taking hydrocortisone or prednisone, which can interfere with your assay, particularly when you are using a chemiluminescence. But this only can be differentiated by taking proper history, or you can do a LCMS where you can look for the cortisol and cortisone ratio that can guide you whether the patient has factitious Cushing syndrome. To conclude, I can say you need a high index of suspicion what kind of Cushing you are dealing with. Pre-test probability is very, very important, whether you are dealing with a Cushing or pseudo Cushing. You should follow the appropriate protocol and optimal sampling when you are doing. Otherwise, there will be a lot of overlap. You might be falsely getting low or high value. So avoid doing random cortisol, like random cortisol, random ACTH. That will not guide you in reaching anywhere. And once you have some test positive, you may need to refer this patient to for rather than doing multiple tests by yourself and try to interpret, better to avoid to the endocrinologist to further testing. Thank you for patiently.
Thank you, sir, for a very clear and crisp presentation. I think in the interest of time, we will go ahead with the third talk for the session, and then we will take up the questions at the end.
Okay, thank you.
Thank you. The next talk is going to be about endogenous excess insulin secretion. Time and again, you get a referral from a GP or from somebody saying that the patient has fainted and had a blood sugar of 60 or 70. And you need further investigation or evaluation to say that there is endogenous insulin, excess insulin secretion. So this topic is going to be taken by Dr. Maya Prasad, who's an endocrinologist and obesity specialist in Prana Medical Center, Chennai. And he's going to highlight on the topic now. Over to Maya.
Next slide.
Yeah, it's visible, sir.
Yeah, thank you, Endocrine Society, for this opportunity. Basically, this I just want to run through about a scenario which I seen a couple of times, where patient.
Can you please put in a slide, sir?
Right.
Yeah, perfect.
Sorry.
Perfect, sir. Now it's perfect.
Okay, thank you. So yeah, we do see we do come across now and then where the patients present with very low sugars to the accident emergency. It is, I mean, they sometimes present with fits, and it leads it leads us to a lot of confusion whether it's a neurological problem. And once they get to see the, and most of us are flued in now to do a, capillary blood glucose level once we come in. So then, I mean, we do come across hypoglycemia, and then the questioning starts: what is the cause for this? Whether it is endogenous or is it a fictitious hypoglycemia? Right. So basically then the questioning starts: why the hypoglycemia? Whether it is especially whether it is related to diabetes or some other problems which is causing hypoglycemia. So if the patient is not known to have diabetes, then it becomes whether it is because of medication excess, or whether the less food intake, or whether it is fictitious. So those sort of line of thinking happens. And if that's not the case, then we need to look into whether it is because of some other reasons. So that's when we look at whether the insulin production is too much, and we start doing tests. So what is the so why does this happen? Why does the excess insulin happen? Is the body producing too much of insulin because of insensitivity, or is it because of beta cells increase production increase in the beta cells? So what are the common causes? What are the causes for insulin excess? So the most common cause is insulin resistance, which we see quite often with obesity increasing, and obesity increasing, and the high levels of diabetes. or whether it is because of something wrong with the pancreas itself. So it is the most common cause of the pancreatic insulin excess is insulinoma, as we though it is not common, that's something we need to think about. The next is the blastosis, which is a very rare condition where the number of cells producing insulin and also the and the number of and the size of the cells producing also increases. It's very rare, but still does happen. And we do see that in patients who've had bariatric surgery. Though it is rare, that's something we think about as well. So that is endogenous. So if it is produced being if the high insulin levels are coming from the pancreatic cells, then that is endogenous hyperinsulinemia. And how do we find out whether it's exogenous or endogenous? And if you look at the so what is endogenous? I mean, the endogenous hyperinsulinemia, as I mentioned, is excess hormone being produced by the beta cells in the pancreas. So when do we call that the hormone level, the insulin level is excess? If the insulin level is higher than 2 micrograms per ml, in the and correspond in a situation of very low sugars, it's like glucose concentration less than 60 milligrams per deciliters. That's when we call it as hyperinsulinemia. We do come across situations where there is a relative hypoglycemia, where the patient gets symptoms of hypoglycemia. I have a couple of patients like this where their sugars have been running at around 200, 220, 300. And when we bring down the levels to around 120, 130, they start getting the symptoms. So that sort of relative hyperglycemia is also hypoglycemia is also we do come across as well very rarely. So that's something we need to bear in mind. So that is one aspect, that the glucose level has to be less than 60 and the insulin level is more than 2 micro unit per ml. And the high insulin level present in addition to that, suppressed beta hydroxybutyrate less than 1 micron in conjunction with the low level of free fatty acids, and all these things indicate hyperinsulinemia. So it's not like the insulin levels alone, but also a conjunction of all these three should be there. Low levels of insulin-like growth factor binding protein. My colleague is talking about may also be useful because insulin suppresses IGF binding protein 1, which is normally elevated in the fasting or fasting hypoglycemic or the hypoglycemic child. So if it is high, then that is another cause of true hypoglycemia. And so we were discussing about exogenous hypoglycemia or surreptitious hypoglycemia. As we all know, insulin is produced along with the C-peptide, which is a part of the insulin molecule, the cleaved end of the insulin. So insulin levels and the C-peptide levels are similar when they are produced. So if it is if there is discordance where the insulin levels are high with the low C-peptide levels, then we need to think about whether it has been injected whether it has been an extraneous injection of insulin. Because the purified insulins which are produced is they're free of C-peptide. So if it is that the sugars are, if the insulin levels are high with low C-peptide levels, then it is possibly insulin-induced hypoglycemia from outside. Similarly, if the sulfonyl areas are given, they induce insulin production, and at the same time, C-peptide levels are also high. So that's how we can differentiate high hypoglycemia related to OHAs or insulin injected from outside. So that is a sort of a test which can be used to differentiate what type of hyperinsulinemia it is. So that's why when they come and present with hypoglycemia, as drug screen for sulfonylureas or insulin secreting oral hypoglycemia should be done. So how do we diagnose? As I said, it's a prolonged fast, which associated with high insulin levels is diagnostic. We usually do a 6-hour fasting test or an extended fast, which can be up to 72 hours of fasting, which produces hypoglycemia associated with high insulin levels. So the other dynamic tests, first surgery, we have discussed hypoglycemia with sugars less than 60 at any age associated with excess amount of insulin is diagnostic. Glycemic response. When we correct the insulin, when we correct hypoglycemia using glucagon in children, hypoglycemia glycemic response is observed in children, but is abnormal in endogenous hypoglycemia. And leucine stimulates the secretion of insulin, and leucine insensitivity to hypoglycemia is it used to be diagnostic, but no longer used, and is used only in the research setting. So what are the other ways of diagnosing? There is there are other radiological tests, and also the histopathological tests showing cells producing the insulin. Shows pancreatic cells with the increased number. What are the other ways of diagnosing hypoglycemia insulinomas? There are radiological imaging tests, which is pancreatic ultrasound or CT scan, MRI, which are then can be used, however not very useful. The most specific tests are pancreatic angiography, and pancreatic venous sampling, which have been very successfully used in some cases and are quite specific. And also spiral CT scanning is useful for islet cell adenoma in adults. So this is a picture of the CT scan showing insulinoma. Because the insulinomas are significantly higher capillaries, they do take up the contrast quite significantly, as we see in this CT scan. They are more visible in this CT scan. And the other specific test is ultrasound guided, endoscopic endoscopic guided ultrasonogram, which shows very, very specific and high sensitivity, which picks up the insulinomas quite commonly. So if you look at this, that's the ultrasound probe, and this is the pancreatic adenoma. It is done in yes, and Hyderabad.
Sir, sorry to in view of interest of time, can you finish it a little faster, sir?
Sure. Okay.
I think we are going over time now.
So these are the radiological modalities which can be used for diagnosing insulinomas. That is one endoscopic ultrasound, and these are angiograms which show the angiogram which can show pick up the insulinoma quite specifically. And there is also another aspect of genetic testing. There are some genes specifically which can be done, which show the reason we do that is to see whether to treat how to treat and whether they'll be responsive for diazoxide. So there are some genes which if they are shown, they are more responsive to diazoxide. The other ones they don't respond that well. And so in summary, that's how we look at the treatment aspect of insulinomas, either surgical or if it is resectable, then it's surgical treatment is the best mode of treatment. If it's not resectable, then there are different modalities, and also medical management using diazoxide might be considered. Thank you.
Thank you, Mahar, for your excellent presentation on insulinoma. There are other things as well, like, most of them are like reactive hypoglycemia, where there is insulin secretion, where you need to do an extended GTT with insulin levels as well. And also, I've come across a patient who was having hypoglycemia after starting on, thionamide like carbimazole for hyperthyroidism, which induced insulin antibodies, which acts as insulin and thereby causing severe hypoglycemia. So there are some other things like this as well, which causes hypoglycemia. But insulinoma is the one which we need to rule out in patients who are having spontaneous hypoglycemia presented with high insulin level.
Sure. I mean, there's a specific entity called insulin antibody hypoglycemia. So that it is very well documented, and as you said, it's quite common. Not common, it's well documented.
There is a question from Kasi Raman, Dr. Kasi Raman, saying, is there any other method to overcome insulin resistance other than one exercise, diet, or metformin?
And pioglitazone helps, but I think those are the easiest and easiest method, weight loss, and there are some other medications, but they're not very significant. Pioglitazone helps, and metformin does certainly help.
Definitely, yes. And
there are two more questions. I think you can answer it in the chat box, sir. I think because of interest of time, we should wind up this session. Oh, Dr. Srinivasan, sir?
Yeah, please opine on conditions where there is a discordance between glucometer and plasma glucose readings. Yes, there are difference. There is usually a difference of about 10% between the glucometer reading and a plasma glucose reading. And if it is more than that, probably that you have to go for the plasma glucose reading rather than a glucometer reading, which is more accurate. Because the whole...
You can try the other different glucometers as well. And also in renal disease, there is more there's more difference in some people. At that time, again, some glucometers adapt for that.
And the other question is, will C-peptide give the amount of endogenous insulin levels?
Yeah, that exactly. I mean, the same amount of insulin produced will be, the insulin will be equivalent to the C-peptide. So if there is discordance, that's when the problem comes, whether it is spurious hyperglycemia or injected from outside.
Thank you. That is all the questions. Thank you, Meher, for your presentation. And over to organizers for the closing remarks and closing of the Enrich program for today.
Thank you, chairpersons. Thank you so much. May I now request Dr. Thomas Paul, President of ESTN, Dr. Muthukumaran, Secretary of ESTN, and Dr. Vijay Bhaskar Reddy to the stage. I think it's time to thank everyone. We have come to the end of a wonderful academic session. On behalf of ESTN, we would like to thank all the faculties, speakers, chairpersons for readily accepting our invitation and to be a part of this program. And thanks to all delegates who connected with us virtually, because the success of meeting is mainly because of the delegate participation and interaction. And special thanks to the audiovisual team, our virtual partners, Imagica, our staff at Lee Pondy, and the staff involved in the secretarial work in both Dr. Muthukumaran's and in our office. And very special thanks to Dr. Sundaraman and Dr. Murthy and the senior endocrine professors who have really guided us. And thanks to Mr. Andrew for coordinating the other hospitality works. And I'm sorry if I have missed someone. And thank you so much. And we would like to invite everyone for Trendo 2022, which is to be held most probably as of today would be on a hybrid, which is organized by the Madurai team of ESTN, and which would be on last Sunday of June 2022. And thank you so much. Let's all stand for national. Thank you so much.